అప్పుడు తీస్తా అంటే వద్దన్నాడు వాళ్ళు నేను విషయాలు మాట్లాడి పెడతారు చాయ్ పెడతారు. యాత్రగా ఇచ్చారా తయారు చేసారా? ఆ లోపల సెట్ చేయనిస్తున్నాడు.
A very good morning to one and all. I am Dr. Nandita, Rheumatology Assistant Professor from Nizam's Institute of Medical Sciences. On behalf of the Department of Rheumatology at Nizam's Institute of Medical Sciences and the Department of Obstetrics at Fernandez Foundation, I warmly welcome you all to the third edition of the MOD CME, that is the Medical Obstetric Interface in Rheumatic Diseases 2026. This academic platform was conceived with a simple yet powerful vision, that is to bridge two specialities that together determine the outcomes of some of the most complex pregnancies in medicine, that is rheumatology and obstetrics. Autoimmune rheumatic diseases often affect women in their reproductive years. This journey from preconception counseling to pregnancy, delivery, and postpartum care requires a seamless collaboration between specialties. Through today's discussions, case-based learning, and interactive sessions, we hope to strengthen this collaboration and translate evidence into better maternal and fetal outcomes. I would now want to call Dr. Lisa Rajshekar, Head of the Department, Clinical Immunology and Rheumatology, and Dean of Nizam's Institute of Medical Sciences, to deliver the opening comments and set the tone for today's academic session.
Good morning, everybody, and a very warm welcome to all of you. It's good to see so many people here right in the morning on Sunday. But I know from talking to Dr. Tara in the last few minutes that this is not something new for you, that you're doing it throughout the year. So it truly a salute to the commitment of all of us, including Dr. Shantvir, who's here on a Sunday morning. The program today has been very, very thoughtfully curated with a lot of dialogue which has gone between the two specialities. And supporting this scientific program is very distinguished faculty, both as speakers and as chairpersons with their expertise, who bring to each of these sessions, I think will be very, very good as we go forward. The content has also been formulated in such a way that the real life challenges which we experience, initially we used to think of the challenge of handling the pregnancy in a patient with rheumatic disease, and now it is more expanded to reproductive health in a patient with rheumatic disease. And the model in our clinic at least has changed from, okay, when this patient hints to me that she's going to get married, then I'm going to start talking to her about the difficult things of how to handle contraception, how to handle a pregnancy, and then the risks to the child. From this model, we have now that every young woman who's diagnosed with a severe systemic rheumatic disease, we need to open up this conversational space. And over the years, we have created time, space, and resources to have these conversations, and you will hear about this development throughout the day. We have a formal inauguration later in the day, so without waiting much time, I will hand over this mic to the organizing team to let the program run. Thank you.
Thank you, ma'am. We now move into the first the scientific program of the day, which focuses on the clinical challenges and obstetric care of patients with rheumatic diseases. So our first talk addresses one of the most critical steps in managing patients, that is the preconceptional risk assessment. May I please invite Dr. Tarakeshwari S. ma'am, who's the head of obstetric medicine at the Fernandez Foundation, and Dr. U.R.K. Rao sir, who's a senior consultant rheumatologist, to please chair the session. I would also like the chairpersons to please introduce the speakers.
Thank you, ma'am. Thank you for the kind introduction. Good morning, everyone. At the outset, I would like to thank Dr. Lisa ma'am, Dr. Madhuri, and the entire team of Department of Rheumatology and Clinical Immunology at Nims for giving me this opportunity. It's always a great pleasure to be back at your alma mater to start off a CME. So, the talk that was given to me today is preconceptional counseling in autoimmune rheumatic diseases. So, we'll be starting with why exactly autoimmune rheumatic diseases preconceptional counseling becomes so important. So we all know that pregnancy in autoimmune rheumatic diseases has its own unique challenges. There are conditions which could result in IUGR, preterm births. There could be conditions which could result in preeclampsia to the mother, or there could be several other complications that could happen in patients with autoimmune rheumatic diseases, including a disease flare. So there's definitely a higher risk, especially when it is unplanned. So it becomes very, very important to minimize these risks, for which preconceptional counseling becomes a very important factor. A planned pregnancy, it is proven beyond doubt that a planned pregnancy would result in better outcomes in individuals with rheumatic diseases. So the objectives of today's topic would be, basically we would be discussing on what are the goals of preconceptional care, what are the key components, how do we assess them, after assessing how do we risk stratify them, and for certain specific autoimmune diseases, what are the considerations, different specific considerations that we need to take into account. So my talk is primarily based on the guidelines that have come up for autoimmune rheumatic disease management during pregnancy, in the preconceptional period and also in the postpartum period. So the goals of care in any patient who is planning a pregnancy would be, number one, to optimize the maternal health. So getting the disease under control, optimizing their health to plan a healthy pregnancy is the most important thing. Then would be ensuring fetal safety by optimizing the mother's medications and also considering adequate monitoring or optimal monitoring during pregnancy to have good outcomes. Third would be adjusting the medications of the mother so that there are no harms done to the fetus. And definitely the most important part would be shared information with the mother so that informed decisions can be taken. So when should we start preconceptional counseling? Though I have put here as soon as pregnancy is considered, but it should actually be from the first visit of any woman in her reproductive age group when she comes to us. Preconceptional counseling is important. They should understand when they can plan a pregnancy, if they want to plan. If they are not planning a pregnancy, what kind of measures they should take, what contraceptive measures have to be practiced, all have to be discussed right from the beginning. So the key components would be assessing the disease activity, the fertility status, the medications, vaccination, lifestyle modifications that need to be done, any genetic counseling that is needed, and also looking at the mental health and emotional readiness of the mother to plan a pregnancy. So when it comes to disease activity, the general standard is that for most autoimmune rheumatic diseases, the disease should be in remission for at least more than or equal to 6 months before planning a pregnancy. However, in select cases, especially in cases where the risk is not very high, even a 3 to 4 month period is considered sufficient, though this is not what has actually been adopted by the guidelines yet, but this is an acceptable time duration. If a pregnancy is planned when there is active disease, the outcomes would be poor. Both maternal and fetal outcomes would be poor. The second thing that we need to assess is the fertility status of the mother, because most patients with autoimmune rheumatic diseases, in the process of getting their disease under control itself, age could become a factor for them which could decrease their fertility. So once they are more than 35 years of age, you should know when to refer to a fertility specialist to these individuals. That is one thing. Second thing is individuals who receive gonadotoxic therapies like cyclophosphamide. Either when we are giving cyclophosphamide, we try and preserve their fertility by giving GnRH agonists, or if they have already received cyclophosphamide, assessing their ovarian reserve becomes very important. And if we feel that the fertility status of the mother may not be very good, it is always better to involve a fertility specialist right in the beginning itself. Then coming to medications, Medications, certain medications cannot be continued during pregnancy, especially teratogenic drugs like methotrexate, mycophenolate. And we always need to switch to safer drugs like tacrolimus, azathioprine, sulfasalazine for women with autoimmune rheumatic diseases who are planning a pregnancy. And for certain conditions, hydroxychloroquine becomes a must. And low dose aspirin, if when indicated, for example, in individuals with lupus nephritis or in individuals with antiphospholipid antibodies, need to be started in the preconceptional period only. Now, coming to vaccinations, as per the national guidelines, the vaccinations could vary for the mother. However, as a general rule, most of the live vaccines, like zoster vaccine, though now we are using a recombinant vaccine, or the rubella vaccine, all these have to be given pre-conception. Inactivated vaccines are usually safe, and the vaccination schedule should be individualized as per the schedule of that particular nation. When it comes to lifestyle modification, weight control, stopping abuse of smoking, alcohol, regular exercises, keeping their bone health and muscle health adequate enough for planning a pregnancy, folic acid supplementation at least 1 to 3 months before onset of pregnancy. These are important as far as lifestyle modification and certain preventive medications are concerned. So when it comes to genetic counseling, the first doubt that most women who are planning a pregnancy in autoimmune rheumatic disease have is, I have this condition, there is a possibility of genetic factor, will my child develop it or not? Though most autoimmune rheumatic diseases are polygenic and multifactorial, and the absolute risk of transmission is actually modest, this has to be driven into the patient's mind and even into their family, because this is one fear that actually abates them sometimes from planning a conception in itself. And but in certain conditions like familial Mediterranean fever, complement deficiencies, monogenic lupus, where the inheritance actually follows a Mendelian pattern, a thorough assessment may sometimes be required. Both partners' family histories must be taken into consideration. Attention has to be paid to the consanguinity of their marriage, previous recurrent pregnancy losses which are not explained by the primary rheumatic condition, congenital anomalies, or any known inherited disorders. And whenever there is a risk of a hereditary syndrome, whenever there is a suspicion of a hereditary syndrome, or when the inheritance risk is unclear, it is always better to involve a specialist from medical genetics department. So this leads us to a plan that it is not a single specialty which can handle a woman of autoimmune rheumatic with autoimmune rheumatic disease planning a pregnancy. So not just the rheumatologist, but even the obstetrician, the fertility specialist, nephrologist if there's nephritis, cardiologist if there's LV dysfunction or pulmonary arterial hypertension, pulmonologist if there is an interstitial lung disease, a nurse or a midwife who could actually counsel the patient, a mental health specialist, all these individuals also become very important in the preconceptional counseling of these individuals. So the core concept basically is plan pregnancy when the individual is in remission, at least for remission or low disease activity for greater than or equal to 6 months, on stable medications which are safe for pregnancy with multidisciplinary care. So what do we assess at a preconceptional visit? Basically, we look at their medical history, obstetric history, the comorbidities that they have, and their physical examination. So in medical history, we look at how active the disease is currently by asking for different symptoms regarding the disease. As far as rheumatoid arthritis is concerned, it would be their joint assessment. For lupus, it would be other organ involvement that they could have. Then obstetric history, as far as how their previous pregnancies have been. Did they have any history of preeclampsia? Have there been any recurrent abortions? What was the baby status after birth? All these have to be taken into account. And other comorbidities like if they have diabetes, hypertension, LV dysfunction, these all also have to be taken into account. And a physical examination, a thorough physical examination to find out the activity status of the disease would definitely be required when at a preconceptional visit when pregnancy is first being planned. Then along with this, the laboratory investigations that we usually do, like the routine labs that we do, antiphospholipid antibodies, the criteria antibodies that we routinely check for, anti-Rho and anti-LAM, disease markers like anti-dsDNA by ELISA, complement levels for individuals with lupus, and assessment of organ function, like assessment of like beyond the routines like blood counts, creatinine, and liver functions, we we may have to do in certain individuals echocardiography. We may have to look at their pulmonary function test to look at the status of their particular organ if they have any involvement like interstitial lung disease or LV dysfunction. So there are certain contraindications for planning a pregnancy in individuals with rheumatic diseases, of which some of them become absolute contraindications. For example, PAH in itself is a contraindication, but when there's severe PAH, definitely it becomes a contraindication. Heart failure when the LVF drops to less than 30% is an absolute contraindication. Active lupus nephritis is an absolute contraindication, but sometimes when the individual develops lupus nephritis during pregnancy, sometimes we try and manage them with medications without considering termination of a pregnancy. End-stage renal disease with GFRs as low as less than 15 ml per minute per meter square, severe ILD with FECs less than 50% also become absolute contraindications for pregnancy. Previous severe eclampsias or HELP syndrome becomes an absolute, becomes a relative contraindication for planning pregnancy in the future. So based on these different based on the information that we have, we could risk stratify the risk stratify individuals with autoimmune rheumatic diseases into those with low risk, moderate risk and high risk. So individuals who have low risk like an uncomplicated rheumatoid arthritis or spondyloarthritis or an uncomplicated lupus with no major organ involvement, only minor organ manifestations with no antiphospholipid antibodies, anti-Ro, then those individuals would be considered as low risk and they could actually be handled at their local level with an obstetrician over there and the rheumatologist being in coordination with them. But in certain individuals, when there's moderate risk or high risk, the care has to be shifted to tertiary care centers, where a multidisciplinary team involving is getting involved into the management is very important. Then we move on to disease-specific complications that could happen. So in lupus, we know that in individuals with lupus, when the disease is uncontrolled or when they have especially associated antiphospholipid antibodies, they could have increased risk of preeclampsia, IUGR, preterm birth, PROM. In individuals who have anti-Ro, anti-La antibodies, the risk of neonatal lupus in the first pregnancy would be somewhere around 5% with a 2% risk of complete heart block. In further pregnancies, the risk could increase to as high as 25% for neonatal lupus and the risk of complete heart block could be somewhere around 5% also. In antiphospholipid antibody syndrome, the recurrent miscarriages would necessitate starting aspirin plus low molecular weight heparin either as prophylaxis or sometimes as treatment dose if they have had previous thrombotic episodes. In rheumatoid arthritis, 50% of the women with rheumatoid arthritis usually go into a state of remission or low disease activity during pregnancy, but there could be 25% of individuals who could have flares and 25% of individuals who could still have a stable disease. Postpartum flares are common in rheumatoid arthritis, so that should be a part of your preconceptional counseling. In individuals with systemic sclerosis, Raynaud's could improve, gastroesophageal reflux could worsen, but what is more important is assessing the PAH status because PAH in itself, severe PAH in itself carries a 20 to 50% maternal mortality rates. So depending on the disease, the preconceptional counseling could actually change. So the basic rule would be consider planning a pregnancy only when the individual is in remission or low disease activity. Make sure if there is such a plan, we have to review the medications early. Multidisciplinary care becomes very important, but the most important among all of this is educating the patient and their family too. Thank you.
Thank you. Discussion will take it in the end.
Thank you.
May I invite Dr. Subhashini, DLB OBGYN, Fellowship in Obstetrics Medicine. She is a consultant obstetrician and head of academics in Fernandez Hospital, Hyderabad. The areas of interest are medical disorders, complicated pregnancy, low birth weight management, electronic fetal monitoring, and perinatal mental health. So now she is speaking on as an extension of the previous talk, pre-conceptual counseling obstetrician's perspective. Dr. One, please.
Very good morning to one and all. I'm Dr. Subhashni. I think Dr. Kirti has made my job really easy, because you would find that most of the slides would be a reiteration of the points which we commonly encompass and formulate as we go through the preconceptional counseling. So for women who live with various autoimmune disorders, usually joyful experience of planning for a family may raise a number of queries, uncertainties, challenges and negative thoughts. Some extend further beyond than their ability to conceive, to include queries regarding the heritability of the disease, ability to maintain a successful pregnancy, effect on the fetus, outcome of the pregnancy, as well as risks of the medication on their baby. So there is a clear need for specialized support, as psychological factors can play an important role and may include a sense of guilt, stigmatization and loneliness, self-concern, not just about their physical and functional ability to become a mom, and whether they will be able to look after their children and family as well as care for themselves. And that's when we as a team step in for pre-pregnancy counseling. In the next few minutes, we will be taking you through these components of the pre-pregnancy counseling. The prevalence of rheumatological disease has seen a 4 to 8-fold increase in the recent years, and this has been seen to affect predominantly the women of childbearing age. The problems which an unplanned pregnancy carries is the use of a potentially teratogenic drug, or with a fear, the discontinuation of an indicated drug, limited knowledge about the drug teratogenicity, phytotoxicity, and the risk of conceiving in a flare. So the points which we consider in pre-pregnancy counseling is evaluation of the general health of the mother, comorbidities, their update, the drugs she is on, optimization of the disease activity, the effect of pregnancy on disease and vice versa, and talking about contraception. So in evaluation, whenever a woman comes to this clinical examination, there is no substitute for it. We check her BMI, we measure her vitals, we look for signs and symptoms of flare, we do a gynecological examination, we take a pap smear. In the investigations, we write for a hemogram, for a urine microscopy, liver function test, renal function test. We look into the viral markers, rubella vaccination status. As a part of organ evaluation, we do ultrasound. We look into the other antibody status like secondary APLA. And for organ evaluation, if required so, we order for a 2D echo or a pulmonary function test. Moving on to drugs. Definitely there is a need of adjustment of dose in relation to pregnancy. Potential risk of drug therapy for the fetus should be weighed against maternal disease. The choice of treatment should be a shared decision between the patient and the clinical care provider. And if the woman is on safe drugs, breastfeeding should always be encouraged. So recent EULAR guidelines have stratified all the drugs as green, yellow and red. So green are the drugs which are compatible with both pregnancy and lactation. The common of drugs would be steroids, hydroxychloroquine and azathioprine or sulfasalazine. The light green shade are the drugs which may be used for effectively controlling the maternal disease. The yellow shade drugs are used to treat the severe refractory medical disease, and the red are definitely non-compatible. Mycophenolate, MMF, methotrexate are some of those which need to be stopped much prior to at least 6 months before she even plans pregnancy. The third important step is definitely for all of us is the disease activity assessment. It helps us to aim for remission and standardize the medical disease and aim for low activity for more than 6 months before we give her a green to plan pregnancy. It involves evaluation of organ involvement, identifying whether she is having any contraindication to pregnancy, and in certain diseases like rheumatoid arthritis, functional assessment and mobility of joints also come under it. So we share a case which is currently following up with us. She is a mother KB who is 26-year-old. ADF, and 12 days later she developed fever with chills, pain abdomen, non-bilious, non-projectile vomiting and severe headache. So she was admitted at local place, evaluated, she was seen by a neurophysician and an MRI brain was ordered. The MRI brain showed right cerebral subdural hemorrhage and subarachnoid hemorrhage. Also there were low platelets, so she received blood and blood products. But despite all this treatment, in view of persistent low platelet count, she was referred to Hyderabad. She also gave a history of petechial rash for 2 months, history of menorrhagia, joint pains and stiffness. So in the tertiary referral center where she was admitted, her investigative panel showed low hemoglobin, platelet count of around 30,000. Her liver function test creatinine was normal. Her antibodies panel showed ANA2 plus and SSA rho positive, and APLA was found to be negative. As a part of further evaluation of a thrombocytopenia, a bone marrow aspiration was done which showed peripheral bicytopenia, ferritin levels of 15.6, DCT was 2 plus. Organ evaluation showed 2D echo was normal. Because she had a brain hemorrhage, CT cerebral angio was done which was found to be normal. So she was diagnosed with lupus with musculoskeletal features and right subdural hemorrhage and arachnoid hemorrhage in April 2023. Started on methylprednisolone and MMF, and gradually her condition improved, her platelet improved to 1 lakh, and she was discharged home on these drugs. She did well for a few months, but she discontinued after few months because she developed side reactions of severe gastritis and acne. 6 months later, she presented back with symptoms of EC fatigability, severe joint pains, skin rash, bleeding gums and alopecia. She was re-evaluated. Her platelet fell down back to 28,000. A CT brain was done because of her easy bruisability, which was found to be normal. APLA was repeated, which was found to be normal. And PT-INR C3, C4 levels were done. She was restarted on the drugs of methylprednisolone, Visalon, MMF, HCQ, and for pain relief was given naproxen. She slowly stabilized on them, and she was counseled for strict follow-up and not to stop the medications. She came back after 6 months, that is 1 year from her previous first incident wherein she had, and the couple came down anxious to conceive. So because they were anxious to conceive, the immunomodulators were changed to Azeron, and rest of the drugs being compatible with pregnancy planning were continued. She also continued of painful dysphagia and irritation, so upper GI endoscopy was done which showed esophageal candidiasis and duodenitis. Rest of the investigations were stable. Her chronic anemia was evaluated with iron studies, and HPLC showed normal study. So she was advised as a part of counseling, because she was SLE, the effect which the SLE has on pregnancy and vice versa. She was counseled that the hypertension, thromboembolic disease and preeclampsia can reoccur in her. She was counseled that she stands at higher fetal complications of miscarriage, fetal growth restriction, preterm delivery, low birth weight, and because she was ROLA positive, she stands at a higher risk of neonatal lupus and congenital heart block and needs follow-up with PR intervals. Similarly, she also told that pregnancy would be an uphill task for her because she stands at a risk of pregnancy itself may induce flare for almost 65%. She may slip down back to lupus nephritis. She may slip down back to bicytopenia and may have MODS. She was strictly told to go slow and to avoid pregnancy if she had pulmonary hypertension or any lung disorders and heart failure. If it is also told that if there is a history of lupus flare within the past 6 months, the pregnancy has to be avoided, and with history of active lupus nephritis or stroke, the pregnancy is supposed to be avoided. Adverse outcomes are seen moreover in these mothers if they conceive with hypocomplementemia, if there are presence of dsDNA antibodies, presence of anti-ROLA antibodies, if they have active lupus nephritis, hypertension, hypoalbuminemia. So these are all the negative predictors wherein which help us to counsel for the upcoming adverse outcomes to the couple. So she took a break of almost 1 year from stopping of MMF and came back to be UPT positive. She booked with us, a viability scan has been done which has confirmed her dating, and all her investigations are pretty stable. Her anemia is corrected, which is 12.6, and her platelet count is 1.68. She has no proteinuria. Her creatinine, liver function tests are normal. C3, C4 levels, dsDNA was redone, which was normal. She was started on heparin prophylaxis and ecosprin, and as she was ROLA positive, she has been monitored with the PR interval. A fetal echo was done at 21 weeks, which was normal, and now she is continuing at 28th week of her pregnancy, and the growth at 27 weeks was an average for gestational age baby. So in pregnancy, there are certain disease activity index which has come up in the literature, and these are the features which are considered for monitoring the disease activity during pregnancy. The lupus activity index pregnancy is the one which is validated, and the final score of less than 2.6 indicates that she is in remission. Lupus flare is very notorious because its constitutional symptoms are very similar to that of normal symptoms of pregnancy. So laboratory changes, decreased complementary levels, increase in the levels of dsDNA, Coombs positive hemolytic anemia, leukopenia, or urinary cellular cast help us differentiate from the signs and symptoms or features of preeclampsia in pregnancy. We will now touch base upon the other common rheumatic disorders and the counseling points. Sjogren's, it has been seen that it presents with an increased rate of miscarriage and fetal loss as much as SLE. It presents with a spectrum of symptoms of dryness of mucosal surface almost up to the organ involvement of interstitial nephritis and lung disease. HCQ, azathioprine and low-dose aspirin are the drugs which are given for these mothers, and it is very important to assess the presence of Arola antibodies also in these Sjogren's. Mixed connective disorders, these are relatively rare. There is no specific clear-cut disease activity measurement indices at present. These present with non-inflammatory overlap symptoms, vasculopathy such as Raynaud's phenomenon. It is important to counsel these mothers that they stand at a risk of 47% of flare during pregnancy. So the baseline investigations, which are the common, which is done for all rheumatological investigations, along with that, it is important to measure the anti-ribonucleoprotein RNP levels in such mothers. It is important in mixed connective disorders to keep vigilance for the development of hypertension and deterioration of renal function in pregnancy. Rheumatoid arthritis, pregnancy is a honeymoon period, but there is an increased risk of flare in the first 3 months post-delivery, almost up to 9 months. Ensure that the mother continues her folic acid and ecosprin and vitamin D supplementation. Lot of disease modulating agents can now be safely used in pregnancy, which could be like azathioprine, sulfasalazine. Make sure that you continue folic acid throughout the pregnancy, and disease activity score 28 CRP less than 2.6 indicates remission. Spondyloarthritis are rarer kind of diseases, and these also show a tendency of having higher disease activity typically during the second trimester and mitigation of symptoms in the third trimester. In women with psoriasis, they encounter new onset psoriasis and additional flares up to 45% during pregnancy, and postpartum up to 65%. Antiphospholipid antibody syndrome, we have some spectacular talks lined up throughout the day. So one caution line is to verify the diagnosis. We will learn more in the subsequent talks. So once you have finished with the disease activity, it is very important that you document and plan her antenatal period once she comes. As obstetricians, we usually see her monthly till her TIFA is over, that is 20 weeks of pregnancy, and then once in 3 weeks depending upon her disease activity and her clinical condition, and we see her once in 15 days from 8th month, that is 32 weeks. Similarly, it is important to refer to a rheumatology clinic and make sure that she attends the rheumatology clinic without fail. Depending upon the disease activity, it is also seen that they see them once in 4 months, once in 4 weeks, and then closer visits. As much as you counsel what to do in pregnancy, if she is in a flare, it is very important and the responsibility of we as obstetricians to provide contraception device so that she doesn't conceive in a flare. The most common contraception which is used in such disorders is the progesterone-only pills. Desogestrel pills are readily available across the counter. Noriday 350 microgram per day can be given. 37.5 microgram of levonorgestrel is also famous. Emergency contraception, these drugs can be used within 5 days of unprotected coitus. IUD of Mirena, which has 37.5 levonorgestrel, is also recommended. And in patients who have completed their family, it is equivocally important that we counsel female or male sterilization. So to summarize, a stable course of disease before conception, close interdisciplinary care, pregnancy compatible medication contribute to reduction in maternal and perinatal complications. Conception during remission improves outcomes. We should remember that rheumatoid arthritis often improves during pregnancy. SLE stands at the risk of flare. Antiphospholipid antibody stands at risk of thrombosis and pregnancy loss. And in spondyloarthropathies, the presentation is variable. To summarize, whenever a mother comes to you for pre-pregnancy counseling, ask one key question. Do you plan to get her pregnant in the next year? Discuss birth control with patients who do not desire pregnancy. Ensure disease control and make sure that she is in pregnancy compatible medications. Look for APLA antibodies, presence of other antibodies. Control and assess the comorbidities which she is already having, and assemble a multidisciplinary team: maternal medicine, rheumatologist, physician, and neonatologist. So I conclude my talk. Parenting begins the moment you make a conscious effort to care for your own health in preparation for enhancing your child's conception. Thank you.
Excellent talk by both speakers. In fact, you have covered the whole day's program. Very nicely dealt. Any questions from the audience, please? Are any comments?
Good morning. Madam, in patients of SLE who are nulliparous and when high-dose cyclophosphamide is strongly indicated, like how much will be the risk reduction in the risk of infertility with the help of GnRH analogs? Like, should we use it regularly?
Microphone, please.
Personally, I do not know what is the exact level of risk reduction, but definitely every patient who wants to plan a pregnancy and is being given high-dose cyclophosphamide has to be given an option of GnRH agonist. Can I ask a question? You finish.
If a patient has SLE and has come in remission for 6 months and she had history of severe pulmonary hypertension previously, but now we are controlled on sulbinafil 20 mg daily. So can she proceed with this pregnancy?
So usually if the pulmonary arterial hypertension, first thing is usually when somebody has pulmonary arterial hypertension, the pressures going down happens a little rarely. So you have to be really sure if the pressures have actually gone down. Sometimes you may have to do a pulmonary arterial catheterization to prove that these patients' pulmonary arterial pressures have actually gone down also. So, but if the pressures have really gone down, then I don't see any particular contraindication in this patient planning a pregnancy, but under a careful cardiology follow-up would be needed. Having said this, we've seen patients who come with accidental pregnancies or have planned off a pregnancy even with moderate to severe PH who have delivered, but the risk is very high. So that has to be instilled into the mother and the family also, because you never know the risk, because they'll not be ready to give up on the pregnancy even if you tell them that there's a very high risk to the mother. So we've seen that spectrum also, but when the pulmonary arterial hypertension is under control, involving the cardiologist and planning a pregnancy is fine. Can I ask a question? So if a mother comes, if a patient with lupus is planning pregnancy and comes to you from a rheumatologist saying that the disease has been under control for the last 6 months, everything has been checked, the anti-ROS status, antiphospholipid antibodies, everything has been checked, there are no particular risk factors. From an obstetrician point of view, what are the additional things from an obstetrician point of view that you would actually look at in that particular woman beyond the disease activity or the medications which a rheumatologist has probably adjusted or has told you that the patient is in remission?
I think as I mentioned, we would like to clinically examine the mother for any gynecological backdrop disease which she is suffering from, and also her obstetric history, what are indicators, and is there any other complications, obstetric complications which we are anticipating. Other than that, I think it's most a hybrid model between you and us, which we are combinedly optimizing the disease. From our side, I think medications wise, mostly once the mother is already on compatible medications, we usually don't much change the medications of her per se.
Would you prefer
Can
checking
I
the
answer that question, Subhashini, for you? First of all, I would like to understand her educational status, family background, support, what she has, and what is her nutritional status, what is her BMI. I would like to rule out anemia. You will be very surprised when we first time see the women who are well educated and working a hemoglobin of 8 grams. I would like to understand her anemia. I would like to know about the background family risk of diabetes, because it's 20% of the women, they are on that borderline 5.8, 6.2 of HbA1c. I tell them if they can do a oral glucose tolerance test. So there is one aspect of the rheumatology, but the entire woman as such, we need to look at her, listen to her, understand her, and then again calling her with all the investigations, and then she plans the pregnancy. I would not repeat about SLE, I would not repeat about the drugs. I say you're doing well about this particular thing, but I would like to understand all the entire fertility as a whole. I think that holds probably good.
what is your call on assessing fertility status of the woman, ma'am, at that point?
Yeah, I directly don't go into that. I will ask her for natural conception. Because lot of women, they will have a AMH done. I'm low AMH, I'm feeling very low. I tell them, wait, just look at your general health, plan natural conception over a 3 months or a 6 months, background age of the woman, 30, 31, 32, I don't think we should get panicky at all, except 35. And then after, if there is no natural conception, then I send her to the fertility specialist.
That's exactly what I wanted to hear.
Thank you.
Thank you.
Dr.
Thank you.
Suhasini, one question from me. You said every week you will see the patient till the TIFA scan is done. So, I mean,
Month.
every month till the TIFA. And like, why do we really need to see them at the second, third, and fourth month? I mean, that's if the patient did not have a disease like autoimmune rheumatic disease, then what is it coming up to the TIFA scan, your obstetric follow-up?
I think the general pregnancy changes in the first trimester, second trimester has to be looked up, ma'am. So she might be having other conditions like hyperemesis which needs some support. So we also do first trimester screening by nuchal scan and combined markers. So we do that usually from 12 weeks to 13 plus 6 weeks. So all those come in. So definitely monthly once till she touches TIFA is what we are planning.
Good morning, everyone. Just few housekeeping comments. There is a discrepancy in the audio output here and the live webinar. So I would request all the speakers to keep the mic close to you while speaking. And the second thing is we are putting up a QR code wherein you can just ask questions from wherever you're seated, and those will be taken up by the chairpersons and will be answered in due time. And I also request the chairpersons to please stick to the time so that we can smoothly conduct the program. Thank you so much.
So last question, please.
My question is, given the risk associated with unplanned pregnancy, the disease can flare up. So what is the kind of contraception that you advise in your practice to prevent unplanned pregnancy?
So the preferred is progesterone only pills as of now, but it also depends. We offer them a basket of choices, like it could be what the woman chooses. We counsel them oral contraceptive pills, that is progesterone only pills, but even there are mothers who are comfortable with intrauterine contraceptive devices. So we have the LNG intrauterine contraceptive device which can be put very comfortably. Barrier contraception with spermicide gels is also if the woman is comfortable. But mostly it is these three methods which we have been seeing that the mothers are more comfortable.
So in patients who are non-compliant, like with medication in general, would you advise IUD
Yes,
over?
yes. So that also depends, because some mothers may choose it, some mothers may not feel comfortable about it. So we offer them all the three and we see.
Thank you, Dr. Keerthi and Dr. Subhashini. We have gone through the preconceptional counseling with few case scenarios. I think you would have got a gist of it. Now we will move on to the second session, and I thank Dr. U.R.K. Rao for being a co-chairperson here. Thank you.
Thank you. Thank you all.
Our next talk deals with a very practical and often challenging aspect of patient care, that is interpreting the laboratory reports in antiphospholipid syndrome. May I invite Dr. Shantivi Rupan, Senior Professor and Head of the Department Pathology at Nizam's Institute of Medical Sciences, and Dr. Ram Mohan, Additional Professor at the Department of Microbiology at Nizam's Institute of Medical Sciences, to please chair the session and introduce the speakers.
Good morning, everybody. May I invite Dr. Rajendra Varaprasad, Senior Consultant, Department of Rheumatology, Yashoda Hospital, Somajiguda. He is also a President of Rheumatology Association of Hyderabad Chapter, Associate Editor of Indian Journal of Rheumatology, and a Scientific Chair of IROCON 2023. I invite Dr. Varaprasad to deliver his talk on clinical interpretation of laboratory reports in APS.
Sorry, the presentation, I think it has to be loaded. So I'll start, please copy it. I'd like to thank Lisa Madam and the organizing team for inviting me for this talk, and this is one of the topics of interest for me. And while even before this presentation and while preparing for this presentation, I was thinking this should be complemented by say specialists from the laboratory side, and I'm glad to see Shandivir sir and the two chairs who are experts in this field. I think I can certainly take their inputs as well. So this is, as we all know, APS is one of the unique rheumatic diseases where there are no warning symptoms or warning signs, and as you all know, the disease manifests itself as a thrombosis or a miscarriage most often, and the diagnosis is so reliant on antibodies that they form a very important point to diagnose APS. Without antibodies, I don't think we can diagnose it. It's very rare to diagnose a seronegative APS. So that is the importance of the laboratory evaluation of these patients. I'll mention few cases just to warm up about the topic. First case, we'll discuss it again at the end, so that it will help us know what we have learned today at the end of the presentation. This is a case of 30-year-old woman, currently 6 weeks pregnant with a history of 3 consecutive first trimester miscarriages. She was extensively evaluated in medical genetics clinic for pregnancy loss, and all the relevant investigations were done which are unremarkable. Then after an autoimmune workup, she was referred to the rheumatologist. The anticardiolipin antibodies IgM are 37 MPL, IgG levels were 2 GPL, which is negative. And lupus anticoagulant, it was given as probable positive. DRVVT screen and confirmed negative, and APTT screen positive, confirmed not done. And beta-2 glycoprotein, both IgM and IgG, both are negative. And ANA is 3+ speckled and 2 cytoplasmic, with blood being negative. The remainder of autoimmune and thrombophilia workup was unremarkable. Just remember this case. We'll see each and all the 3 antibodies in detail, and at the end we'll review this. And I'll also mention a few of the cases, how the typical cases present. These are all real life cases. There's a 20-year-old ICU nurse who had mild arthritis and Raynaud's and she was absolutely fine, but when we tested, she was having very high titers of ANA and high titers of anticoagulant and beta 2 GP1. She is very well controlled with low dose steroid initially, on only maintaining on hydroxychloroquine and put on ecosprin because she is. And going on her career, and on routine test, her VDRL has come as positive, and she was being recruited in one of the organizations. And she couldn't go through it because of this test. They did not accept. And so we always hear false positive VDRL, but this is one real life case where a APS patient had this VDRL positive, which was done without any reason. And one more case, 30-year-old lady, she had a back pain, knee pain, and classic symptoms of SPA, but she already came with a report of ANA, and on evaluation, one after the other ANA profile was positive, anticoagulant antibodies all are positive. This was 5 years ago, but because the strong antibodies ecosprin was given, but she always behaved like SPA, treated with sulfasalazine. Now she is absolutely remission in the last 2 to 3 years for the joint pains. Her ANA became negative, but APS panels are still positive with the low titers. Now she is planning pregnancy. She is continuing ecosprin. The 35-year-old lady, she had very difficult to treat hypertension, eventually found to have renal artery stenosis. History of TIA was thought because of hypertension itself. One report, old report, was showing mild thrombocytopenia, around 1.1 lakhs. And she was having primary infertility, and this was some 5 years ago. All the routine evaluation was done along, including an APS panel, which was showing titers 10 times over the upper limit of the lab cutoff. She was managed appropriately, and she had a successful pregnancy eventually. And this last case, a young lady who had recurrent miscarriages, and routine evaluation, genetic ANA is RN negative. Went to a tertiary care center. Tests were repeated because of strong suspicion of miscarriages in a young female without any other histories, genetic normal. And this time beta 2 glycoprotein 1 has come as strongly positive. Does this case says how the value of repeating a test. The repetition is because of the reasons why I will subsequently tell you. So which test to be done, when to test, how to interpret them, these are the main goals. And how to do the test, this is not entirely in the clinician's domain, but we should know how they do it. So brief epidemiology, APS antibody present in 10 times more commonly than actual patients of APS. The prevalence is, this is a Western data, prevalence is around 50 per 1 lakh, and the incidence is 2 per 1 lakh every year. Brief pathogenesis, now just to refresh, because the pathogenesis of APS has been moving from the entirely thrombosis to more of inflammation, even at the level of thrombosis and at the level of uterus. So here I think most of you know the classification criteria, the 2023 classification criteria, and I'd like just to revise them, and we will go at individual antibodies in detail. So the entry criteria is at least one document. The miscarriages in the less than 10 weeks, they were given as lesser weightage, but when the more weightage is given to preeclampsia and placental insufficiency, especially, and more if they both are there together. And cardiac valvular thickening or vegetation given more weightage, and mild thrombocytopenia. These are the 6 domains. Each is coming to the laboratory criteria. A single positive test of LAC, lupus anticoagulant, is given a 1, and persistent positivity is a higher score of 5. And please note the anti-cardiolipin and beta-2 glycoprotein. If it is a moderate positive IgM, either anti-cardiolipin and or beta-2 glycoprotein, the score is only 1. If it is an IgG antibody with a moderate positive, either ICL or beta-2 GPI, or both, the score is 4. If it is the levels are high positive of IgG, either of anti-cardiolipin or beta-2 GPI, the score is 5. And if both are positive, the score, it is given the highest score, 7. So if there, and putting all the clinical and laboratory domain, if the score is more than 3 for the clinical and more than 3 in the lab, we can classify these patients as APS patients. So the important point here is classify the patient as APS. So because every patient will not fit into these criteria. So the indication to test, I think we all know the unexplained thrombosis, unusual sites, recurrent miscarriages, preeclampsia help, and classic APS manifestation like AHA, mild thrombocytopenia, persistent prolonged APTTs. These are the common indications. And as mentioned, how to test is the functional assay, lupus anticoagulant, and solid phase assays, anti-cardiolipin and beta-2 GPI. So coming to lupus anticoagulant, it is a functional assay where we determine the APTT because any antibody which is, even if it is APL independent, it can be detected by lupus anticoagulant. That is why it is given. It has a one of the high predictive value for a thrombosis, and this is classically done by either 2 APTTs. One is 2 tests. That is a screen test, that is DRVVT test, and one more very sensitive APTT, either using a silica activator or allergic acid activator. So there are 3 different types. I'm not sure which is done currently in most of the centers. So traditionally there is a screening test, a mixing test, and a confirming test. So the screening is where we determine that APTT is positive. Mixing test is where we will see that whether the prolonged APT is being corrected, and a confirmation test is when excess phospholipid added to the patient's serum, and to see if it is corrected. And if it is corrected by the excess APS, it is a confirmation test. How high the values are of the APTT are with the, corresponding to the confirmation test when given with when the test is repeated with the excess phospholipid, that the ratio is what determines as a positive LAC. Usually the ratio is more than 1.2, at least 1.2 or more than 1.2. So there are false positives and false negatives, especially in acute scenarios, any major trauma surgeries where factor 8 can be high, there could be a false negative. And any inflammatory case where there is high CRP, because it also is a phospholipid, it competes with the test, and there could be a false positive LAC. And all infection and inflammation, there will be transient elevation of these antibodies leading to high LAC. Medication as non-anticoagulant medication, there can be either this hydrolyzin, this antibody methyl-dopa, this kind of drugs can prolong the APTT, and vitamin K antagonists, heparins, and direct and the newer anticoagulants, they all can intervene with the test. So while requesting a test, we should mention that patient is on such and such medication, so that the interpretation that it will be helpful for the lab. So and they will also can give accurate values for us. Coming to the anti-cardiolipin and beta-2 GPI antibodies, here it is done by an ELISA, or there are other solid phase assays. Most commonly is ELISA is the one which we do, which can be either manual or automated. Manual, and here we should know that here I will be speaking that there are expert recommendations how it has to be done, what should be the batch to batch calibration, how much different should it be between batches, and how to follow the cutoffs given by the manufacturer, and how to have their own cutoff of a particular group of patients, like say in India. So because these antibodies there is no standard, so certain guidelines has to be followed by lab, which is little more for me to explain everything, but that has to be kept in mind. And they also can be, there could be interference because of infection, inflammation. A very high rheumatoid factor can give a false positive antibody test. And hemolysis, jaundice and lipemia, they all can interfere with the assays depending on how the assay is being done. So interpreting the test, once we get the lab values, what we look at is, as mentioned in the criteria, so the isotype, whether it is IgG or IgM. IgG always is more important and has higher risk of thrombosis or OBG complications. The titer, the higher the titer, more significant it is, and we are more comfortable saying that it is truly positive. And number of times it is positive. If a patient has persistently high antibody levels, like 3 or 4 times, then we are sure that patient is APS. Here is where the most of the confusion is when the test is only positive for once or not at high titers, and only So when we see what clinically we see when we see a APS patient, classically most of the patient have high titers and persistent positive. So that is very easy, but other times when we all have this non-criteria type of presentation, which is difficult. So IgG is more important clinically, and moderate to high titers, that is more than 40 units in case of ACL, and is important. And if the number of tests which is positive, that is triple positive, carries the highest risk for clinical manifestations. And out of all antibodies, LAC is more sensitive, I would say, and beta-2 IgG, beta-2 GPI is the most pathogenic antibody out of all the phospholipid antibodies. And coming to the brief word about the isolated test positives. Isolated LAC, more and more data is coming. Even isolated LAC is very important. IgM is important for obstetric patients, there could be some miscarriages. And isolated ACL, previously it was considered just follow. They are also on follow-up, want to be symptomatic. So as more and more data comes, I think we'll know more about it. So these are the titers which were given by recommendations were given by ISTH. It is 40 is the cutoff for the medium positive titer, and more than 40 is considered moderate, is medium, and more than 80 is high. Here, regarding standardization, I want to skip, but I would like to say a couple of sentences here. So what is a high value, and what exactly is when is it significant in a group of population? When the level of titers, if the recommendation say we should test at least 120 patients in a group of in a cohort, and to see the 99th percentile of the antibodies, and that percentile is the significant percentile where the patient can be significant. Anything less than that, 95 to 99 are moderate positive, and otherwise what most of the commercial lab do is the kits itself carry the values, and that has to be replicated in the lab, and then the test results done and forwarded to the clinician. So it is important that there is a lot of inter-assay variability in the same laboratory. It could be in the different batches there will be variability, and sometimes if you do by a different platform, like say if you switch from ELISA to CLIA, the sensitivity may differ if we suspect strongly about the underlying APS in particular patients. So there are some common clinical dilemmas: false positives, false negatives, and in emergency settings where we don't have time but patient has thrombosis, we give heparin, we can't test LAC immediately, or the lab reports comes late, and patient is already pregnant, only one antibody is positive some 2 months back, we can't repeat immediately. These are all some real life problems. And especially in precious pregnancies, when especially it is a problem if it is the titers are not very significant, and with how to treat and all. And when the patient is on anticoagulant treatment also, it is not very easy to test. There are a couple of scoring systems which are devised to assess the risk. One is the APL score, which takes into consideration all the different types of LEC testing, the various isotypes of antibodies, and, including PSPT, and including what is the level of titers. This is just to mention this, no need to remember, because these are for trials only. There is another scoring system, global APS score, where you give weightage to individual antibodies, and they included the common other prothromonic risk factors like hypertension and hyperlipidemia. And composite score is based on this, and a score more than 6 in SLE patients, and the general score more than 11 to 12 is associated with high risk of thrombosis. A small note about IgA isotypes. IgA isotype previously, even now there is not much data, but the newer studies show they also carry a risk in few patients. But we don't know how significant this carries when we already are doing IgG and IgM isotypes. So coming back to our previous case, here we have IgM titer which is just 37, which is I would say low to moderate positive, and lupus erythematosus is probable positive, and beta 2 GPI is negative. So this patient will not fulfill the criteria of APS antibodies, but given the history of recurrent miscarriages, we have to treat her as an APS patient. And what to do about this test? We have to repeat the anticardiolipin antibody obviously after 3 months, and lupus erythematosus also repeat. And one more thing is always depends on how reliable the lab is. So sometimes we may need to repeat this test to check the versatility of the reports if we done in a center which doesn't have an expertise of doing this test. So some important points I'd like to mention are it is a potentially life-threatening disease and have a devastating complications with the most imperfect laboratory tools sometimes. And the IPS biology and the clinical manifestation does not fit into the classification criteria, and still believe it is all dependent on the clinical suspicion and interpretation of the patient. And once every patient should be seen as a different individual, not based on the classification criteria, and perform all the tests in the same sample. And there is also how to handle the samples. We should be doing with immediately, and we should freeze it if it's not done. So how sampling is also important, and report and interpret using a whole panel. One report isolated which cannot interpret. We have to have all the 3 tests to interpret properly. And I think with the experience of practicing, I would emphasize my interest is more on standardizing this test so that we have some uniformity in the future, and how important are these non-criteria antibodies, maybe we'll know in the subsequent lecture. Thank you.
Thank you, Varaprasad, for completing your talk in well in time. We have time for questions. Do we have any questions on his talk from the audience?
Nice talk, sir. So my question was about the difference between ELISA and CLIA, sir, for anti-cardiolipin and anti-beta 2 GP1 antibodies. So how do we, so we get many reports with the CLIA and not with ELISA. So how do we accept the CLIA? Do we accept it? And do we get any difference if we do the same test with both?
Yeah, so that is where I was talking. We need the chairperson's answer, I think, here. Because what I know is CLIA is more sensitive. I don't know how good it is better than ELISA. So when we have a doubt in one method, we can repeat in another method. So I think you are the right person to answer.
Actually, we do by ELISA method, but I remember seeing once in the literature that ACL and beta-2 glycoprotein need to be tested by ELISA method only rather than CLIA. That's where somewhere I have read it. But other non-criteria antibodies anyway, some ELISAs are not available. So then CLIA is the only method, or fluorescence method is the only one available for the other non-criteria antibodies. But as far as I know, and most of the labs they do, maybe they do by CLIA if they have an instrument, but I remember reading somewhere that ELISA is the standard method for these two antibodies.
To add to what Ramu is telling, for the diagnostic criteria for laboratory testing of lupus and antiphospholipid antibodies for these like anticardiolipin and anti-beta-2 glycoprotein, it is the standardized ELISA which is recommended. So I don't know much about, maybe the others are using CLIA, but it is the recommended one is the standardized ELISA for these two antibodies. Any more questions?
Yeah, I have some questions, just to provoke some thoughts, because we see whenever we interact with other specialists around, they will ask some people who know about this antibody, they will ask, where do you do your tests? How good is your lab? Standardization, all this, and shall be repeated somewhere. So standardization is one of the most important thing I think everyone should look forward to.
Thank you, sir, for the great talk. Sir, actually, my question was on the same lines. So, would you, if a patient has this borderline elevated antibodies, would you recommend it to repeat from the same lab by the same method, or would you plan on tell them on repeating from a different lab from a different method? So that would be.
So literature say, I mean, the expert says the test should be done in the same lab. But in the practice, like if you have to do in the most reliable lab and experts who know about how to do the test. Because now we have a lot of commercial labs, we don't know from who is doing their expertise. Sometimes, so recommendation is that we have to do the whole panel, the handling the sample. They are not done within the first hour, or they should be frozen immediately and done. So these things, are they being followed? We don't know. So expert says should be done in the same lab. They also say the best lab. So then next time when you do.
Questions are on the screen. If you can answer, we have another 2-3 minutes. The next question is whether I think they are keeping changing. How to solve difficulty of probable positive? One of your case had a probable positivity for LAC.
I think I mentioned it, that has to be repeated again after 3 months, and that is the only way to know.
To add that, because usually DRVVT means from the lab side is the best test for, but if you see the recommendations for testing the lupus, you have to have 2 tests with 2 methodology and tested twice with 12 weeks difference. So, but usually PTT-LA, if you are doing as another test apart from DRVVT, it should be also confirmed. They give probable result, because we also give probable result when we are not having a phospholipid based neutralization confirmatory test for that. So those tests have to be taken with a pinch of salt. If other things are negative, clinically it is not fitting into it, better to repeat at a later date and then only consider that as a APS.
Two things. What is the problem in getting the PTT-LA? Because we've been now in a phase when we're doing it in volumes. Second is the guidelines say that they should be considered negative. You also said with a pinch of salt. So because it places a burden on the clinician and the patient to come back for a testing when they are not sure, the situation may be that you want to know definitively, and if you have to give one answer, I think it would be that that test is negative.
And the problem with getting a phospholipid based PTT-LA confirmatory test is the reagent supply is little problem. We have to import this reagent, and we are trying since several years actually. In fact, there was a difficulty, RC, it was not included initially and all those things. Now we have gone for a fresh notification of our coagulation, we will be able to do it. Anyway, what we are doing is total things. If you see, we are doing a 3-step procedure from screen, we are doing mixing, and then we are doing the confirmatory test for DRVVT. The problem is with only PTT-LA, because we are doing a screen and mixing, but the next step of confirmation is not helping, and especially in cases where there is isolated PTT LA increase. So that is our problem. We are trying to solve that to get this antibody, then we can standardize that
And
also.
what are this paid test and all the three come together, those tests?
That's what we have to do. These three, we do all the three tests. Only thing is there is little difference in the recommendations by different guidelines. International Society for Thrombosis and Hemostasis ask the stepwise, like first is screen, then it is mixed, then it is confirmed. But if you see other guidelines, CLSI guidelines, it is first screen, then confirm, and then mixing. So there is little change, but we follow the ISHT guidelines. I think we have exceeded the time. Last question we can take.
So the last answers are some of the questions. They say one antibody is positive and next time ACL is positive. So any antibody, if it is positive, we have to consider it as APS. So once it is beta 2, next is ACL, we have to consider.
Sir, of late we are seeing many patients walking with APL antibodies rather than the triple antibodies, what the guidelines suggest. So if they are strongly positive, do we need to follow the repetition the same repetition as we do for the triple antibody? And the positivity, does it really weigh when we manage these patients, especially the patients who has only a history of recurrent pregnancy losses?
Yeah, but APL, as we all know, these when the antiphospholipid antibodies, so they theoretically mean all the phospholipid antibodies, anticardiolipin, beta-2-glucuron, phosphatidylserine, ethanolamine, all, they're detecting phospholipid antibodies. But the guidelines and the recommendation, the studies are done for specific antibodies, cardiolipin and beta-2-glucuron. They are significant. We cannot ignore them. But when you want to prospectively follow up the patient, then maybe you can be more specific and do anticardiolipin beta-2-glucuron.
Okay.
Thank you.
Organizing team for the opportunity to chair this session. Thank you, Varaprasad.
We move on to the next talk. The next topic explores an area that continues to generate debate in clinical practice, that is non-criteria obstetric APS. I would invite Dr. Radhika, Additional Professor, Obstetrics and Gynecology Department at Nims, to kindly chair the session.
Good morning, everyone. As we take up the topic of a confirmed APS, and everybody had so many questions to ask, and they were still unanswered, left to be answered. So now we move on to the next session, which is an even more enigmatic topic, which says non-criteria obstetric APS. Is it a myth or a reality? So a confirmed APS can be so problematic, and now we have an APS which does not meet the criteria. It does not meet the 3 clinical or the laboratory lab criteria that we needed. So now I invite Dr. Akshay Parekh. Welcome back to his alma mater. He's a senior consultant rheumatologist at AIG Hospital. I request Dr. Akshay Parekh to take up the topic.
Good morning. I'll be talking on non-criteria obstetric APS, whether this is a myth or a reality. So the structure of the talk will include the evolution of classification criteria of APS, the subsets of non-criteria obstetric APS, including the clinical non-criteria obstetric APS and seronegative obstetric APS, and finally coming to the conclusion. So it was the year 1983 when Mr. Graham Hughes, in his landmark article titled Thrombosis, Abortion, Cerebral Disease and Lupus Anticoagulant, first described antiphospholipid syndrome. And this can be traditionally defined as a systemic autoimmune disorder characterized by recurrent vascular thrombosis and or pregnancy morbidity, occurring in the setting of a persistently positive antiphospholipid antibodies. And it could be either a thrombotic APS or an obstetric APS. Obstetric APS when there is only pregnancy morbidity. And as discussed in the previous lecture, these are classification criteria, and they have been created to define homogeneous cohorts appropriate for clinical research, not for diagnosis. Coming to the evolution of this classification criteria, in 1999, the first criteria was defined that was called as the Sapporo criteria, and this laid the foundational framework for classifying definite APS. It required 1 clinical and 1 lab criteria. In the clinical criteria, there should be vascular thrombosis either in the arteries, veins or small vessels. And this will be the most important slide of this presentation, and which we all know, that is the pregnancy morbidity. there should be positivity for at least one of these following. It could be either early recurrent losses, 3 or more unexplained consecutive spontaneous abortions before 10th week, with the exclusion of parental chromosomal anomalies, maternal, anatomic and hormonal causes. Or it could be a late fetal death, 1 or more unexplained death of a morphologically normal fetus after 10 weeks. Or a premature birth, 1 or more premature births of a morphological normal neonate before 34 weeks due to severe preeclampsia, eclampsia, or a severe placental insufficiency. And the lab criteria at that point needed to be positive twice 6 weeks apart, requiring either ACLs or the lupus anticoagulant. So they also mentioned about non-criteria manifestations at that time, which were associated with APS but could not be included in the criteria. These included the cardiac valve disease, levodoreticularis, thrombocytopenia, nephropathy, etc. And at that time, the beta-2-GP1 antibodies were non-criteria. But soon in 2006, the next criteria, that is famously known as the revised Sapporo criteria, was defined. It included the beta-2-GP1 in the criteria because there was enough evidence at that time. The pregnancy morbidity and the thrombosis was almost same. The antibodies this time needed to be positive twice 12 weeks apart. And the pregnancy morbidity specificity was improved with the help of recognized features of placental insufficiency. They also mentioned about the non-criteria manifestations of APS. The clinical non-criteria manifestations were still similar. And this time, the non-criteria antibodies included the IgA subtypes and a list of antiphospholipid antibodies, including phosphatidylethanolamine, phosphatidylserine, and the complex of phosphatidylserine and prothrombin, famously known as anti-PSPT. And after this came the 2023 criteria, which was discussed in the previous talk. So this criteria had a higher specificity compared to the 2006 criteria, that is 99%. But this came at the cost of a sensitivity. That is, the criteria was okay to miss out on APS patients just to make sure the specificity is not compromised. And in the clinical domains, the previous non-criteria manifestations, that is levodoreticularis, nephropathy, cardiac valve involvement, and thrombocytopenia, are now all part of the criteria. But the obstetric manifestations still remain almost the same. The only addition being the early fetal death, that is 10 to 16 weeks, now comes in this category compared to the next category. And in the lab domain, if we can see, even a criteria with 99% specificity now gives a score for a single time LAC positivity, and even though the score is more for a persistent positivity. So coming to the case scenarios given to me, in a 26-year-old female with 2 consecutive first trimester miscarriages and LAC positivity, what do we do? Or a patient with late onset preeclampsia with persistent anti-beta-2-GP1 positivity. Or a 30-year-old female with infertility with persistent LAC positivity on repeated testing. So we can make out that all these patients do not fulfill the clinical criteria but do fulfill the lab criteria. And as we repeatedly emphasized, these classification criteria are for high specificity and for research purposes. They are not diagnostic criteria. And also pregnancies are limited events in the life of a woman. So we can't wait for a next miscarriage just to classify her as APS. So for such obstetric morbidity related to APS, the concept of non-criteria obstetric APS was suggested. So as the name suggests, there can be 3 subsets to this. It could be a clinical non-criteria, that is the clinical manifestations are not fulfilled, but the lab criteria is fulfilled. Or it could also be an incomplete lab obstetric APS, that is the clinical criteria is fulfilled, but the labs are either not persistently positive or low titer positive. Or it could be a completely seronegative obstetric APS, that is the criteria manifestations are fulfilled, but the labs show non-criteria APL antibodies, not the routine well-defined APS antibodies. So what does this clinical non-criteria include? The manifestations which have been recognized now by the European Registry of Obstetric APS, that is the Euro APS, include these non-criteria manifestations. 1 or 2 unexplained pregnancy losses before 10 weeks, 3 non-consecutive pregnancy losses, a late placental vasculopathy, that is beyond 34 weeks, a late premature birth between 34 to 37 weeks without any other apparent cause, placental abruption and placental hematoma, and recurrent implantation failure. So let's see how does this non-criteria obstetric APS behave compared to obstetric APS. So from the same registry, around 1640 cases were selected with more than 5,000 pregnancies, and 1,000 of them met the classification criteria and they were defined as obstetric APS. 640 of them did not meet the criteria. So they included a mix of clinical non-criteria and incomplete lab obstetric APS. So what did the results show? The non-criteria obstetric APS group had higher rates of recurrent implantation failure and late placental events. But this was also partly because that is how the definition of non-criteria obstetric APS is defined. But in the labs also there were differences. When they looked at double or triple positivity or lupus anticoagulant positivity, it was more in the obstetric APS group. While looking at isolated positivity of either ACL or beta-2-GP1 or even at non-criteria antibodies, it was more in the non-criteria obstetric APS. And the non-criteria antibodies were seen in almost double the population, that is 11%, in the non-criteria obstetric APS group compared to the obstetric APS. Also, 4% in the obstetric APS and 2% in the non-criteria obstetric APS further evolved into SLE on follow-up. And when 70% of patients in both the groups were treated as APS with low-dose aspirin and prophylactic low molecular weight heparin from the first trimester, the treatment outcomes in terms of live births were almost similar. So they concluded that a different nosologic entity exists in the obstetric APS, which can be called as non-criteria obstetric APS, with slight differences in clinical and lab, but with similar fetal and maternal outcomes when treatment is offered. But now let's look at the individual manifestations and how sure are we that we can always classify them as non-criteria obstetric APS. Coming to early recurrent pregnancy losses, this is one of the most frequent obstetric complications. 35% of the patients with APS can have early recurrent pregnancy losses, but the specificity of it is very, very low, in part because it requires exclusion of other causes. These include known genetic abnormalities in the products of conception, parental chromosomal abnormalities, and other anatomical causes in the mother or metabolic causes. And so it is not always easy to attribute every early recurrent pregnancy loss into a non-criteria obstetric APS. Looking at the late placental complications beyond 34 weeks, in this study when there were 431 patients with late placental complications, 87% had a small for gestational age neonate, and 5% had preeclampsia with severe features, and another 6% had placental abruption. So when they looked at the prevalence of APL antibodies, in the entire cohort it was only 4.9%. And in the general population also it is reported as between 1.4 to 7% based on the study. So are we then justified to attribute this late placental complications always as a non-criteria APS? And coming to another study which gave much different results when they looked at late onset pregnancy complications beyond 28 weeks. They had 100 patients and the prevalence of APL antibodies was almost 31%. But they also included the non-criteria antibodies. When they looked only at the criteria antibodies, the prevalence was still higher, it was 14%. But that could be because they also included stillbirth and placental complications between 28 to 34 weeks, which is actually a part of the APS criteria. And coming to the third part, that is recurrent implantation failure in APS. It is also a matter of debate. Studies show different results. Like in one study, it showed that in women with infertility, compared to controls, there was statistical significance only for anticardiolipin antibodies. While in another study, they found that the significance was for beta-2-GP1 and anti-phosphatidylserine antibodies. So with all this, it is already difficult to prove association, leave alone causation. And coming to how the treatment outcomes are there with non-criteria obstetric APS. In one study, we already saw that the outcomes are almost similar. In another systematic review with over 2,700 participants, 7 out of 10 studies showed similar outcomes in terms of successful pregnancies or live births. And 5 studies showed that there was an improvement in live births in both the groups when treatment was offered. So coming to the answer for our case scenarios, what we have is an entity which does not fulfill the clinical criteria. It has slightly different manifestations, slightly different antibodies, but responds similarly to treatment like the established APS. There is a wide variation in results, probably because of heterogeneous samples, poor exclusion of other causes, and large variations in the detecting methods. So, proving causation is very difficult. Ironically, these issues can be solved by a new classification criteria for non-criteria obstetric APS. And coming to the second part of the talk, another case scenario where a 29-year-old woman who is 6 weeks pregnant with prior severe placental insufficiency outcomes in terms of preterm delivery with severe fetal growth restriction, neonatal death, followed by one episode of IUFD at 28 weeks with PIH. Her standard APS panel of ACL beta 2 GP1 LAC is negative, but the PSPT antibodies are positive, both IgM and IgG. So in this setting of recurrent placental disease with isolated PSPT positivity, can she be considered to have non-criteria obstetric APS? So for this, I'll just like to define seronegative APS, which is a diagnosis of exclusion. It requires persistent clinical features, unexplained thrombosis or obstetric morbidity, persistent seronegativity for all the three antibodies, that too twice, 12 weeks apart, and exclusion of other causes. So if there are only obstetric manifestations, we can call it a seronegative obstetric APS. So again, in the year 2003, the same gentleman, Mr. Graham Hughes, described for the first time seronegative APS. He asked what of seronegative APS, and three possibilities came to his mind. Is it a wrong diagnosis? Or is it just a lab problem and the lab is failing to pick up cases and the antibodies which are directed against different phospholipids? Or the previous APL antibodies which were earlier positive and are still causing the disease have now reverted to negative. So some of the important seronegative APS antibodies which are routinely discussed in literature include the IgA isotypes. These are linked to SLE, recurrent pregnancy losses, and isolated heart valve disease. And one of the most famous ones, that is the anti-PSPT complex. 70 to 80% of LAC positivity patients have anti-PSPT. It has a strong independent risk factor for both thrombosis and serious obstetric complications. Another one is the anti-annexin 5. The annexin 5 is a layer in the endothelium and the placenta which prevents coagulation. When these antibodies react with this layer, they can cause localized placental inflammation, early and late pregnancy loss, even without systemic thrombosis. The anti-cardiolipin vimentin complex, it is associated with severe refractory thrombotic events. And a domain 1 of beta 2 GP1. Beta 2 GP1 has 5 domains. The domain 1 antibody is what actually causes all the thrombotic manifestations. So how relevant are these non-criteria antibodies? In one study of around 107 seropositive APS and 68 seronegative APS patients, 36.8% of the seronegative APS had actually one of the non-criteria antibodies. In another Chinese study with 192 seropositive and 90 seronegative APS patients, they tested for the PSPT complex, IgA isotypes, and anti-domain 1 antibody, and found that 60.9% of seronegative APS and 93.5% of seropositive APS had a non-criteria antibody. Looking at the non-criteria antibodies in obstetric APS exclusively, in a retrospective study of 283 women who were subsequently followed up for pregnancy outcomes, they tested for criteria and non-criteria antibodies, including the PSPT complex, IgA isotypes, and anti-D1. 54 patients met the criteria for obstetric APS and 144 were the incomplete lab obstetric APS. They found that even the PSPT complex had moderate accuracy to diagnose obstetric APS. And the PSPT had a significant odds ratio to cause adverse pregnancy outcomes and early pregnancy losses. And also, as Graham mentioned, is the lab failing to detect the antibodies? So there is a significant limitation in ELISA. In ELISA, when the phospholipid layer is coated to the well, the microtiter well, the spatial orientation of these phospholipids is lost, and some of the important epitopes to which the antibodies actually bind cannot be exposed, and this results in a false negative test. And this can be solved with the help of a thin layer chromatography, where in a silica gel, these phospholipids actually retain their structure, the epitopes are exposed, and the antibodies can be better detected. So in one study, where sera of 61 obstetric seronegative APS patients were used, and several of the criteria and non-criteria antibodies were tested. with the help of thin layer chromatography, 82% had one of the antibody, and 76% had ACL, which were previously found to have seronegative APS. 54% had the anticardiolipin vimentin complex, and 12% had the PSPT antibody. So coming to the answer for the second case scenario, seronegative antibodies, especially the PSPT complex, now does have a strong clinical relevance. But for all these antibodies, as discussed in the previous lecture, still standardization is needed. We don't know the significant cutoff titers, and we are also not sure if all of these are equally pathogenic. Even for an established antibody like beta-2-GP1, if it is isolated positive, in 20% of these cases, we may find negativity for the anti-domain 1 antibody, and there would be a positivity for anti-domain 4 or 5 antibody. And these anti-domain 4-5 antibodies are not are not associated with thromboembolic events. So coming to my conclusion, if we consider non-APS as this black box and obstetric APS as this white box with 100% specificity, the non-criteria obstetric APS as of now is a continuum, this entire spectrum from this range to this range. And if we look at the subsets, the clinical non-criteria APS would be somewhere on this side, the incomplete lab obstetric APS would be somewhere in the middle, and the seronegative APS is coming closer to obstetric APS. And the further way would be guided with the help of antibodies and maybe other homogeneous studies using newer classification criteria for non-criteria obstetric APS. Thank you.
That was a very clearly explained lecture. Thank you so much for that. And now it's open for questions. Any questions?
I would like to know from the gynecology obstetrician colleagues, if we have a patient with 2 or say 3 consecutive pregnancy losses, early pregnancy losses with all the antibodies negative, how do we give heparin or no?
Maybe first I would like to ask the pregnancy losses, what is it documented? The woman may say, I am 12 weeks pregnant, I lost the pregnancy, but if you have time to look through her scan report, it will be only an early pregnancy loss of a gestational sac seed. Sometimes they say it is 10 weeks, that it is only the pregnancy test positive, but there is no evidence. So first, when you decide it's a pregnancy loss, before 10 weeks, I think we need to have a documented scan report. If the documented scan report is there and you have an embryo of 10 weeks, then we think about the obstetric APS. And also the preeclampsia. 10 out of 4 can have a preeclampsia in the first pregnancy. And second pregnancy, when you do the screening, along with the NT scan which we do and the 3 biochemical markers, PLGF and PAPA, and she is the risk of preeclampsia, we give 150 milligram of aspirin now. If I don't have the screening, if I am somewhere else and I take this preeclampsia as the criteria, and if I start low-dose aspirin and heparin, actually she probably may not require heparin, but I start giving heparin. So there is a lot of constraints and keep treating. Like for example, the first case of recurrent pregnancy losses, Dr. Rajendra Varaprasad has shown it. I will tell her wait for 3 months and repeat the test. I won't, in case she conceives, then probably you're justified in starting. So the establishment of the antiphospholipid syndrome is extremely important. Then only the treatment should start.
Just regarding the pathophysiology of the beta-2 glycoprotein, like this, there are 5 domains as you said. The beta-1 domain is the most important. And in vivo, what I've seen in the literature is the cardiolipin goes in vivo in the body. The cardiolipin goes to the beta-2 glycoprotein, binds to the domain 5, and then opens up the domain 1 for antibodies to act. So in that case, both positivity of dual positivity would mean mostly the domain 1 is the positive antibody.
Yes.
So do you take that like what I said, both the antibodies being positive suggests that it's a domain 1 antibody, beta 2 glycoprotein.
Yes.
If it's a single beta 2 without ACL, it could be another domains.
Yes.
Do you take that in that way, or do you clinically see that most of these beta 2 and ACL together being positive mostly correlates with the diagnosis?
Sir, so what I discussed was a special case scenario, but overall, even if one antibody is positive and there is a strong clinical criteria, then we will give it significance.
But dual positivity, does it correlate more? That's
Yes,
what I added.
so dual positivity, triple
Without
positivity always correlate more with obstetric APS.
Thank you. Thank you, sir.
Ma'am, I have one question. This we have recurrent implantation losses, implantation failure. Especially most of the patients they go for IVF. So after IVF, they have an implantation failure, and they come with the reports of this anticoagulopin antibody positive. So how to go in this situation? Do we consider that as a pregnancy loss, or how does those patients require to be treated or not to be treated? So it's only IVF, implantation failure, anticoagulopin antibody positive. This is one question. And second thing is, like we have 2 pregnancy losses, and we have low titer beta 2 GP1. So how to attribute it? Because I agree with, because if that low titer beta 2 GP1 has a high affinity for domain 1, so like how do we interpret about this implantation failure as well as low titer antibodies with 2 pregnancy losses, early pregnancy losses? It fits into the criteria. Do we have to wait for 3rd pregnancy loss? Because practically it is very difficult for us to convince the patient to tell. It looks good on theory for criteria, everything, but practically you have only 2 losses, wait for 1 more loss, then I will start treatment. It's very difficult.
Yes, sir. So that's why the concept of non-criteria obstetric APS. And still, as of now, because the data is limited, in every case, the way forward would be to rule out other causes, to discuss with the patient, and if there is an advanced maternal age, it is a precious pregnancy, if there are no other contraindications, to treat it as a criteria IPS.
Thank you, Dr. Akshay. I would like to end this session here, and I think next the inauguration follows.
Good morning, everyone. So we now begin the formal inaugural ceremony of the MOD CME 2026 3rd edition, Medical Obstetric Interface in Rheumatic Diseases. So this inaugural ceremony marks the formal commencement of this academic gathering dedicated to advancing care at the interface of rheumatology and obstetrics. So to begin the inaugural ceremony, I would like to invite the dignitaries onto the stage. Firstly, I would like to invite Dr. Rajendra Varaprasad sir, President, Indian Rheumatology Association, Hyderabad chapter. Can we have a round of applause for the dignitaries? Next, I would like to invite Dr. Raj Kiran sir, Secretary, Indian Rheumatology Association, Senior Consultant Rheumatologist at Hyderabad Rheumatology Center. Then I would like to invite Dr. Sharat Chandra Mauli sir, Senior Consultant Rheumatologist, Senior Member of Indian Rheumatology Association and Academic Coordinator of HRA. Welcome, sir. I would also like to invite Dr. Tarakeshwari ma'am, Chief Medical Director, Senior Consultant Obstetrics, Department of Obstetrics, Fernandez Hospital. And I would take the privilege to invite our chief guest of the day, Professor N. Birappa sir, Director, Senior Professor, Department of Surgical Gastroenterology, to come onto the stage, please. So every meaningful beginning in our culture is marked by invoking positivity, knowledge and collective purpose. And today is no different. To seek blessings from the Almighty for a successful academic session, we would like to, like everyone to request, stand up for the prayer song, please.
Gajananayutam Ganeshwaram Bhajami Satatam Sureshwaram Shri Gajananayutam Ganeshwaram Ajendra Pujita Vigneshwaram Ganadi Sannuta Padapadmakaram Kunjarabanjana Chaturataram Guru Guhatmajam Pranavakaram Gajananayutam Ganeshwaram Bhajami Satatam Sureshwaram Shri Gajananayutam Ganeshwaram.
Thank you. Please be seated. So light symbolizes knowledge, wisdom and the dispelling of ignorance. May I now invite our esteemed dignitaries onto the stage for lighting the lamp. So it is an electric lamp. As the lamp is lit, may it guide us towards clarity in thought, excellence in practice and compassion in care. Thank you so much. Please be seated. Now, I would like to invite Dr. Lisa ma'am to address the gathering and set the stage for Mod CME in a formal tone. Thank you so much.
Good morning, everybody. First of all, I'm really grateful that all of you are here. And secondly, I'm myself overwhelmed at the complexity of what we've been hearing from the morning. This is the third edition of this interface between medical obstetrics and rheumatic disease. And we are fully aware that this interface of medical obstetrics is just one part of what the obstetricians do. They deal with many other very challenging medical disorders in pregnancy. But I think they also agree, and that is the result why when we started the first CME, we knew that we had to do many editions of this CME. And what we've heard this morning, and I'm sure what will come in the day as it unfolds, is scientific evidence which will be challenged by the real life situations that we have, which classification criteria, which guidelines do not even cover. And when we leave today, if rheumatologists and obstetricians can at least understand what we are saying to each other, this is what I thought, but having heard the last two lectures and having heard the pearls of wisdom from even the lab medicine, I think that every conversation will now have to involve even the laboratory specialists, especially when the tests are falling below the international standards of positivity. The challenges that are ahead in this field will be not only to continue to train the youngsters to speak this common language, but also to improve understanding of the lab and the standardization of these tests, because I think it's high time. I think when we started our journey together, Dr. Tara, we used to discuss individual cases on the phone, and then we had exchange lectures between the two institutes. Then we had these CMEs, and now I think it's high time, because the medical field in India is matured at a point that we could have our own standards. As Dr. Varaprasad rightly said, the focus should be there. These are the thoughts which come to the top of my mind. I have also been told by the organizing team that I should bring to the podium the case of this young woman who is with us now in the ward. She was diagnosed with lupus in 2021, and for the next 4 years she has been off treatment. When she became pregnant, she had severe preeclampsia, and the medical termination of pregnancy was done. A week later, she was in our ward with severe abdominal pain, orthopnea. Investigations showed that she had a proteinuria which was 16 grams, she had myocarditis, and she had hepatic infarcts and a chronic splenic infarct. She went through intensive care for the last 15 days. She's now back in the ward. But these 15 days have been very high cost, not only to the family, but also to the society as well. The cost of intensive care, hearing Acinetobacter in the lung, doing a bronchoscopy, managing the repeated episodes of pulmonary edema, hypertension, this is the reality of individual patient care. And this could have been prevented definitely if she was compliant to therapy. So that's a challenge in the patient sector. And if her pregnancy would have been guided by acknowledging the fact that there was a major disease in the background. I just stop here because you'll hear many of these cases in the hours to come. Thank you very much.
To set the stage and to share her insights.
It is indeed a privilege and an honor to be here. Yes, as Dr. Lisa said, 20 years ago, this journey started where we had individual mothers coming in with a diagnosis of antiphospholipid syndrome. So I remember the days I came to Nims, to the Department of Microbiology, to learn how LAC, ACL is being done. I sit with Dr. Lakshmi in that department, and to understand this pathophysiology. Now it is a third CME which we are doing, and we are indeed privileged to take care of the mothers who come from Nims to us, because they come from the middle income group or low middle income group. And I fully agree when Dr. Rajkiran said it's a challenge. It is extremely challenging when we take the journey of the woman with established heparin throughout the pregnancy, and it's not easy for us to stop heparin when it is really meant, no, she will not need heparin. So definitely there are challenges, and I think all of us are working towards the patient care, keeping those families into consideration with the limitations what they have and the financial challenges what they have. We should come up to a stage where we should be able to take care of all these women, not only with the rheumatological disorders, the medical disorders, and the obstetricians and different specialities when we work together. So in premier institutes they are able to do, but in our level at individual cities, I think we should talk to each other rather than working in silos to help this woman in front of us to get the best possible care in the limited situations what we have. I think this is an excellent example of the clinicians, the rheumatologists and the obstetricians meeting together, and we should have more of dialogues, and we should understand the patient issues, and we should take care of them. Thank you for this wonderful opportunity, and thank you all for attending this session. Thank you.
Thank you so much, ma'am. I would now like to invite Professor N. Birappa sir, Director NIMS, to address this gathering.
Good morning, everyone. Dr. Varaprasad, President of Rheumatology Association. Dr. Raj Kiran, Secretary, and Dr. Sharat Chandra, the Academic Coordinator, and Dr. Tarakeshwari Madam, and Professor Lisa, dear friends, students, and the delegates. The interface I used to hear in software engineers, they do discuss about this. I never understood the interface between a radiologist and obstetrician. This is the first time I am hearing, ma'am. Anyhow, this is all very complicated issue. If brain doesn't know anything, we don't understand. So I am a surgeon, so I don't understand any of these things. But one thing I can say, this looks like very, very complicated issue. The walking on a very tight rope. The planning of pregnancy in a patient who has a rheumatology issue is a big challenge. Diagnosing a rheumatology disease is a big challenge. Followed by, if the patient conceives, and then maintenance with the drugs, whatever drugs you call it as methotrexate or MMF. I know that these drugs can cause some teratogenic effect. So you need to maintain the dosage, and then complications of these drugs. And these people, they may develop eclampsia or preeclampsia, whatever it is. And then delivery, during the delivery it's more challenging. The later also, during lactation also, I think they need to stop certain drugs and change certain drugs, and it's a big exercise. So definitely the word interface has a lot of meaning here. The interface between a rheumatologist, the gynecologist or obstetrician, and the lab, all are major players in treating this kind of complex cases. Professor Lisa was mentioning yesterday, and now also, there have to be common discussion about these patients. Sit together, as Tarakeshwari Madam was also mentioning, sit together and discuss about the case by case, along with a lab specialist. And the young guy was presenting seronegative antiphospholipid, whatever it's syndrome, and seropositive, seronegative. But how to treat? Did you go ahead with levels of the antibodies? I don't know. So this seems to be very tricky and complicated. Need to sit and together and discuss and come out with a big solution. And the rich people doesn't come to us. All poorest of the poor patients comes to us with all these problems. And they may not, as Madam said, they may not be able to afford the treatment, especially biological. So the cost factor, the lab, everything needs to be discussed. I really congratulate Department of Rheumatology and Fernandez Foundation coming together and discussing very complicated issues. Thank you for giving me this opportunity. Thank you.
Thank you so much, sir, for acknowledging the challenges that we face in our day-to-day practice, both the rheumatologists and the obstetricians. Now, I would like to invite Dr. Raj Kiran, sir, Secretary, Indian Rheumatology Association, to speak on behalf of Indian Rheumatology Association. Please, welcome, sir.
Thank you, Madhuri. Respected dignitaries, Professor Birappa sir, Dr. Lisa ma'am, Dr. Tarakeshwari ma'am, Varaprasad and Sharat sir, and all the delegates who have come here. Interface meetings are one of the wonderful meetings. What I feel is rheumatology itself is a branch of common grounds. We share interface with obstetrics, dermatology, orthopedics, whatnot, everything. And there is a lot of scope for us. Everything we come to these kind of meetings, definitely we go home learning new things. I have to congratulate and thank Dr. Lisa ma'am and Tarakeshwari ma'am, who have been, for them it has become a habit to conduct these events over the years. I think they have learned it, like how difficult it is, and they are trying to make it easier for us, especially who are not like me in academia, to learn a lot of things. So it's a wonderful setting, and like we have like light or knowledge, like it's which through which we see. And these kind of meetings are very good for a lot of underinformed clinicians, and a lot of things can be learned. Definitely these kind of meetings will have a significant impact on our practice. So what I have been seeing through is in last few years, most of the youngsters who are into the practice, so they have been treating very complex cases, and they are getting an opportunity to publish it or present it at various platforms of conferences what we are having across the country. And here I think what I would say is, because even we are discussing here, like I would urge and request the members of both the obstetric community and as well as rheumatology community to collect the series of these cases. And I would request the organizers of such kind of meetings to give more opportunities for the youngsters who have this series of cases, so that they can present it and we can have a discussion, debate and dialogue, and we can try to evolve a consensus of it. Now India has emerged a lot, so there is no dearth of clinical material. We have lots of clinical material in India, and the quality of laboratory standards are also significantly increasing. Post-COVID, the quality of laboratory standards, what we have been doing in institutions and as well as private organizations, have been significantly increased. And the quality of costs in doing these laboratory tests have been significantly coming down. And the NGOs and support organizations are also increasing. So IRA, we have lots of grants, especially if someone comes with a good proposal, and that if that is convincing to the research committee, so IRA can support in this kind of research thing. So now we have a clinical material, we have a good laboratory support, it needs an integration. So like madams, both Professor Lisa ma'am and Dharakeshwari madam has brought up the tone for it, and I think it's now for us to take it forward. I think whatever they have started, I think they have started as an education CME. I think it has to transform into a research. So initially the clinical form of research, then at a molecular level research, and now people are talking about single cell RNA transcriptomics, and they are not far. So in India we can start doing it, and the budgets will come if we come out with the good proposals. I think all these things if we do, and as a nation and as an organizations, we don't lag behind any of the major countries, and we need not look at the Western world to treat our patients. Because a lot of genetic data, if you see which has come last year from Indian genetic pool, so we see the single nucleotide polymorphisms, whatever they are, we are completely different. And if you see, the North India is different from South India. So the ancestral North Indian genetic pool is different from ancestral South Indian genetic pool. West is different, East is different. So lots of things to learn about. It's really an exciting future. I think we all need to be committed to collect data and interpret data and present data in such kind of forms, so that we are debated, we are questioned, and then later on with that we can come out with the best of our understanding of our own patients, and hopefully we will soon come with our own ideas, and we can try to give the best of our patients. And finally, and you see, both madam and sir has spoken about the challenges of treating poor patients. What I personally feel is it is equally challenging or more challenging treating a rich patient, or patient who can afford everything. So I think myself, Kirti and Vara, we know it's very difficult for them to convince for what we are treating. Because today, if we have to convince a rich patient or anybody who can afford for everything, you have to be thoroughly knowledgeable. With the available AI tools, so all these patients would immediately Google and they will come and cross-question you. Unless our knowledge is much superior to them and our experience speaks about it, we can't handle these patients. It's equally challenging, and the affordable patients are actually more sufferers. They don't stick to one doctor, they keep on moving from doctor to doctor, and ultimately they will mess up with their own health. So it is equally challenging. It's all about the mindset, what I feel. It's not about rich, poor mindset and the education. So IRA is celebrating Rheumatology Awareness Month. So most of the obstetricians are underinformed. They try to stop hydroxychloroquine. I think we need to educate them that you should not stop hydroxychloroquine. And as a rheumatologist, we also need to learn from them about what are the things which we need, when to ask for fetal echo, when to ask for uterine Doppler, when to ask for umbilical artery Doppler. I think these are all things we need to learn from each other. Thank you very much, and thank you, ladies and gentlemen.
with this we come to the end of the inaugural ceremony, but I would like to ask Lisa ma'am to give a small token of gratitude from our team to Director Sir for graciously taking out some time to attend the mod CME. So on behalf of the organizing team, I would like to thank all the esteemed dignitaries on the stage, and then we conclude the inaugural ceremony. Now we take a short break for 10 minutes. Tea and snacks are served outside, and we come back at 11:20 a.m. Thank you so much.
Hello, check, 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 1, 2, 3. Hello, check, 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 check. Hello, hello. Check, check, 1, 2, 3. Check, check. Hello. Hello, check, 1, 2, 3. 1, 2, 3. 1, 2, 3.
Surveillance tools. I invite Dr. Raj Kiran sir, Senior Consultant Rheumatologist and Managing Director of HRC, and Dr. PSR Gupta sir, Senior Consultant Rheumatology, to kindly chair the session.
Once again, good morning. We will start discussing about the fetal surveillance tools, which as a rheumatologist we need to know. And for this, to speak on this, we have Dr. Aarti Singh. She is obstetrician and she did her fellowship in high-risk pregnancy and perinatology. And she did fellowship in obstetrics ultrasound in Chennai. And at present, she is a senior consultant fetal medicine in Fernandez Hospital. And in next 15 minutes, she is going to enlighten us on this fetal ultrasound, and she will tell us how to use technology to identify pathology. Over to you, Dr. Aarti.
Very good morning to all. I will be discussing the fetal surveillance tool in autoimmune rheumatic disease, mother. And I will discuss only the point what rheumatologists need to know. So first I will start my topic with the question, is there is really a need for fetal monitoring in pregnancy complicated by autoimmune rheumatic disease? So let us see what the So let us see what the evidence, which is based upon the published literature, say. So let us see what the evidence, which is based upon the previous published literature, says. So we can see that pregnancy loss is more than 10 weeks is almost double. And and also we can see the early onset preeclampsia is 7 times, and FGR is almost 2 to 3 times, and preterm birth is 3 times. And on the top of that, there is neonatal lupus syndrome. And being a fetal medicine person, I can say it is a fetal neonatal Lucas syndrome. So now coming to the role of antenatal ultrasound in the autoimmune rheumatic disease. So it can be used for prediction, diagnosis and surveillance. So prediction of preeclampsia, preterm labor, diagnosis of FGR, preterm labor and many congenital anomaly associated with the rheumatic disease, and also for the surveillance of fetal growth restriction and complete heart block. So we can say that it plays the role in all level of prevention, primary, secondary and tertiary. So starting with the role in the early pregnancy scan, if we see SWOG guidelines, which is the standard guidelines for fetal medicine person, and according to that, the confirmation of viability is necessary in the high risk mother, and it should be established based upon the crown rump length. So apart from the establishment of the dating, we should do the detailed early anatomy scan between 11 to 13 weeks, 6 days. And when it comes to the prenatal aneuploidy screening, we can see we have two options: NIPT, non-invasive prenatal testing, and EFTS, which is called enhanced first trimester screening. So what is the pro and cons of the two testing? We can see for the NIPT, although it's a costlier, but detection rate is very high. It is 99.7% for the trisomy 21. And that's why it is suggested by the American College of Genetics and Genomics to be offered to all mothers irrespective of the low risk and high risk. But on the other hand, although EFTS, enhanced first trimester screening, has the lower detection rate of 90% for trisomy 21, but additional benefit of the prediction of the preterm preeclampsia. And here I want your attention, being a rheumatologist, if you are counseling the mother for giving the NIPT, which is the most which is suggested for the aneuploidy screening, here we have to discuss about the risk of no result. Because autoimmune disease, in autoimmune disease, there is chance of low fetal fraction leading to the no result or inconclusive result in 3 to 4% of the cases. So overall, if I can say in nutshell, in absence of financial constraint, it is reasonable to offer both NIPT and EFTS, so that to achieve the maximum level of detection rate for trisomy 21, at the same time enabling mother to get the early preeclampsia screening. So now coming to role of the ultrasound in second and third trimester, it will be the T5 scan, where we should look for the drug toxicity which is used in the disease management, and we should see for the unique fetal complication associated with the connective tissue disorder, and prediction of preeclampsia and prediction of preterm birth and the fetal growth restriction. So let us see what all to be seen. From top to toe, baby should be examined in the ultrasound, and if we see the drug toxicity, it is mostly the drugs which is used at present are safer. Except NSAIDs, there is chance of premature closure of ductus arteriosus when it is used more than 30 weeks. And apart from that, there is small association of steroid with the cleft lip and palate. And apart from that, steroid, azathioprine and cyclosporine can be associated with the fetal growth restriction and preterm labor. So now prediction of preterm birth, according to the SWOG guidelines, women with pre-existing medical condition that could affect the cervical connective tissue structure are at increased risk of spontaneous preterm birth. That's why they should be screened for short cervix at the time of the T5 scan by transvaginal ultrasound. Now coming to the antenatal surveillance and growth assessment, according to Society of Maternal and Fetal Medicine guidelines, which is recently published in 2023, according to that, there is no evidence to support the optimal approach, but whatever they have suggested, interval growth should be performed on monthly basis after T5 scan, or if it is not possible, at least 28 weeks and 34 weeks. Weekly antenatal surveillance by the modified biophysical profile should be started from the 32 weeks. And also, if it is a complicated SLE, then we have to we have to modify our frequency of the antenatal surveillance after discussing with the maternal fetal medicine team. So now coming to the growth assessment in the pregnancy with the autoimmune rheumatic disease. So for that, being a fetal medicine person, we have to identify first the baby as a small, then we have to discriminate between the fetal growth restriction and SGA. Why? We have to see in subsequent slide. We have to see whether it's an early onset or late onset growth restriction, and fetal follow-up based upon the Doppler finding. And according to Doppler finding, we have to do the stage-based management. So let us see what we fetal medicine person are doing. We are just like Taylor, we are measuring the baby at the different level of the body parts, at the level of head, at the level of the abdominal girth, and at the bone, and we are looking for the bone length. And what we are doing with this, we are actually plotting in the growth chart, provided your dating is correct. So here this mother, 30-year-old SLE mother, chronic hypertensive mother, and she has done anti-5 scan with us, but lost to follow-up. She was from the remote place, and suddenly she came at 34 weeks. We can see what happened here. So we can see BPD is normal, head circumference. Anything falling between this red line is normal. Only the abdominal circumference is less, making the effective fetal weight on the 8th centile. So what is the diagnosis? It is the small fetus. Why? Because effective fetal weight is less than 10 centile. That is the protocol. So now what you will do? Now you have diagnosed the small baby. What you will do? You have to segregate the fetal growth restricted baby, which is pathologically small, and also from the SGA baby, which is constitutionally small, because the prognosis is quite different in these two scenarios. So who will help? It is the Doppler. So which Doppler you will do? It is a multi-vessel Doppler, including the one maternal from mother side we are taking uterine artery into consideration, and from fetal side it is umbilical artery, middle cerebral artery, and ductus venosus Doppler. Now, so what you will do with this Doppler finding? Effective fetal weight less than 10 centile. We have to perform the arterial Doppler, uterine, umbilical, and MC. All are arterial Doppler. So based upon that, we have to find out whether the effective fetal weight is less than 3rd centile, or the uterine and MC or uterine umbilical Doppler is abnormal. So suppose these are all normal, that means we are dealing with the SGA baby, constitutionally small, and if it is yes, if all these are abnormal, it means fetal growth restriction. In simple term, we can say that effective fetal weight between 3rd to 9.9 centile with the normal Doppler is making the diagnosis of SGA baby. And if it is less than 3rd centile, irrespective of the Doppler finding, or between 3rd to 9.9 centile with the abnormal Doppler, also is making the diagnosis of FGR. So what we will do in the SGA, just we have to repeat the ultrasound every 2 weeks, and we have to deliver the baby, because you are dealing with the connective tissue disorder, we should deliver earlier according to your decision with the multidisciplinary team. But if it is FGR, we have to go one step ahead, and we have to integrate the venous Doppler, DV Doppler, and we have to do the staging. So let us see. This stage-based management is proposed by Gretarkos et al. In 2013. It is a milestone, we can say, is this article to be read by everyone. and they have proposed the stage-based management protocol, which is popularly known as the Barcelona protocol. And based upon that, this Doppler finding, we have to categorize the mother into different stages. First, stage 1, stage 2. Stage 1 means that is mild smallness with the mild Doppler change. Stage 2, it is the absent end-diastolic flow in the umbilical artery. Stage 3, it is the DV, abnormal DV more than 95th centile, and it is the reverse end-diastolic flow in the umbilical artery. And terminal stage is depicted by the absent reversal of A wave in the ductus venosus. So what you will do with this, we have to do stage-based management, and based upon the staging, you have to decide the monitoring plan and the mode and the gestational age of the delivery. So stage 1, it is 37 weeks, and we can go with the normal delivery, we can induce the labor. But second stage onward, we have to offer the cesarean section. So we can see how the this management will change according to the staging. So stage 4 is a terminal stage. We will try to deliver baby as early as possible according to your NICU facility. So in Fernandez Hospital, we are actually delivering at 26 weeks with the 750 gram is the lowest limit for us. So now it's looking very difficult to remember all the stages. So don't worry because Barcelona has also provided a software. Just we have to write in Google fetal medicine Barcelona. The calculator will ready to help you. And what we can see, we have to go to the fetal growth segment, and you have to enter your data of the gestational age, fetal effective fetal weight. It will give you the centile, as well as it will ask for the Doppler according to the staging. And we can see here it is a stage 1 Doppler and suggesting to do the delivery on the 37 weeks. So now here I want your attention. So this software are ready to use us, but at the same time we should be, being a clinician, we should be careful to consider the entire scenario, fetus as well as the mother. Suppose same mother, if she has SLE mother with the severe preeclampsia, comes to you at 37 weeks, and the software is saying to deliver at 37, will you go ahead? No, because we have to see the mother and fetus together. So it means, yes, software is ready, but we have to apply our own knowledge to deal with the case. Now coming to the unique fetal complication in pregnancy with the autoimmune rheumatic disease. Here you can see this mother, 27-year-old, gravida 2 para 1, no comorbidity, booked at 23 weeks at our hospital. So we can see what is your finding. It is the mid-facial hypoplasia, binder facies, and because of that we have done the extensive survey, and we found that it is a bilateral rhizomelic shortening of the long bones with the epiphysis stippling. We can see abnormal calcification at the epiphysis, which is the abnormal finding at the fetal life. We can see the premature calcification of coccyx, which should not happen in the fetal life, and also echogenic focus in the both ventricle, making the diagnosis of non-lethal skeletal dysplasia, possibly the chondrodysplasia punctata. So what you will do, if we see the causes of the chondrodysplasia punctata, it is a big list of the causes. It is a heterogeneous condition because of the inborn error of metabolism, disruption of vitamin K metabolism. Also it can be associated with chromosomal abnormality, and also the maternal factors like drug, warfarin, embryopathy, infection, hyperemesis gravidarum, bowel malabsorption leading to the vitamin K deficiency, and also it is associated with the maternal autoimmune disease. So what you will do, because the long list of cause, the evaluation is also very complicated. So we have to seek help from the genetician. But for us, clinicians should know the association of chondrodysplasia punctata to the autoimmune rheumatic disease is a diagnosis of exclusion. That's why we need to take the detailed history about the drug, hyperemesis, alcohol, family history. Autoimmune disease should be worked up. Immunological workup should be done to find out the cause. Targeted ultrasound to look for the other anomaly. Prenatal invasive testing in the form of the chromosomal microarray, and if it is required, it is the whole exome sequencing should be done to rule out a single gene disorder causing the chondrodysplasia punctata. Growth should be done 4-weekly, neonatal evaluation should be done, and recurrence and prognosis depends upon the type of the chondrodysplasia punctata. So now, if we see the chondrodysplasia punctata associated with the maternal autoimmune disease, and if you see this review article, they have clearly said that it is because of the transplacental passage of the maternal autoantibody. Mainly it is anti-RNA antibody, apart from the anti-Rho, anti-La, which is mostly associated with the SLE, mixed connective tissue disorder, and Sjogren syndrome. So what is the pathophysiology? It inhibits the vitamin K activity by targeting on the matrix GLA protein, and this protein is crucial. This protein is actually normally inhibit the calcium deposit formation in the soft tissue and cartilage. So what happens is there is inhibition of this protein, there is abnormal calcification at the cartilage level. So now we can see what happened to this mother who came just now. We have discussed immunological worker. We found that mother was ANA positive. Mother was totally asymptomatic, unaware about these findings, and it was turned out as the mixed connective tissue disorder with anti-RNA antibody strongly positive and the anti-Rho positive. So in this case, an otherwise asymptomatic mother was diagnosed with mixed connective tissue disorder due to the abnormal fetal scan finding. So if we see Fernandez Hospital data, out of all mothers with the anti-Rho positive, 7 to 8% are diagnosed due to the abnormal fetal finding. So often these mothers are totally unaware of the maternal disease status. So always fetal screening gives one chance to diagnose such case. So it is actually fetal monitoring plays a very crucial role for the management of the connective tissue disorder. So for we clinician, we should aware the association of fetal chondrodysplasia punctata and its association with the maternal SLE and the mixed connective tissue disorder. So, and when we'll suspect, when the negative report in the genetic analysis, absence of history of the teratogenic drugs and the maternal levels. Because it is diagnosis of exclusion, if everything is abnormal, we should think about the connective tissue disorder in the mother. So now coming to the next fetal complication. So now I will ask you, there is 3 fetal heart. Which one is abnormal? A, B, C. I want your opinion. Anyone, fellow? So I will disclose answer here. This is the normal heart, normal rhythm. At the same time, here we can see that, so in the second also we can see it is normal rhythm, but it is a first degree heart block and it is a complete heart block. So now how to go about pathophysiology, because lack of time I can't discuss. The risk of 1 to 2% if the mother is Rho positive, and risk will increase up to 10 times, 15 to 20% when there is previously affected baby. So now when we are dealing, we should have basic knowledge when we are dealing with the fetal bradycardia, which is the heart, when the fetal heart rate is less than 100 beats per minute in the 50% of the observation. It can be because of the sinus bradycardia, block, atrial bigeminy and heart block. So today we will confine to the heart block, and we can see the first degree where there is prolonged PR interval but 1-to-1 AB association. Normal heartbeat Second degree with the type 1, that is progressive lengthening of the PR interval, and because of that there is irregular heartbeat. Second degree heart block type 2, there is 2-to-1 conduction and there is slow heartbeat. Third degree, complete disruption of the AV conduction, AV atria and ventricle beat independently. So how to go about? The basic thing is that when we are dealing with the bradycardia, we should do the functional assessment of the heart, fetal heart, and for the first step, we have to look for the rate. For that, umbilical artery Doppler is the ideal one, and for the rhythm, it is the M-mode echocardiography and pulse wave Doppler. So we can see M-mode echocardiography how to do. For that, we have to place the M-mode cursor or the atria and ventricle, and simultaneously we can notice the atrial and ventricular relation can be established. So there is certain drawbacks with the M-mode because the quality is little bit poor, and we can see how to perform. Small clip. Now moving to the spectral Doppler waveform. So here the atrioventricular relationship is established in number of places, and most preferred one is the left ventricular outflow tract at the mitral and aortic valve confluence. So here what we'll do, with this we can establish the atrioventricular relationship, and at the same time we can establish the temporal cardiac event and various time interval, especially the PR interval, which we cannot see in the, we cannot make out with the M mode. This is the additional benefit of the spectral Doppler waveform. So we can see spectral waveform is closely resembles with the adult ECG, and we can see it is the atrial waveform E and A, and it is ventricular V wave. So we can see atrial waveform, P wave resembles with the A wave of the pulse wave Doppler. Similarly, QRS complex is the ventricular complex, and PR interval can be calculated. So how to calculate the PR interval? We have to incorporate the, we can see here by placing this, so we can see here it is the PR interval, the waveform, and we can calculate from the beginning of the atrial contraction to the beginning of the ventricular contraction. Normal PR interval 120 plus minus 20.
Running short of time.
Yeah, and more than 150 is making the diagnosis of the heart block. So now just few case scenario will take based upon the American College of Rheumatology guidelines, which is based upon the expert opinion and relatively small and non-randomized study. According to this, if patient will come to you with the SLE with ROLA negative, so you know what to do. You have to do special care and fetal growth monitoring and fetal surveillance from 32 weeks as we discussed. But if mother come with a ROLA positive,
Dr. Aarti, I think we need to quickly wind up.
will do. Okay.
In another few seconds.
So should I stop here?
So slides you have?
2, 3 or
yeah, please.
So if ROLA positive, apart from the routine care, we have to do special care because risk of the congenital heart block is 1 to 2%, and for that we have to start the hydroxychloroquine 400 milligram per day. Routine monitoring of the PR interval, although it's a controversial, although it's a ROLA positive, but the mother has no history of the previous baby affected. Consider PR interval, not weekly, at least at the interval of 2 to 3 weeks. Now, if the mother comes with the previous history of the congenital heart block, apart from the routine management, we have to do special care because here risk of the 15 to 20% of congenital anomaly in this case. PR interval should start, PR interval monitoring should start from 16 weeks. Frequency should be done on weekly interval from 16 to 26 weeks. Hydroxychloroquine should be started before 10 weeks. And roll-up intravenous immunoglobulin is actually controversial. So now hydroxychloroquine, you know about the role. First degree heart block, what you will do? We have to start the dexamethasone, oral dexamethasone, 4 milligram per day, although it's a controversial because according to the PRIDE trial, it is not well proven. And if it is the second degree heart block, so, yeah, ma'am, just, so When it is second degree heart block, dexamethasone, and we have to start dexamethasone and monitoring till 26 weeks at least, and discontinue dexamethasone if the heart block revert by 28 weeks. Similarly, I will not go in detail. Third degree complete heart block, we have to discontinue dexamethasone because there is no role for dexamethasone. And if it is heartbeat is less than 55, we have to start apart from dexamethasone, terbutaline, if the heartbeat is less than 55. Similarly, if the third degree heart block with the hydrops, what you will do? Dexamethasone should be started again apart from the terbutaline. So, and also we have to explain the poor prognosis. So, although everywhere I am telling poor prognosis, but there is no new hope of the new light of hope on the way, and this is the newly published study by the K. Nageswara from Rainbow Hospital, and what they have noticed, they have used the intravenous immunoglobulin directly on the baby, and they found that according to them, this is the first clinical experience on the fetal intraperitoneal immunoglobulin in the 5 fetuses with the immune-mediated carditis and conduction abnormality. Between 21 to 27 weeks, they have used that at the dose of the 1 gram per day. According to the fetal weight, they have given under ultrasound surveillance, and they have found that maternal, along with the dexamethasone also, they have continued, and they found that all fetuses demonstrated with the rapid resolution of the hydrops, regression of the endocardial fibroelastosis, and improvement in the myocardial performance. So, what they have suggested that although it's a very encouraging finding, although the outcome needs the further validation to use in the clinical practice, and other newly drug which is under experiment is the nivocalimab. So it is the FcRn inhibitor. It's underway of investigation to prevent the maternal antibody transfer in the early pregnancy.
Dr. Aarti, I think.
Thank you so much.
It was a wonderful, exhaustive lecture. I think quickly, if we have any one or two questions from audience. So, Aarti, just I will ask a few questions to make out this, because as a rheumatologist, because this is basically for the rheumatologist. So, as a rheumatologist, we are concerned with 2 things. One is one of our patients get accidentally exposed to methotrexate, and it will be a precious pregnancy for the patient. So, patient will be on methotrexate. So technically we need to tell that it's a teratogenic drug, they can't continue. But sometimes because it's a precious pregnancy, they continue. This is one setting where how frequently we have to look, do an ultrasound screening. So when we need to look into the ultrasound screening.
As you told, methotrexate is a category X drug. It should not be used, but somehow patient has used. So that time we should not, because patient is keen to continue pregnancy, will not ask for the termination. At the same time, we should look for the anti-scan, early pregnancy scan, then anti-scan 11 to 13 weeks, 6 days, and the 16 weeks also scan will be required, and then 20 weeks we have to do for the anomaly scan.
Okay.
And
so
after 4 weekly monitoring, and most...
So after 20 weeks only we can tell that this patient is out of methotrexate risk.
Yeah, but still we can't say, because 90% of the anomaly can be diagnosed till 20 weeks. Still 10% of the anomaly can be evolving lesions, can be diagnosed in 3rd trimester.
Okay. And second thing is you said about Dopplers, like uterine Doppler, umbilical Doppler, MCA Doppler, and ductus venosus Doppler. Yeah. So these are 4 things you said, and when actually we need to look, because in our clinical settings, especially if you are coming to the disease related thing, so we have 2 diseases to deal with. One is APS, the other one is lupus, because both of them, not much data from scleroderma, but these are the 2 diseases where we are mainly concerned about the placental insufficiency. So because we get a fetal medicine report from 3 to 4 pages, we actually don't know what to see. So what exactly we need to look for, especially in the uterine Doppler, umbilical Doppler, and when exactly these to be done, in the time frame?
Yeah, so actually according to the, just I told, it is the according to Society of Maternal Fetal Medicine guidelines published in 2023. According to that, after T5 scan, 4 weekly monitoring is required. And this all, we can't go with the one Doppler finding. We have to take the all Doppler finding together to make that conclusion. That's why it's a multi-vessel Doppler, and based upon that, we have to do the staging of the disease.
And when you look at AEDF and reverse endostolic flow, is it a time that you have a placental insufficiency completed? Do we still continue the pregnancy,
So,
or
just-
reverse endostolic
yeah.
flow?
So just now I have shown that table, stage-based management. So if it is AEDF, we can't go beyond 30 weeks.
So you
Because
need
that
to
is
take a decision of terminating.
No, it all depends upon if the baby present before viability, then we can, and it is a
Arati, I'll take this question. So Doppler, uterine artery Doppler, increased resistance. Then you see 3, umbilical artery, middle cerebral artery. Dopplers are fine. Only uterine artery Doppler after 3 weeks. See the growth and see how the growth of the baby is, and other Dopplers, umbilical and middle cerebral artery is becoming abnormal. Suppose you have an absent endostolic flow. Then you look at the profile of the mother, 30 weeks. Baby is 1 kg. And can she come weekly till it becomes reversal? We talk to the neonatologist. They say reversal is very bad. That means the outcome in the NICU may be difficult. So right time you do the NST, the cardiotocography we do. If the NST is fine, we buy time for the steroids and deliver. Doppler abnormality when it comes to AEDF, it will be cesarean delivery. So first you see the uterine artery Doppler as you asked. If it is abnormal, then you see the other Dopplers. If other Dopplers and the growth is normal, you follow 2 to 3 weekly. Usually they come up to 30-32 weeks. And then depending upon the entire clinical picture of the medical condition and the baby, then you take a call. Most of us, we deliver at AEDF. Suppose AEDF comes at 26 weeks and 500 grams. We discourage, to be honest. Sacrifice the baby and do a normal delivery. And then in the next pregnancy, we closely monitor in the interval period, do effective counseling, and take her through the second journey in a much better way.
And finally, madam, like how about this kicks? Like we ask mothers, because as a clinician, I think we can tell to our patients, like to observe this kicks, number of kicks, like you tell about to have around 10 kicks in 2 hours or something like that. So how we need to tell to our patients to observe this? Because our patients especially roll are positive. So weekly fetal echos we do. So in between, I think how we have to educate our patients to look for these things.
So 26 weeks onwards, 10 movements in 12 hours. Before 26 weeks, awareness of the fetal movements. Rest all doubts I'll do clear in the lunch period.
antenatal surveillance only should be offered to mother once your NICU is ready for the taking the baby. So 26 weeks is our lower limit.
Because short of time, we are closing the session. Even I have personal doubts.
One small announcement, we request all the speakers and chairpersons to please be mindful of the time to ensure a smooth conduct. Now we have a talk on the evidence of pharmacotherapy in obstetric APS. May I please invite Dr. Aruna, the Professor and Head, Obstetrics and Gynecology at Nilofer Hospital, to chair the session.
Is an additional professor, Department of Clinical Immunology and Rheumatology, Nims. MD Internal Medicine, PJ Chandigarh, DM Rheumatology, Nims Hyderabad. He had 35 national and international publications, peer-reviewed journals, chapters 10 in national level books. Special interests, inflammatory myositis and Takayasu arthritis, lupus. Welcome.
Yeah. Thank you, ma'am. I think as we are running time, so I also thought I should keep my talk short. So I will try for that. So I will be talking on pharmacotherapy, improving the outcome in obstetric antiphospholipid syndrome, the evidence. So the name, the evidence. So from since the morning we are talking about lot of evidence with lot of dilemmas, because as we know the trials in pregnancy are linked with many regulatory things, ethical things, very things. So I think what are the data available, I will be shortly saying in this talk. So I will talk about brief introduction. Before I talk about therapies, I talk about shortly about pathogenesis and anticoagulant therapy, which is a standard of care, and non-anticoagulant therapy. As in the morning, there is a note that the pathogens of APS is going from procoagulant state to inflammatory shape, saying it is a thromboinflammatory disease. So future targets, if I get time, I will cover. Otherwise, I just skip on that. So to start, OAPS, which is an obstetric antiphospholipid syndrome, is an autoimmune disorder associated with pregnancy morbidity, with recurrent pregnancy loss, preeclampsia, and fetal growth. And the defective placenta is the main important thing in pathogens of OAPS, which is a major cause of pregnancy morbidity. So throughout the stages of pregnancy, in the first trimester, from the start of implantation, which is a placentogenesis, to placental full placental growth and placental insufficiency the last trimester. So these are very important stages in OAPS pathology. When you come to clinical phenotypes of OAPS, we have two phenotypes, because when we call OAPS in total, we just call the pregnancy loss. But if you say the initial part of pregnancy morbidity and early miscarriages, which they call a lot of terms, if you go into literature, as early miscarriages, recurrent spontaneous abortion, recurrent pregnancy loss. These are all used interchangeably. So that's the reason for the data will be so heterogeneous when people has collected with different definitions. So the main pathophysiology is impaired invasion. So what are the trophoblasts, which invade very imperfectly because of this antiphospholipid antibody binding to them, and causing maternal spiral arteries which are not invasive. So the fetus doesn't get blood, so there will be early drops, so which lead to early miscarriages. The next phenotype is the late pregnancy morbidity, which we call with, which we see with either preeclampsia or placental insufficiency, which is nothing but the pathophysiology is impaired transformation of the spiral arteries together, where this inflammatory pathways come into action in the late mostly, so which are with complement and coagulation cascade activation. So this, I think all are familiar with this criteria, the Sydney criteria 2006. I think most of the trials use this definition to say who did not have previous thrombotic events, had only obstetric morbidity, and with laboratory criteria. These are across all the studies. I think this was the definition used. When we come to the newer criteria, which was touched in the morning, I just want to make a comment. They're all classification criteria for a single case. You should not use this to diagnose, because if you see which are the insert which I kept on the right side, if you see this, if you see the scoring, so if you see the initial pregnancy, which is the most common manifestation of APS, if you see the scoring is 1, but when you go to the late pregnancy complication, they are scored high. So this itself makes that. And literature says this is the most important. Some say this is most important. So this is a lot of confusion. So that is the we should not use in diagnosis. And the second is the antibody. So most think about IgM, which is scored only 1. And Igs are given more score. So again, we miss those cases. So in an individual case, I don't think we should use this classification criteria to diagnose. So coming to the pathogens, which I shortly, because we know from the rheumatologist here knows, I think it's a dual hit hypothesis when we talk about thrombotic APS, and it was talked mostly in obstetric also the same. But this is being debatable, and now this is getting clearer. If you see, the first hit is the presence of antiphospholipid antibodies, and it is a priming phase where the antibodies bind to different cells like neutrophils, platelets, and monocytes, and becomes a ground for a procoagulant state. In the second hit, which is mostly an inflammation, infection, malignancy, or pregnancy, where other than there will be more of beta-2, more expression on the endothelium, and the activation of this complement and mitosis, which is more important than the neutrophil. So they cause a second hit that causes thrombosis. But now the concept of obstetric APS is coming as why it is a single hit, because we see all obstetric APS patients that they will be just like obstetric APS throughout their lifetime. They may not develop thrombosis. This is all because the beta-2 expression on the placental tissue, either to the deciduo or tropoblast, they have high beta-2 expression. And we know this circular loop is an inactive stage of beta-2. When it becomes activated, it will be as an open loop. So when the pathogenic antibodies bind to this beta-2 complex and this bind to the beta-2 glycoprotein receptor on the cell membrane of the tropoblast, which is given here. So it causes then the inward cascade, so of the stimulation of TLR4 and NF-κB and release of cytokines. So the concept is becoming, it is a one-hit hypothesis in obstetric APS. And this is I don't go deep into pathogens. If you see, it can be pro-inflammatory, and complement in utero is very important in pathogens of APS, and this is the prothrombotic. And we know in a pregnancy itself, there are a lot of procoagulant factors increase and anticoagulant factors decrease, and because of addition of this antiphospholipid antibody, they have more tissue factor release from the monocytes, a lot of complement activation. This all leads to prothrombotic. And deciduous and trophoblast are very important, so with a lot of inflammatory changes, they all lead to pregnancy, morbidity, and placental insufficiency. And coming to the treatment proper, as I said in the previous slide, placental thrombosis, inflammation, and complement activation all play major roles in the pathogens of OAPS. And conventional treatment, we know adequate heparin dose with low dose aspirin. This therapy, as we know, it is only successful in 70 to 80%. So other 20% is what we talk about the inflammatory part of OAPS pathogenesis. And we know low dose aspirin should be started before conception, and low molecular weight heparin started at conception and should be continued throughout pregnancy. And coming to the evidence, so what we have with this combination in the literature. So if you see, most of them are literature from the recurrent pregnancies loss. So the late pregnancy complication, we don't have any much data, but we still we treat all OAPS as same. If they had history of a placental insufficiency in the past or a recurrent pregnancy loss, we give this combination. So if you see this study, which included 5 trials, which included 334 patients with recurrent miscarriage, and they reported a live birth rate of 74.3, and with either of them, either with aspirin or an heparin alone, it is 55.9%, saying combination is good in recurrent miscarriages. And coming to the next is the Cochrane review, it also says the same, that the combination is good in increasing the live birth than either of the therapy alone. And coming to the Euro APS, because a very big registry started in 2010, it has almost 2,000 cases of APS now, including lupus APS too. And this study says the miscarriages rate in this cohort is 38.6%, and the late pregnancy complication preeclampsia is 18%, and fetal growth restriction, which is 16.1. That is all about less than 34 weeks as per the criteria. And they also recommend the recommended standard of care treatment. They say it is almost 85%. Only 45% of them received the standard combination therapy of heparin and aspirin. And they say when they received either of them, the live birth rate dropped to 72.4, and who didn't receive, the poor birth rate almost to 49.6%. And coming to the guidelines, what guidelines say? So, URAR guidelines in 2019, they recommend, if you see in between lines, it is only recommend with a history of 3 pregnancy losses or more than 1 loss, that is more than 10 weeks, but that it doesn't include the late pregnancy complication giving this combination. But if you see that, they also say the recommendation is because of lack of evidence. So we don't have evidence in this part when patient had previous preeclampsia or placental insufficiency, whether this combination definitely helps them. And as you know, in the morning we discussed about asymptomatic. I think that is one more group what to do. The low dose aspirin in asymptomatic carriers, most of the guidelines recommend. And with history of thrombosis, we should definitely give a therapeutic heparin than a prophylactic heparin. And this is the dosing which we should give in different scenarios. The prophylactic dose is 0.4 to 0.6 mg per kg per day. And when they have thrombotic history, we should give 1 mg per kg per every 12 hours. And again, this one clinical dilemma which is superior. So whether low molecular weight or unfractionated. So if these are some studies published in 2005 and 11, they both says that the live birth rate is same. Either you use low molecular weight or unfractionated. And why we prefer low molecular weight? So it is one thing of the single time dosing and the longer half-life, and it has stable and predictable pharmacokinetic profile, and it has a lower anti-2A activity. There is lower against the thrombin activity than anti-10A activity, and there is no need for a regular monitoring, and lesser degree of bleeding, thrombocytopenia, and osteoporosis. But again, regarding the dosage, what should we use? Prophylactic heparin, what is the fixed dose? Again, the literature says variable doses. And when you come to low molecular heparin, this is not only about the anticoagulant pathway, which I highlight on the left side. It is all about, it can target the anti-inflammatory pathway. So like it can target complement, it can decrease a lot of cytokines. So it definitely helps in pregnancies in OAPS other than the anticoagulant action. And coming to the evidence, so because way back to 2004, I think these are the Jane Salmon, he is from Hospital of Newark. I think they are doing decades of work on OAPS, but as we know, the models are mostly mouse models, and we can't take everything of the mouse model to equal to a human placenta model. So in this mouse model, they had showed when they treated with heparin, with unfractionated heparin or an low molecular weight heparin, they definitely showed the fetal resorption rate is very less when the mice is treated with the black line, which is an APL IgG antibody. And this is the same thing on staining. So whatever being stained red, so these are all with hirudin and fondaparinux, they don't reverse, but with low molecular weight and heparin, they reverse the complement deposition, the decidue. And they also seen low molecular heparin on endometrial angiogenesis. And it also says definitely the low molecular heparin will increase the VEGF expression, because one part of pathogenesis is an impaired angiogenesis. So that is the reason they also showed in the mouse model that this heparin also increases the VEGF expression and improves the endometrial angiogenesis. And coming to the aspirin, so why do you think only heparin has actions other than anticoagulation? Aspirin too has actions other than acting only on platelet by reducing the thromboxane A2. It can reduce FMS like thyrokinase 1, which is an anti-angiogenic marker in preeclampsia. It increases the proliferation and invasion of trophoblasts by inhibiting its apoptosis. It can inhibition of that NF-kB pathway, it can inhibit lot of cytokines. So the aspirin also has lot of actions other than only the antiplatelet and antithrombotic action. And what about in delivery at puerperium? When you use low molecular weight heparin, so one is either we can continue throughout pregnancy, and 12 to 24 hours before elective induction cesarean and neuroaxial anesthesia we can stop it, or we can switch at 36 to 37 weeks to unfractionated heparin, and because it has a short half-life, we can stop 4 to 6 hours prior. And the Euro-APS APS cohort also says that the combination until the end of pregnancy showed no increased risk of major bleeding. And because we know a lot of catastrophic apply, everything can happen postpartum, so definitely we should advise to give heparin almost to 6 to 12 weeks postpartum. Again, the duration is debatable. The people talk about a lot of risk factors. So based on risk factors, if they're triple positive, if they had lupus in background, they should be given for 12 weeks, if not to 6 weeks. And the other part of my talk is refractive APS, so which is very important, which interested me in reading a lot on this, because if you see the 70 to 80% giving heparin and aspirin that everyone do, but this area is still underdeveloped because there are no lot of drug trials in this. So almost 20 to 30% they definitely fail the therapy. As I said, the late pregnancy complication like stillbirth, preeclampsia, they don't reverse with this combination. And the PROMISE study, which is a bigger study studying about the biomarkers in predicting adverse pregnancy outcome in lupus and APS, they almost showed 40% they fail and they have this adverse pregnancy outcome even if with this combination. And when I started saying, if you see this, why it is beyond thrombosis, this is one of interesting study published in 2015. They studied almost 580 placenta, and if you see the thrombosis is very uncommon, and the more common findings are impaired spinal remodeling, decidual inflammation, and they have villous trophoblast changes with increase in syncytial knots and decreased vasosyncytial membrane, and there's a lot of deposition of complement 4D. And the other study also says that only thrombosis is only shown in 50%. And there are a lot of cluster analysis being published in obstetric APS, and they say they have higher levels of peripheral TB, NK cells, saying that a lot of immune cells get activated in OAPS. It is not only about the coagulant pathway. And coming to the treatments, these are lined according to the evidence they have. So hydroxychloroquine evidence, and now RCT is abated, and the next is TNF inhibitor, which I'll be talking about the trial, which has recently published the impact trial, and the steroids, which are low dose being used by some groups, IV immunoglobulin, statins, complement inhibitors, and the last are plasmapheresis and dipyrimidine, so which I'll be talking briefly over. Coming to the HCQ, so as you know, we should continue HCQ in all lupus pregnancies because it has pleiotropic action. So HCQ, it can inhibit TNF production, it reduces tissue factor production, so it decreases thrombosis, it restores the endothelial function, and it disintegrates binding of beta-2 glycoprotein to trophoblast, and it reduces trophoblast alteration, and it restores annexin A5, which is an anticoagulant shield over the syncytial trophoblast, which physiologically present, and it inhibits complement X. So it has a lot of actions saying that usefulness in obstetric APS. So this is one meta-analysis published in 2025 August. It includes 7 studies which are observational retrospective cohort which had 750 patients. If you see the forest plots, the top one represents the live birth rate, the lower one is the obstetric complication. You can see it has definitely reduced, increased the live birth rate and decreased the obstetric complication with these odds which being shown. And these are the trials which are upcoming in HCQ, so which is the most trial awaited as a hypatia trial. So it's a prospective randomized trial of hydroxychloroquine to improve pregnancy outcome in women with antiphospholipid. So this is only one trial active now and recruiting patients, and with a lot of regulatory things because of doing a trial in pregnancy. And coming to the TNF in obstetric APS, there is an increased TNF alpha is involved in APL related placental injury with recurrent fetal loss, hypertensive syndromes and IUGR. And TNF is an inflammatory cytokine. It regulates a lot of hormones which are important for a normal pregnancy, like secretion of prostaglandin, HCG, serum immune, placental prolactin, progesterone. These all will affected by with the TNF with placental formation and embryonic development. Coming to this trial, because the same other which I said before, Janie Salmon, I think almost 2 decades back, they did a mouse in vitro study which is with a mouse model. This is the left up figure. What they did, I think, to the pregnancy APS model, they have injected pathogenic APL, and you can see within 8 hours there's a peak in TNF levels, and they showed the same thing, the staining with a non-pregnant and pregnant with an APL treated mouse. After this explanted of placenta, they show a lot of TNF expression. So later they went to do another experiment to see with the fetal resorption is more with APL antibodies and with TNF presence. In the TNF absence, definitely there is a lesser fetal resorption. They went ahead seeing fetal TNF blockade. So they definitely showed anti-TNF blockade has a potential therapy in pregnancy complication of APS. So after this, there are studies which has a case in 2019. So where they treated with the refractory OAPS patients which already had treated with low-molecular heparin, aspirin and HCQ, still had recurrent pregnancy complication. They have given adalimumab in 16 and cetuximab in 12 with a good obstetric outcome. The same other which did in vitro study before, and they did this trial of an impact study which is mostly talked now with the cetuximab, which is a single arm investigator initiated, and they selected cetuximab because it lacks an FC part of it, so it doesn't cross placenta. So for them to get a regulator upload somewhat easy because the crossing the placenta is less, and it included patients with previous preeclampsia, previous placental insufficiency, and they gave cetuximab in addition to the usual standard of care in pregnant women, and they also took one more layer with high risk patients which are LAC positive, which we know that they have high pregnancy outcome between 8 to 28 weeks, and they have given the dosing of 400 mg at 024 and later followed by 200 mg every 8 weeks. And they recruited almost in 7 years. So it says that how difficult to get patients into a clinical trial in pregnancy. So in the 7 years, they recruited almost 51 patients and 45 were included. And adverse pregnancy outcome happened in 9 of 45 patients. And if you see, they had a composite adverse outcome, which I told fetal loss more than 10 weeks of gestation or severe preeclampsia or placental insufficiency less than 34 weeks, which I said the data is very less in this area, so they selected these people with LAC positive. So that is more making them more risk profile to have an adverse pregnancy outcome. And they definitely showed almost 20% adverse pregnancy outcome. They compared it to the historic cohort. That's the promise cohort, which showed almost 40% adverse pregnancy outcome, saying that it is definitely useful. And the median gestation also improved in this patient to 36.5 weeks. A neonatal survival to hospital was almost 93%. And coming to the next steroids, as you know, it suppresses immune activation, inflammation. And EULAR recommendation also says in refractory cases you may try in first trimester less than 14 weeks, but the evidence is limited. But again, the data says it can be used, and in a recurrent miscarriage it may be helpful in early trimester. But high dose steroid group, definitely they had more risk for preeclampsia, gestational diabetes. Coming to IV immunoglobulin, and I surprised to see that study in neonate which were done. So the IVIG, which was, we know it has immunomodulatory effects both on cells and cytokines. It also being said as an add-on refractory. This study was published in 2024. They had very smaller studies, but they say it is a randomized controlled trial. It almost included 366 APL positive women. The primary outcome was looking for live birth rate and miscarriages, and definitely it showed, but Again, the dosing, everything is very complicated in different studies, and the numbers are very small to conclude. That is definitely helpful in. And some used throughout pregnancy, some used only in the first trimester. So the dosing is totally different when they use IV immunoglobulin obstetric APs. Coming to the statins, the protective effect of statins on endothelium was studied with pravastatin. So the main mechanism is by improving this uteroplacental flow. Pravastatin helps in improving the circulation to fetus and helping in preventing an adverse pregnancy outcome. So they had showed in smaller studies both with pravastatin and simvastatin. And complement as such, as I showed in histopathology studies, there is a definitely lot of deposition on trophoblast and residua, saying which plays a major role. But in OAPS, the data is very less when compared to the other catastrophic apnea. And coming to the recommendation, so I take one minute of time to say about the recommendation. If you see with the recurrent EPL, all the guidelines from the Euler, British Society of Hematology, the Royal College of Obstetrician, ACR, they all recommend. But when you come to the late, and they recommend but with no evidence, and with the previous thrombotic episode, they should be given with a not a prophylactic dose, it should be given a therapeutic dose. And the non-crater which we are talking in between, most of the guidelines about low dose aspirin. And the refractory, this is one no data, so EULAR says you can give steroids and IVIG, and ACR only says give HESIC. And future targets are many, but the trials in thrombotic APs are much more than obstetric APs across different cells. I think the Carlson is one study which is now going with the in vitro study first in OAPS. And these are the other targets, because in the morning we are talking about the 5 domains of beta-2 glycoprotein. These are all mouse models, but not into anything into a clinical trial. And the future targets. So the placenta-centric immunotherapies are now mostly talked about that precisely target key inflammatory nodes. The more important node which I told the TLR4, NFKB signaling with all the inflammatory cells. So the shift from anticoagulation to anti-inflammation, from systemic to local, from broad spectrum to precision. So these are the future targets being now people talk about these pathways to counter. So to conclude, management of obstetric APS remains guided by observational data and expert consensus rather than robust clinical trials. There's a paradigm shift in pathogens from immune-mediated placental dysfunction to thrombosis rather than thrombosis alone. And the combination of low-dose heparin and heparin with aspirin is a cornerstone of OPS care, which is refracted in 20 to 30% with predominant data in early pregnancy loss. And observational data says HCQ may enhance live birth in refractory cases. And TNF inhibitors is one hope in refractory cases with a clinical evidence from impact study. And glucocorticoids offer limited benefit, and evidence is upcoming. As I said, there are a lot of cells being now studied in obstetric APS. So you may see a lot of targeted drugs, but again the pregnancy itself is a exclusion for most of the trials. So that makes everything to get a trial in pregnancy is more difficult. Thank you.
Thank you, Dr. Anil. It is crystal clear. I think no questions will come. Lack of time. Any questions, one or two?
Sir, so I have one case of obstetric APS. She's gravid of 14, abortion 13. All are miscarriages between 16 to 20 weeks, mid-trimester, and genetic anomalies are ruled out in that case. She has already taken HCQs, ecosprin, steroids, and on prophylactic heparin. Still she is not continuing. This pregnancy I have given her therapeutic dose of heparin, but in case this also goes as a miscarriage, then should we go for cetrizumab, sir?
I think it is not available one, and
what should be the
not available, and we don't have this combination. Different combinations being tried. Some studied statin. I think cetrizumab not available in India for that.
So no other option.
No other option, because you tried everything. You said you have increased the dose of heparin to therapeutic, and you started steroids. So I think IVIG is one, but again to comply with the cost and everything, giving monthly something. Patient, it should be a patient and a physician shared decision.
Thank you.
Sir, in obstetric APS, in some special conditions, when patient cannot take heparin throughout pregnancy, is it safe to offer acetrom between 14 to 32 weeks?
I think again the same, because people say because of teratogenicity to stop it before 6 weeks and to convert to heparin. But again, I think I too did in few cases before, but the data says you should use heparin because of the other actions it has, not only the anticoagulant pathway action and inflammatory.
Thank you, doctor.
Can I ask? What about, recently came across a patient who is allergic to acrospin. So are there any options for her? And how come, and in settings of intrauterine bleeding in the early pregnancy, there is a lot of concern from the obstetricians that we should, in people who are on antiplatelets and heparin, to stop this. So,
but ideally antiplatelets are stopped between 32 to 35 weeks. Most of them do that, and heparin people continue.
No, early pregnancy and intrauterine bleeding. So do we need to stop or decrease?
I don't think, sir, any other options we have. Yeah.
Thank you, doctor.
We move to the next session. Now we have a talk on the obstetrician's challenges in the pregnancy journey of a patient with OAPS. I would invite Dr. S. Nayan Patel to kindly chair the session. He's a consultant rheumatologist at Star Hospital.
Good afternoon, everyone. The next topic is on obstetrician's challenges in the pregnancy journey of an obstetric APS patient, for which I invite Dr. Rama V, who is a consultant obstetrician at Fernandez. Over to you, ma'am.
Good afternoon, everyone. I'm Dr. Rama. I'm a consultant at Fernandez Hospital. So I would like to begin with a woman many of us would have met, perhaps in different names and different places, but a same story. A 30-year-old lady, educated well, married for 5 years, and she has no live child. She had one miscarriage at 8 weeks, then another stillbirth at 24 weeks, after that another miscarriage, and another baby lost at 23 weeks, despite treatment. Now, by the time she reaches us, she does not come with only reports. She comes carrying a lot of grief and comes with her hope. So our rheumatology colleagues have explained the importance of the antibodies, the classifications, and the pathogenesis and the medications. Now I want to talk about something which is equally important, and that is how to convert this into a healthy pregnancy journey, because as obstetricians, our challenge begins where the lab reports end. So many people still think that the obstetric APS is only recurrent miscarriage, but the definition is incomplete, as we have already seen. It is fundamentally the disease of the implantation, the placentation, and maternal vascular dysfunction. So we need to have a pregnancy morbidity in the presence of antiphospholipid antibodies, in the absence of the other 5 APS domains as mentioned. This has already been discussed. What I want to suggest, what I want to tell is, when the losses are early, we should rule out the other causes, which could be genetic, structural, or infectious causes, before categorizing them as APS. And the scoring, which has shown that it's because of the severe preeclampsia or placental insufficiency before 34 weeks, it carries highest weightage. This reflects that the central role of placental disease in APS. Dr. Fani has already discussed the pathogenesis of the obstetric APS. What I would like to emphasize in this is mere presence of the antibodies does not need importance, except when they are significant titers or when they cause a previous morbidity. But in the presence of a second hit, which is the pregnancy, which is the strongest physiological second hits, there can be placental implantation failure, inflammation, and altered coagulation together, which can unmask the clinical disease in the form of preeclampsia, fetal growth restriction, or fetal loss. So why does this matter to us? This is because this condition is devastating and because it is treatable. So without diagnosis, the women may lose many pregnancies before even we recognize the pattern. Even with treatment, the risk remains higher than the general population to both mother and the fetus. So from a mild livedo reticularis, the complications can go up to life-threatening thrombosis, and from the fetal, it can range from miscarriages to term stillbirths. So what these women need is not just a routine antenatal care, but they need a strategic care, planned care, and a vigilant care. So returning to my patient, as I said, she is para 2 live 0 with A2, and in her first pregnancy was an 8 weeks missed miscarriage, followed by a 24 week stillbirth, then at 6 weeks missed miscarriage again, and now after 3 pregnancies she was evaluated. Parental karyotyping was done, which was normal. ANA profile was negative. APLA testing was done, and it was found ACL IgG was medium positive. The rest of the profile was negative, but it was not repeated after 12 weeks. So this time when she conceived, she was started on ecosprin 150 milligrams. 40 mg low molecular weight heparin was started, but on alternate days. Now the LDA was stopped at 19 weeks because she was planned for a cerclage, and then they didn't restart it. So at 22 week scan, it was found that there was an early onset FGR, oligohydramnios, and she had an IUFD at 23 weeks. So now we ask ourselves, did the placenta fail? Yes. But did the system fail also? Definitely yes. Because this is the greatest challenges which we face, that is the fragmented care. So what happens is they have started the aspirin, they have started heparin, but at an ineffective dose, then which was stopped for a procedure, but it was never restarted. So the problem is no one has owned the patient or the care plan. So that is why the multidisciplinary care is very important, to have a formulated care plan for a better outcome. So later she was referred for further evaluation and management to Nims, where she again had a repeat APLA testing, and this time the lupus anticoagulant was positive and ACL beta-2 glycoproteins were negative. After 12 weeks, when it was repeated, ANA profile was 4+ positive with homogeneous pattern, anti-DS DNA was negative, ACL both IgG IgM were positive, beta-2 IgG IgM were positive, and LAC was positive, making her a triple IPS positive, and her anti-SSA SSB were negative. So as it was already discussed by Dr. Varaprasad, it is important that the tests have to be done in the way it has to be done, and the standardization is very important to get the accurate results for better planning. So this is the most powerful intervention which can help in a better pregnancy outcome. So this is where we do the risk stratification, we optimize the comorbidities, formulate a clear plan after realistic outcome discussions with the couple. So as we all know, not all positive antibodies are equal. So a low risk isolated transient antibody positive is not the same as a high risk antibody profile like a persistent lupus anticoagulant or double or triple positive antibodies. So the risk stratification helps in avoiding under or over treatment for a lady, and as evidence suggests that lupus anticoagulant positivity is associated with thrombosis, and beta-2 glycoprotein 1 positivity is associated with obstetric complications. This has to be kept in mind. So this was a pregnant study which was published in 2017, which was a multicentric retrospective cohort study involving 750 pregnant women with primary APLA on LDA and prophylactic heparin, and the antibody profile based complications were noted, where they found, this is where the high risk APLA came into pictures. As the positivity increases, the complications also increase, and the similar way the live birth rate also decreases when it is a high risk profile antibodies. So apart from the antibody profile, we need to also screen for the and also manage the comorbidities. So we had to screen for other autoimmune disorders, especially lupus, and confirm remission before they embark on pregnancy. We should screen and control hypertension, diabetes, or any other thyroid disorders, if any. Optimize the body mass index with appropriate nutritional counseling and active lifestyle management wherever required. So when we come to formulating a care plan, it should not be something which is copied blindly. So we need to ask 3 questions. Has she had a previous thrombosis? Has she had a previous obstetric morbidity? And what is her antibody profile? So these 3 answers usually tell us what she needs: aspirin alone, prophylactic LMWH, therapeutic anticoagulation, or escalation of therapy, which has already been discussed by Dr. Fani. So this is just a slide on the same. This is the EULAR 2019 matrix. So if the woman is a high-risk antibody profile with no prior history of thrombosis or any other pregnancy complications, then also low-dose aspirin is to be considered preconception and to be continued in pregnancy. In case of obstetric APS, then low-dose aspirin plus prophylactic heparin to be considered. And if there is a clinical non-criteria APS, as Dr. Akshay mentioned, we have to individualize whether it's only LDA or LDA and prophylactic heparin, after taking into the previous obstetric histories and the patient profile. When some women, as we already know, that they do fail despite doing everything, in refractory APS, the options include heparin to making it to therapeutic dose, hydroxychloroquine, low-dose prednisolone, IVIG in refractory cases. But what is more important for us as obstetrician is, do not manage any refractory APS without involving the rheumatologist. So then comes the hardest part, which is the counseling. This is where our textbooks end. The patient looks at us and asks, will I lose this baby also? and then there is no guideline statement which we can give them. So what we have to give is not a false assurance, not just cold statistics. We have to tell them the truth, but with some hope. So we tell, yes, your pregnancy is high risk, and we need close monitoring of you and the baby. These are the real risks, but with adequate treatment, there is success definitely which has been shown. So we have to involve the family, we have to involve the partner in the decision. And it is always, because it's some women may need daily injections, it is important to teach them how to self-inject themselves, how to safely dispose the needles, which we will not get in the textbook. So these are all the practical points which we need to emphasize on. And most important thing is, being available is just not an option for us at this moment. It becomes a reassurance to the mother. So once they are pregnant, the antenatal care is not, like I mentioned, not routine antenatal care. So we closely watched actually the placenta in real time. So at every antenatal visit, we have to have a purpose, that is the BP increasing? Is there any proteinuria developing? Is there any, is she gaining any excess weight? Is she taking her medications is she able to take her medications? And are there any symptoms of DVT? In the similar way, we monitor the fetus. As already mentioned, we do an early enhanced first trimester screening, followed by a detailed TIFA scan where we check the uterine artery Dopplers. Mind you, a normal 12-week or a 20-week scan doesn't imply that this is a very benign pregnancy and that everything will be fine, because APS pregnancies are known to silently deteriorate. That's when this growth surveillance becomes important, and we start surveillance from the period of viability. In our institute, it's 26 weeks, so we start surveillance from 26 weeks, every 3 to 4 weekly, depending on the size of the baby, whether it's an average size baby or a small for gestational baby. Then we include Doppler studies if needed. So the growth monitoring becomes central in fetal monitoring. And after 32 to 34 weeks, after individualizing the profile in the lady, we do weekly or bi-weekly non-stress test for the fetal surveillance. So our mother, now she was preconceptionally diagnosed as triple APS positive and was started on HCQS and low-dose aspirin and periconceptional folic acid. She was booked with us at 6 weeks with a BMI of 27. After confirming viability, low molecular weight heparin was started at 40 mg per day, and her baseline investigations were normal. She continued to have a uneventful second and third trimester, and the fetus was serially monitored with growth scans, which showed an average for gestation age baby around 40 centile at 35 plus weeks. So next comes the challenge of when to birth them. So timing of birth is often a compromise between delivering preterm or sacrificing the placenta. So that becomes, sometimes it's too early and we have to stop LMWH, increasing the thrombosis risk. Or sometimes it's too late when there is risk of having a bleeding during surgery. So when do we have to deliver early is when there is worsening of maternal condition, like developing severe preeclampsia or accelerated hypertension requiring multiple antihypertensives, or when there's fetal compromise, either in the form of fetal growth restriction with abnormal Dopplers or a non-reassuring fetus status. In the absence of any obstetric indications for early delivery, then we usually schedule delivery at 37 to 39 weeks depending on the risk profile. And cesarean is indicated for obstetric indications. So this is another challenge which we face, and one of the commonest practical failures in APS patient, because we have made the diagnosis, we have given the right treatment, suddenly, and the pregnancy is reached term, and suddenly the lady sets into labor in the midnight, and no one knows when was the last dose of heparin. So a clear handoff between the obstetrician, the anesthetist, and the nurses is very important to avoid any delay in neuraxial analgesia or any emergency cesarean deliveries and delayed postpartum thrombosis. All this can be avoided. Therefore, every lady who's on anticoagulation should have a care plan documented for anticoagulation at 36 weeks as to when to stop heparin, when to come in, what to do when the labor sets in. We should educate them to stop their usual dose of heparin if they have any symptoms of labor and come to the hospital. So this is the American Society of Regional Anesthesia guidelines for peripartum anticoagulation. In case they are on aspirin and they come in labor, then there is no limitations for giving the anesthesia. But if they are on prophylactic UFH of less than 10,000, then it's 6 hours to hold. And prophylactic LMWH is 12 hours. If they are on therapeutic UFH, then we hold for 12 hours and assess the coagulation status with APTT. If they are on therapeutic LMWH, then it is better to hold for 24 hours for neuroaxial anesthesia. it's as important to restart the anticoagulation as to stop it, because the risk of thrombosis is very high. So usually after an uncomplicated vaginal delivery, 4 to 6 hours later, we can start the restart the anticoagulation. And in case of cesarean, 6 to 12 hours, depend on making sure that there's no ongoing bleeding or there is no ongoing any risk of bleeding which is there. Otherwise, the guidelines say for prophylactic UFH, it's 4 to 6 hours, and for prophylactic LMWH, it's 12 hours, and therapeutic UFH is again 6 to 12 hours, and therapeutic LMWH is 24 hours after neuroaxial placement, or 4 hours after the catheter indwelling epidural catheter removal, whichever is later. So sometimes we do get surprises. Some woman is on full anticoagulation and she comes in labor. At that time, it's always important that we document the last heparin dose, avoid regional anesthesia, check for coagulation status, and for pain relief for vaginal delivery, opioids can be used, and for emergency cesarean section, general anesthesia may be given. To some extent, the protamine sulfate does partially reverse the LMWH effect, and adequate transfusion of fresh frozen plasma if needed. And we should always be prepared for bleeding intra-op postpartum hemorrhage because of the risk of bleeding in these ladies. And those who are on warfarin, as already mentioned, if they are on warfarin for high-risk thrombotic APS, then it is better we bridge them at 36 weeks to UFH or LMWH so that these surprises are less in labor. So for Our Lady, we stopped decosprin at 36 weeks. A planned induction was made at 37 weeks. LMWH was stopped 12 hours before admission, and labor was induced with Foley's mechanical dilator. But an emergency cesarean section was done because of her maternal request, as she was very anxious. A girl baby of 2.69 kg with good upguards was born, and she is doing fine. The LMWH was restarted 12 hours post-delivery and was continued till 6 weeks postpartum. So now we move to the most overlooked phase. Most of us relax once the delivery is over. Okay, everything went fine, it's all fine. But what we forget is almost 6 times higher risk of thrombosis for the mother. So it's important that we educate about the hydration, ambulation, compression stockings were available, and restarting anticoagulation at the earliest, and to continue at least 6 weeks to 12 weeks depending on their risk profile. It is our job to reassure the mothers that these drugs are compatible with breastfeeding and they should not be stopped. Also, it's very important that we screen them for mental health, because a woman with so many repeated pregnancy loss, even if she is delivered and had a healthy child, will have a lot of enormous burden of this on her emotional health. So we have to be watchful about postpartum depression. At discharge and follow-up, it is important to educate about the contraception, and there is a theoretical risk of having thrombosis with the oral contraceptive pills, but intrauterine devices are safer for these women. And it is important to tell them about follow-up with rheumatology, as obstetric APS can progress later in life to thrombotic APS. So it's important to educate them about the symptoms which they need to be watchful about. So this is an entity which I would like to talk about to the obstetricians, as most of us will not know. So it is always better we have this entity in our mind, because it closely resembles sepsis, and delaying in diagnosis and management can be very catastrophic, as the name suggests. Catastrophic APS affects 1% of the APS cases, with an overall mortality of almost 36%. And there's rapid onset of symptoms with widespread coagulopathy with thrombosis of the large and small vessels, resulting in multi-organ failure very fast. And there's no, the proposed treatment is with anticoagulants, corticosteroids, plasmapheresis or IVIG, but in refractory cases, immunosuppressive therapy has been implicated. So the key messages from my talk, what I want to give is few do's and don'ts for the obstetricians. So what we need to do is to verify the diagnosis carefully and identify the antibody risk profile. Use preconceptional counseling to align the treatment, comorbidity control and pregnancy timing. Monitor the fetal growth and placental function proactively and not reactively. Document a written anticoagulation plan for delivery and postpartum restart. And what is important is not to do. So do not equate all pregnancy losses with APS. Do not assume normal early scans will give you a guarantee of a benign third trimester. Do not ignore postpartum risk of antenatal care went well, so it doesn't have any risk. And do not manage refractory disease without involving the rheumatologists. So I would like to conclude. As obstetricians, we cannot remove every risk, but we can remove delay, we can remove confusion, we can remove fragmented care, and definitely we can replace fear with a plan. And sometimes that is all the difference which will make between another loss and a baby in the mother's arm. Thank you. These are my
Thank you, Dr. Rama, for elaborating on how an obstetrician deals with APS patients. One quick question from the audience. I don't see any questions, so I would like to close the session in view of lack of time. Thank you.
We now move to the next session. That will be a dialogue between the rheumatologist and a fertility specialist. I'm sorry. In this one, we would explore the latest ULR updates on the usage of drugs, that is from the NSAIDs to biologics in pregnancy and lactation. May I invite Dr. C. Prabhakar Reddy, sir, Additional Professor in the Department of Clinical Pharmacology and Therapeutics, to kindly chair this session.
Good afternoon, everybody. For the next session, I'd like to call on Dr. Vijay Lakshmi Prasanna Parimi, Professor in HOD, Department of Clinical Immunology and Rheumatology, ESIC Medical College and Hospital, Hyderabad. Madam is Assistant Editor at Indian Journal of Rheumatology, member of Reproductive Rheumatology, Special Interest Groups, IRA. So I'd like to invite Madam to deliver the next talk.
A very good morning to all of you. Thank you, sir, for the kind invite. At the outset, I thank the organizing team for making me a part of this program. So, whenever we are seeing a patient with suffering with rheumatic musculoskeletal diseases and planning pregnancy, as a rheumatologist and slides are not moving. So as a rheumatologist and definitely as an obstetrician, we extend our care in order to have good pregnancy outcomes. This care is very much important because the pregnancy outcomes, both maternal and the fetal outcomes, they depend upon the disease activity and also the fetal drug effects on the fetus. So can somebody? So this is a critical aspect of care of these patients, and the management of these patients is definitely a challenging task to both a rheumatologist and an obstetrician. In the past, our treatment decisions are mainly fear driven, and they were not up to mark in achieving good fetal outcomes because these decisions were mainly wandering around the adverse effect profile of the drugs which the mother used. We are more concerned about this harm over the fetus. But as the newer treatment approaches have been evolving, now we are focusing and moving into an era where we are targeting the maternal disease activity to get it controlled. So treat to target strategy is the one which we are following now. In order to attain this strategy, we have to have the maternal disease to be in remission or at least a low disease activity even before conception, because uncontrolled maternal disease is a key determinant of adverse pregnancy outcomes. So if you look at the old ULR thinking, that is at the initial guidelines, which has mainly concentrated on the drug safety, and later on, though it has discussed about balancing the disease control and the fetal effects, but the main decision in treating these patients wandered around the fetal teratogenicity. This was a key determinant in making the decisions, and both these guidelines predominantly concentrated on avoiding harm to the fetus by restricting drugs which are not safe. But this current 2024 update has given a comprehensive drugs which you can safely use during the reproductive journey.
And as we look, this treat to target is highly emphasized in this 2024 update. So if you look at the evolution from drug restriction to optimized disease control is a major treatment paradigm shift in addition to early and regular counseling of these couple or the patients who are suffering with these rheumatic musculoskeletal diseases. In addition, this update has also clearly categorized what are the safe drugs, what are the drugs which can use conditionally, and what are the drugs you have to stop or avoid during planning pregnancy or during antepartum period. And it has expanded the list of safe drugs, and it has given a trimester-based drug strategy. Biologics which were once feared of for using during pregnancy is no longer a taboo nowadays. And this guidelines also has incorporated the male exposure especially when a male is planning to become a father. And it has given drugs which can use safely during the lactation period in addition to the multidisciplinary care in a specialized clinics. So EULAR has clearly emphasized to treat the maternal disease actively while planning the pregnancy and during the entire course of the pregnancy and in the postpartum period rather than withdrawing the therapy. So it has prioritized the optimized disease control in these updates. EULAR became more restrictive in NSAID usage because there were no subsequent RCTs, and it has clearly recommended to use NSAIDs only if required to control the disease activity. So when to use them? It has clearly recommended to use them for a very short term, that is for 7 to 10 days if required clinically, and their use should be restricted to early pregnancy, and you have to avoid the prolonged usage of NSAIDs. And in the couple who are having difficulty in conception, in the preconception period also, you can think of avoiding these NSAIDs. And it has preferred to use short, non-selective NSAIDs with a short half-life, especially ibuprofen, which has a good reassuring data, followed by diclofenac. And it has clearly asked to avoid COX-2 inhibitors and avoid all types of NSAIDs after 28 weeks of gestation. So you have to use NSAIDs if at all required for a short term, that is a non-selective NSAID, restrict its use to the early pregnancy and strictly avoid after 28 weeks. Similar to NSAIDs, EULAR also became restrictive to the glucocorticoid use, though the older guidelines have advised on a low dose of steroids. EULAR 2024 has clearly given a target dose, which has given precisely the dose of the steroid which has to be used, and it has clearly mentioned to use a very low dose of steroid, that is less than or equal to 5 milligrams of prednisolone per day or its equivalent, and it has clearly advised to avoid the chronic maintenance use. However, you can think of using high dose of steroid, especially if there is a severe flare or on organ threatening disease in the mother. So transient use with a caution is clearly focused in EULAR 2024 guidelines, and it also has advised to transit to early safer medications which are steroid sparing. And regarding the conventional synthetic DMARDs, there is no major change as of the safe drugs to continue. Hydroxychloroquine at a dose of 400 milligrams, chloroquine, azathioprine at 2 mg per kg, sulfasalazine along with the folic acid, calcineurin inhibitors you can safely continue throughout the pregnancy. And it has very much emphasized the contraindicated drugs. Methotrexate, mycophenolate and cyclophosphamide are clearly a contraindicated as they are category X drugs during pregnancy planning and during antepartum period. But the newer point which was incorporated in this update is you can think of mycophenolate usage or a cyclophosphamide usage in second and third trimester if the patient is having a severe refractory disease. Though leflunomide is not considered as a teratogen, but EULAR has strongly advised to avoid leflunomide. When a patient is planning pregnancy and on leflunomide, it has advised to stop the drug at least for 5T half-life, that is 3.5 months to 4 months before becoming pregnant. and you have to monitor the drug level of the leflunomide, and the drug level should be at least less than 0.02 milligram per deciliter at least for 2 or 3 menstrual periods. If the patient becomes pregnant on leflunomide, you have to go with a cholestyramine washout. So you have to treat the active disease throughout the pregnancy. Do not stop any of the effective compatible conventional synthetic DMARDs, because disease control is more and more appropriate as compared to the theoretical drug risk on the fetus. So the updates on the biologic DMARDs are really useful clinically. So before we understand this update, we will go through how these biologic molecules are transferred across the placenta from the maternal side to the fetal side. We all know that small molecules diffuse passively, but larger molecules like biologics, they need an active receptor mediated transport. So if you look at the transfer, IgG is the only immunoglobulin which can cross the placenta from the maternal side. So this IgG molecule at a physiological pH, it cannot bind to the neonatal Fc receptor, but once it is endocytosed in the acidic pH in the placenta at the syncytiotropoblast level, it binds tightly to the receptor and then it enters into the fetal circulation at physiological pH. So throughout this, it is a pH dependent transfer which starts as early as 12 weeks of gestation, and it progressively increases throughout the gestational age, with a peak transfer occurring in the last 4 weeks in a term fetus. In what way these biologics are related to this immunoglobulin G transfer? So these molecules, they also undergo this Fc receptor, neonatal Fc receptor mediated transfer. So if you observe that for this transfer, you need to have a Fc fragment and also the receptor. So all the biologics which have this Fc receptor has a capability to travel, to transfer across the placenta and reach the fetal circulation. So the TNF inhibitors, almost all the TNF inhibitors except certolizumab, they can cross the placenta and enter the fetal circulation. But this certolizumab, as it lacks the Fc fragment, it cannot transfer and it doesn't enter into the fetal circulation. So whatever the updates given by the EULAR is been based on a very large database, and it has incorporated many meta-analytic studies, and it has clearly shown that the TNF exposure, TNF inhibitors can be given throughout the pregnancy with no significant increase in serious infections, and it has supported the continuation of TNF inhibitors in pregnancy. And there were no observed congenital malformations or adverse pregnancy outcome in the fetus or in the mother who has used TNF inhibitors during pregnancy. And what about the non-TNF biologic DMARDs? So anti-T cells, anti-B cell therapy, anti-IL-6, IL-1 inhibitors, and the other drugs like IL-12 and 23 inhibitors, they are also considered safe, but the safety data is limited as compared to the anti-TNF. And there were no observed safety concerns in the infants who were exposed to these drugs in the utero. So EULAR has advised to use them if needed for effective control of the maternal disease. And similarly, the other drugs like anifrolumab, guselkumab, they have no safety data in pregnancy. And for severe refractory cases, these drugs can be considered as per the 2024 EULAR update. So you can use non-TNF inhibitors only if you require an optimal maternal disease control, if you do not have any other option of compatible drugs for treating the maternal disease. And for severe refractory disease, or when there is no alternative, you can think of using IVIG, methylprednisolone and sildenafil, and other drugs like JAK inhibitors, mycophenolate, oclosporin, leflunomide, apremilast. They were mentioned to avoid or replace with a compatible drugs when required if the maternal disease is active. So whenever the mother is receiving these biologics, you have to be very cautious regarding the vaccination in the infant. So EULAR moving forward, it also had given a guidelines regarding the infant vaccination when the patient is on these biologic DMARDs. So all the inactive vaccines can be considered and they can be administered safely when the mother is on these biologic DMARDs. But whenever the mother is on TNF inhibitors or non-TNF inhibitors, we have to be very cautious while advising vaccination, especially the live vaccination in the infant. So BCG vaccination, whether the patient is receiving TNF or non-TNF, throughout in the entire pregnancy, you have to delay it by 6 months, because it takes 4 to 6 months for the biologics to be cleared from the fetal serum. And for rotavirus, again, if the mother is on non-TNF, you have to delay it by 6 months. And if the mother is on TNF, you can consider giving it as a routine schedule, because there were no untoward effects that were observed in the infants who has received rotavirus infections, whose mothers were on TNFs and those who were not on TNF. So there is no major difference in the untoward effects in these two groups. But if your maternal disease is under control and if you want to stop these biologics, you can think of stopping the biologics at the following gestational age. So you can think of stopping infliximab and adalimumab at 20 weeks of gestation, golimumab at 38 weeks and etanercept at 30 or 32 weeks. So if you stop at this particular gestational age, you can continue with a routine vaccination schedule in the infant. As we have seen that certolizumab do not cross the placenta because it doesn't have an FC part. So it can be continued throughout the pregnancy and there is no need to stop this drug. And similar to the placental transfer, these molecules also cross across the breast milk and reach the fetus. We all know that IgA is a predominant immunoglobulin which is present in the breast milk, but however IgG constitute to less than 10%. Like a placental transfer, in the breast milk also this transfer occurs through neonatal FC receptor, and being these are a large molecule, the transfer is very minimal and the levels in the breast milk is also very minimal. So the systemic exposure of these drugs is very low in the infants. So minimal milk transfer and negligible infant exposure. So you can safely continue these drugs throughout the breastfeeding time. So all the medications, including the ones which are compatible during pregnancy, can be continued in breastfeeding. And the one which I want to highlight here is regarding the methotrexate, which you can think of giving to the mother if her condition is warranting treatment with methotrexate even during breastfeeding. This is a very new point which has come. Previously it was thought that methotrexate needs to be avoided during breastfeeding, but you can think of giving methotrexate at a dose of less than 25 milligram per week if required to control the disease activity. And you can avoid all the other conventional synthetic DMARDs like leflunomide, immunomodulators like mycophenolate, cyclophosphamide, apremilast, JAK inhibitors during breastfeeding. And one more dimension which was added to EULAR 2024 update is drugs in a male patient who is planning to become a father. So you have to discontinue cyclophosphamide at least 3 months before planning, if at all, because cyclophosphamide is having a negative impact on spermatogenesis. You have to advise the couple to go with a fertility preservation techniques, and all the NSAIDs, prednisolone, all the conventional synthetic DMARDs and immunomodulatory drugs like mycophenolate, calcineurin inhibitors, biologic DMARDs, IVIG can be considered in a male who is planning to become a father, and they are found to have no negative impact on the birth outcome. But however, when the patient is on apremilast, avacopan, IL-23 interferon inhibitors, C5 inhibitors, you have to think of switching to an alternative because we don't have a sufficient data regarding the safety. So this updated version has given how we have to manage a pregnant lady or a couple throughout the reproductive journey, and it has clearly advised to prioritize to treat the maternal disease to the target, and more anti-rheumatic drugs were added to the safe list, and it has been restrictive use of NSAIDs and steroids in the EULA 2024 update, and at the same time it became more pervasive for use of biologics in these patients. And it has clearly given the guidelines when to vaccinate, especially the live vaccination when the patient is on biologics, and it has incorporated the male reproductive health in these guidelines. Thank you so much.
Thank you, madam, for clearly telling us the shift in major shift in guidelines from older ones to 2024. So, with this, I think there will not be any questions that will be taken.
Good afternoon, ma'am.
Except for this short question.
I have a question, yeah.
Very short.
Actually, we have recently come across a mother who is second gravida A1, ma'am. First history of first trimester miscarriage. Currently in 8 weeks of her gestation with a diagnosis of probable SLE. She is currently on HCQ 300 mg once daily and Visalon. And ma'am, my first question is like increasing the dose of HCQ. Usually we give 200 mg. So from 200 mg to 300 mg, will it provide any added extra advantage? Or and second question is there any role of low dose heparin, low dose aspirin plus heparin in this pregnancy?
So the first part of your question is increasing from 200 milligrams to 300 milligrams. Rather than looking at the dose, we individualize the dose as per the kg body weight. So previously it was thought that 6 mg to 6.5 mg per kg body weight was associated with a lesser side effects as compared to a dose which is like 200, 400 or 500 milligrams. But EULAR has clearly mentioned now it is up to 400 mg per day we have a safety data. But the current guidelines also say that regarding the HCQ dosage it is 5 milligram per kg body weight. So I suggest to go as per the body weight rather than a fixed dose combination. And regarding the heparin, so you are thinking heparin and aspirin, right? So you are thinking heparin and aspirin only because of diagnosis of lupus, or in addition to that she had one pregnancy loss, right?
Combining both, the outside rheumatologists have like suggestion. They gave an opinion. The patient has come for the opinion for low dose aspirin plus heparin. We usually start heparin from after doing NT scan with enhanced first trimester screening, ma'am. If she is screen positive, we will start straight away with 150 mg aspirin. But I have a dilemma, ma'am.
So here so whenever we are thinking of antiplatelets with or without anticoagulation, we have to think whether the patient is having any OPS or a vascular APS. So if the patient is having vascular or OPS APS or in combination, I think from the previous talks the message is so clear. But if the patient is primary and we don't know her, she doesn't have any other past thrombotic episodes, and we are like, again it is a gray area whether to start ecosprin or not in them. But if you go back and see the literature, ecosprin do also have a protective effect in the pre-eclampsia. So most of these patients, especially the ones who had a rheumatic musculoskeletal diseases, and if the patient is a diagnosed case of lupus, even we go forward to start on ecosprin, irrespective whether she had a previous OPS APS or not, especially in cases of primary.
Thank you, ma'am.
No heparin. No heparin.
I thought the question was small, but answer became big. Thank you, ma'am.
Thank you, sir.
The EULAR drug handouts have been included in the delegate kit, which have been designed for a practical reference in the clinics. Everybody can go through that. Now we'll request all the delegates and the faculty to come forward and assemble for a group photo. Post that, we'll break for lunch and reassemble at 1:45 for the next session on fertility preservation strategies.
I request everyone to please come up onto stage for the group photograph, and we'll quickly proceed to lunch after that. We have a shortened lunch break, so we are going to come back here at 1:45. So if you could quickly come up onto stage, then I think you'll also be quickly on to lunch.
కూర్చుంటే బాగుంటుంది. కూర్చుండేమే 2 స్టెప్స్ వేస్తాను. కూర్చోంటుందా? కూర్చోబెడితే బెస్ట్. చైర్ల మీద కూర్చోబెడతా.
Delegates at the back, faculty at the back, they are not visible.
చైర్లు వేస్తే మంచిగా ఇది ఉంటుంది. నేను ఇంకా సెట్ చేసుకోలేదు. వదిలేసిన
Residents, rheumatology residents, can you please kneel down at the bottom? Rheumatology, obstetric fellows, please, whoever can kneel down, please. This is not at all right. I am also going to kneel down.
Position yourself.
ప్రాబ్లం కాలేదు. ఏ పని ఏం చేయలేము. ఎంతగానో ఏం చేస్తాం. స్ప్రెడ్ చైర్ తీసుకొని వచ్చి చైర్ మీద కొంచెం బ్యాక్ వెళ్ళిపోతా. సెంటర్ చైర్ వేసుకో. ఇప్పుడు వైడ్ వస్తుంది అంటే చూసుకో. లైటింగ్ కట్టలేదు ఫ్రంట్. వస్తాను. రైట్ చూసుకోండి. నీకు ఎంత ఫిట్స్ లేదు లాస్ట్ చూసుకో. సరిపోతుందా? సరిపోతానికి బ్యాగ్ పోతావా? ఇంకొంచెం బ్యాగ్ పోవాలా? తప్పదు. ఫుల్ ఎంత ఈ మైక్ తీసుకోండి. మైక్ బాగా తీసుకోవాలి.
Okay, ready? Yes, ready, look here. Yes. So 1 second.
హలో, మొత్తం వైడే.
Okay. Yes, ready, look here.
ఓకే, కూర్చో.
Yes.
లాస్ట్ జరిగింది మనకి.
1 second.
అదే నేను మొత్తం వైడే చేసిన.
1 second. Okay, yes. 1 second.
అయిపోయింది.
Okay. Yes, ready. Last.
Disaster.
Okay, thank you.
చేరు ముగ్గుతుంది ఉయ్యాలో కింద
ఇది కంపోజ్ చేసి మనకు అనవాడు కదా ఇది తర్వాత లైవ్ వైట్ పెట్టాడు అయిపోయింది.
Rheumatologist and a fertility specialist. So we have devised this in a dialogue way only. After a brief introduction delineating our respective perspectives, we have proposed few cases in which I will discuss the rheumatology perspective or the concerns, and Dr. Vaijayanti ma'am will give us the input about her from the fertility point of view. If we have time, we will deal with a few myth busters. So from the rheumatology point of view, whenever we have a patient, our focus is generally primarily first we want to establish the diagnosis, get an idea of the disease activity or organ damage, plan the therapy with regard to how can we best achieve the disease activity, get it under remission, and at follow-ups, how can we optimize the medication. In some situations, there may be situations where we may not have time to think about the long-term consequences of our therapeutic decisions. Our goals of disease activity, getting the disease activity under control, may not be aligned with the patient's long-term reproductive goals. We are probably designed, or we probably think of fertility as a secondary priority. We may be considering, as rheumatologists, possibly our approach to fertility is to give it a secondary priority. We may say first let us save the life of the patient, and fertility preservation or fertility having a family comes later. While this may be a reasonable approach in some emergency situations, we should also remember that fertility choices and reproductive choices are central to a patient's identity and are very central to their quality of life. So we should probably be aware of these and initiate the dialogue. So these are the clinical urgencies and the decision-making problems which we face from the rheumatology point of view. I invite Dr. Vaijayanti to provide her perspective from the viewpoint of a fertility specialist.
Good afternoon, everyone. At the outset, I would like to thank Dr. Lisa, Dr. Tara, and Dr. Madhuri for giving me this wonderful opportunity to be here today. I would also like to take this opportunity to congratulate them on putting forth an excellent program. Fertility preservation is a subject close to my heart. In the context of rheumatological diseases, fertility preservation services is underutilized in the clinical scenario. When we look at, however, most of these rheumatological diseases are diagnosed during the peak reproductive years in both men and women. Say, for instance, if we take SLE, the disease process itself can affect fertility. Many women with SLE do have low reserve, and there's a lot of evidence supporting this. Apart from the disease process itself, the treatment given for rheumatological disorders, particularly cyclophosphamide, has got a potential to reduce fertility. So it is both the disease process itself and the treatment can affect fertility. So it is very important to integrate fertility preservation into routine rheumatological care, and that is where we are moving in the future. So when we look at, so the goal mainly is to understand that every young man and woman who is in need of fertility preservation should be referred to a fertility specialist prior to starting treatment like cyclophosphamide, which can affect the fertility. The counseling is very important, and all the guidelines, EULAR, American Association of Rheumatology, ASRM, all give the guidance as to early counseling is very, very important, and referral for fertility services. So today, in our discussion today, we'll be looking into the different fertility preservation techniques available and when to refer and how to manage the different scenarios. Thank you. Over to you.
So let us start off with a hypothetical case, but very commonly seen. A 27-year-old lady, newly diagnosed lupus, with mild to moderate activity, hemodynamically stable, is planned for cyclophosphamide in the coming weeks. She is unmarried and would strongly want to preserve her future fertility. So this is a typical case, and here it gives an opportunity for us to discuss when should we refer to fertility preservation services, how should we as rheumatologists try to optimize fertility in our patients, and what are the different options available for our patient, and how do we plan this. So from the treatment point of view, because we know that cyclophosphamide is likely to decrease the ovarian reserve in this lady, can we opt for less gonadotoxic therapies? Can we consider mycophenolate? Can we consider any other options? And do we have a window of time in which we can use the help of our fertility preservation services to help maintain her future fertility? So now if this lady can have a lower dose of cyclophosphamide also, like if we could follow the ELNT protocol instead of the monthly NIH protocol, possibly because the cumulative dose of cyclophosphamide will be less for her, then that may also help in preserving her fertility. And now it is the timing of referring to fertility preservation services is not during the onset or during the course of therapy, it is prior to initiating therapy.
Yes. Thank you. So here, this is a young lady, 27-year-old, and we still have time prior to starting cyclophosphamide. Do I take it as few weeks, Dr. Madhuri, we have here?
No, probably a week or two.
A week or two, yes, okay. So basically what we are looking at is, in the context of the timeline, it is a myth that, fertility preservation takes longer. But when we look at, we just need 10 days to complete one cycle of oocyte preservation. So in this context, we would be looking at oocyte cryopreservation, because she is a young lady and she has got mild disease, am I right? Yeah. So she would be in a position to offer, we are in a position to offer oocyte preservation in this case, but it just takes 10 days, that's the timeline we are looking at. But when we look at the safety aspect, there are three things I would like to highlight. One is, the IVF process in itself these days is very, very safe with using antagonist protocols, and we also use what is called agonist trigger. So the risk of OHSS is almost eliminated from the IVF practice. So IVF per se is not risky for these women. We can keep it safe. The second aspect is with SLE, what happens is high estrogen can have a flare up of the disease. So to avoid that, what we use is letrozole, which is an anti-estrogen. We start it right from day 1 of stimulation and then take it till the egg collection, 2 days post the egg collection. By doing this, we are able to keep the estrogen levels during stimulation at a very low level, less than 1000 picogram, which is what we see in a natural cycle. When women have their natural cycles, we are looking at a value around 600, and we are able to reach that level. So it is very safe. And the third thing is, we also, thrombosis is also a risk factor when women with SLE have. So that also we cover with anticoagulants, which I'll be covering later. So these are all the things which we need to look at. Another thing is, these days we have what is called random start protocol, which means if a lady walks into our clinic today, I'll be able to start the fertility preservation from today. So which means 10 days is more than enough for us to complete one cycle of oocyte stimulation, oocyte cryopreservation. But having said that, women with SLE, as I mentioned earlier, the AMH is, we have a large body of evidence to say that the AMH levels are low in these women compared to age-matched controls. So when even in a 27-year-old, we might be facing low ovarian reserve or less number of eggs which we might be able to collect. So if 3 weeks we also do what is called duo stimulation, which is back-to-back. First 10 days we do, and 2 days post-egg collection I can do another stimulation, which means in 3 weeks we can do back-to-back and get more number of oocytes cryopreserved. And again, in this context, I would also like to add, but this is a standard practice which we can do in any IVF clinic. But these days, we also have what is called OTC, ovarian tissue freezing, which we, in this context, I would like to share that we have the expertise and we are offering it in our unit. So this would be also an ideal case for OTC. So ovarian tissue freezing doesn't involve the risks of which we spoke about, the risks of IVF, the duration. All this is not a factor. Just 1 day is enough. If she is fit enough for surgery and anesthesia risks, then we will be able to do the laparoscopy, remove one ovary, that's what we would want to do, separate the cortex, freeze the cortex, and then transplant it at a later date. So this is another thing which we can always consider in these cases. Thank you.
Now, suppose we do not have the luxury of time, as in this second case. A 35-year-old lady with severely active lupus, with lupus nephritis, rapidly progressive glomerulonephritis, and CNS involvement, requires urgent initiation of high-dose steroids and cyclophosphamide. However, she would like to preserve her future fertility. So, in the previous case, we had some time, a little bit of time, in which without leading to long-term organ damage, we could use a oocyte preservation, or like ma'am said, an ovarian cryopreservation. There are some times when we cannot have that luxury of a week or 10 days, in which case we have to opt for urgent treatment, but we have to align our disease activity control with the patient's reproductive goals. So in this scenario, what do you think we could offer, ma'am?
Here, as you said, she is having severe SLE. And in this instance, what we always say is it's maternal health which comes first. So if she has severe SLE, which means that she is not in a situation to offer, definitely not oocyte cryopreservation in this case, but she might also not be fit to withstand a laparoscopy, which is needed for ovarian tissue freezing. So in this instance, what we would say is, yes, cyclophosphamide can damage the fertility, but before, once she is in remission post this acute episode, we can also do fertility preservation. So many of these patients with SLA understand might need multiple courses of cyclophosphamide, right? So even after one cycle of cyclophosphamide, everything is not lost. So when they have the next remission, that would be a right time to consider fertility preservation. So that would be a right time.
Can we also talk about GnRH analogs, the role of GnRH analogs?
So here, fertility preservation is one thing and fertility protection, I would say. GnRH analogs, in general, we can't say that is a fertility preservation technique. That is only a supportive treatment, we would say, for GnRH analogs. But if GnRH analogs, the use has been derived from oncology setting, where in breast cancer patients, that has got a minimal role that it might be beneficial. So we have a similar scenario here in SLE where it might be, but that is not the primary treatment modality which we are going to offer. The standard techniques, oocyte, embryo, sperm preservation, or ovarian tissue freezing or testicular tissue freezing is what we are looking at as primary modes of fertility preservation. This is just a supportive method is what I would say. Thank you.
So GnRH analogs, there are only a handful of studies in patients with rheumatological illnesses, and they do not have very high numbers of patients. They have at the best 20 to 40 patients. But whatever data is available, including a meta-analysis of around 200 patients, supports that with the use of GnRH analogs, you are able to protect fertility in at least, so if you do not use GnRH analogs, with the use of cyclophosphamide, the risk of premature ovarian failure may range between 20 to 40%. With the use of GnRH analogs, the range is between 5 to 8%. So there is a role. GnRH analogs are now conditionally recommended by most of our guidelines, including the ACR guidelines. Ideally should be commenced 10 to 14 days before the initial dose of cyclophosphamide, but in emergent cases, we may have to give them simultaneously also. While the use of ELNT protocol may decrease the cumulative gonadal toxicity, the timing of GnRH analogs with the ELNT protocol is not well known because there is not enough data on this. So you can consider use of GnRH analogs in severe cases, but it may not be completely sufficient. It does not guarantee ovarian protection. Now coming to a third case where we have a 32-year-old woman who is stable with lupus and thrombotic APS. She is on mycophenolate, doing well clinically. She is not yet planning pregnancy and has never been counseled about fertility preservation. So would the audience want to opt about when will you discuss fertility preservation with this patient? No, she is stable and not planning a pregnancy soon, so we will not discuss. Any show of hands for option A? Option B, only when she actively plans pregnancy. Option C, counsel now and consider referral. We have a good show of hands for this option. And option D, only when she asks. So as most of you have rightly guessed, even if this lady is not planning pregnancy now, if she wants to plan it in the future, that is probably the best period of time when we can plan her fertility preservation. Having said that, this lady has never been counseled in the past, so there is actually already a missed window of opportunity where we could have done better, because with age the ovarian reserve actually declines. Now this case will require very close monitoring because, as ma'am has said, you will have a risk of lupus flare, you will have a risk of thrombotic episodes with a coexistent APS. So we are going to need, from the rheumatology point of view, assess one, disease activity, she is stable, so yes, you can proceed with ART. Two, risk of the APS thrombotic episodes, so anticoagulation as has been described in the previous sessions. This lady will require therapeutic dose of anticoagulation. And third, regarding the drug transition. While mycophenolate is not gonadotoxic, it is teratogenic. So if this lady is planning a pregnancy now, it is time to do a transition from mycophenolate to a pregnancy compatible drug. If the target is only oocyte cryopreservation, possibly we can continue this on mycophenolate.
So the guidelines do suggest that mycophenolate can be continued, but having said that, there is no body of evidence to support that. They do declare that there's a body of evidence isn't there. But there's a recent paper from Japan, 23 it was published, where they had used methotrexate, mycophenolate, both in the same context. We are allowed to do oocyte preservation, but because methotrexate acts on the growing phase of the follicular pool, that does have a significant effect when we do oocyte preservation with patient on methotrexate. But my sort of query to you is, can they be shifted to other immunosuppressants when they, for instance, the others, azathioprine and other, and they can be stabilized on biologicals? These two are quite okay. Say they don't affect the cycle, the growing pool of the follicles. So we will be able to get a better outcome when we do the oocyte cryopreservation. So if that's okay, they can be stabilized and done. But this lady is already 32, so she might having an age-related decline in the number of oocytes too. So that is something which we need to consider. With consideration to OTC, we don't do ovarian tissue freezing post 35 years and above. In Indian context, I would say 33, because our women age earlier than Western counterparts. So anybody more than 33, we would really have to assess the ovarian reserve whether OTC is going to be beneficial for them. And again, ethically also, if someone's AMH is very low, less than 0.5, it would not be prudent to go ahead with preservation technique. So this is something where we have to individualize every case and then take the call as what would be the best given the circumstances.
So we'll talk about a male with newly diagnosed ANCA vasculitis who's planned for cyclophosphamide induction therapy and he's yet to begin his family. So we just wanted to bring out that even males need to be counseled about fertility preservation, especially when we are initiating them on cyclophosphamide. Male fertility preservation is simpler, it is more effective and feasible. So there is no role for the use of hormonal therapy. Testosterone does not play any role in preserving fertility in males. It is not recommended. And sperm cryopreservation is the easiest way for preserving male fertility.
Yeah. So sperm cryopreservation is very easy. We just need one sample. There is no delay with regards to starting treatment. Even if we have couple of days, we can freeze 2 to 3 samples. But even if one sample we are able to get, we can split those samples and freeze, which means these couples, when they come back for treatment, we have got enough sperm to provide them, with ART techniques, IVF techniques. With the newer techniques like ICSI, we just need few sperm. Say for 10x, we just need 10 good quality sperm. That's all we are looking at. So even when the quality of the sperm is very poor, we are still able to offer fertility preservation. The cost is also not more. So just one last thing, testicular tissue freezing, that is particularly applicable in adolescents, adolescent boys. If they are say more than 14, they are still be able to give a sample, because many of these young boys who might be in their adolescence also might be diagnosed with rheumatological diseases, I suppose. So if, more than 13, 14, they'll still be able to give a sample if possible. Our youngest is 14 years who has preserved with us. But if not, testicular tissue freezing we can consider. But it has got an experimental label because there are no pregnancies established from testicular tissue freezing. Whereas ovarian tissue freezing, there are 200 live births all over the world. So it has now become an established technique. Whereas here we can freeze it, there is no issues with freezing, but replacing it hasn't given spermatogenesis under pregnancy. But 10 years down the line, we might be in a better situation. Yeah, thank you.
So I'd like to conclude saying that even oocyte or embryo cryopreservation would not guarantee a future pregnancy. It is another thing important to counsel our patients, even when they are undergoing all these therapies, to continue their rheumatic medications, because that is how we can decrease the risk of flare and thrombotic episodes. It is important for us as rheumatologists to take a proactive lead in establishing these discussions with our patients and to not miss the window of opportunity, because time is very critical in fertility preservation. I think we are out of time here.
So any questions?
This is a challenge. It adds a burden to the dimension of the conversations that you need to have in the clinic. So are there cases where you will say, I don't need to refer for any fertility preservation? And I think the field should move towards guidelines where you should definitely send them.
Yes.
Because not, so are there any such guidelines, age-based or AMH-based?
So
AMH or previous history of infertility based?
When we should send. So any woman who is in the reproductive age group or who has yet to, not in the postmenopausal age group, should we inquire about their plans of their, this one.
We don't have guidelines as of now, Lisa ma'am, we don't have. But that's something we should, different specialties need fertility preservation. So it would be prudent to, for the fertility specialists and rheumatologists to come together to form a guideline so that we know when to refer, when not to refer, what are all the procedures we can offer. There are no guidelines as such, but it would be prudent to put down some of these guidelines. Thank you.
Mother, is there any risk of flare of autoimmune disease, especially when this ovarian tissue is reimplanted in these patients?
Ovarian tissue reimplantation, there is no risk because there is no estrogen increase, there is no flare. It is a surgery where we are removing the ovarian cortex, freezing the cortical tissue. We freeze, we do about 5 millimeter fragments, small fragments. We freeze them and say, for instance, from one ovary, if it is a good size, we can even get 12 to 15 pieces. But when we put it back, we don't have to put the entire 15 pieces in one go. We can use 5 or 6 pieces. So we'll be transplanting them into the residual ovary, the other ovary where we haven't removed. And if cyclophosphamide has damaged the ovarian reserve and she's postmenopause, she's amenorrheic, we can put it inside the other ovary or in a peritoneal pocket where the original ovary sat. The only risk is the small pieces, we usually stitch it together to the peritoneal pocket. And once the vascularization happens, it works like a normal ovary. And many of them can conceive on their own also at that point. Or we can, given the fact that the reserve, if it is based on how the reserve is, we can help them with ART also. But there is no flare-up when we put back. It is like replacing a normal ovarian tissue.
That's what. Theoretically, there appears to be a little bit of estrogen surge. So there can be autoimmune
So the
because you
data
don't know
for
that.
ovarian tissue cryopreservation is limited only to case reports, sir, as of now.
Yes.
So in this, there are 1 or 2 case reports, especially one patient of MCTD who ended up being on the ventilator. Even though the ovarian tissue preservation procedure was successful and uneventful, after the surgery, possibly as a trigger, the surgery being a trigger for her autoimmune disease, she had thrombotic episode and ultimately recovered, but it was a very stormy course. So there are few case reports which suggest that the primary disease may flare.
And I think guideline is very difficult to come out with this kind of thing because lots of social things will come into picture. Some people want children, some people don't want, some people already had. So, no, I think it's applicable to the patient group, I think, ma'am. Once, even if you bring also, it becomes a bit difficult because that guideline should take into consideration those who have completed family, and I think patient's interest is the first thing. I think patient, if they want, then only we can suggest.
Yeah, we can suggest, but it's up to them to take it or
So
whether
the
they want
simplest
to
thing
take
is,
it
are you
to be
planning a
patient driven
pregnancy in the
rather
next
than we
year?
are telling them.
So one quick clinical question, do you plan a pregnancy in the next year? If yes, then we
Then
have to...
that's the entry question.
Entry. That is a basic screening question, that's all.
Yeah, thank you.
So the session is closed. Thank you.
Now we would have an ART primer for the rheumatologist, which will be followed by case presentation by our rheumatology resident, who will highlight the key clinical scenarios and raise important questions, which will further be discussed by the chairperson and the speaker. So may I now invite Dr. Manish Dugar to kindly take the dais and guide the session forward.
Good afternoon, everyone. I have the pleasure to inviting Dr. Kameshwari, who will be taking us through this talk on ART primer for the rheumatologist. And she has areas of interest in infertility and minimal access and other things, and also works in the prestigious Fernandez Hospital. Thank you, madam.
It's an eye-opener for me too. I've learned a lot of points this morning, from clarity to confusion. So hopefully I'll wait for... So I had the luxury of calling Dr. Tara anytime and asking if I have a patient with a doubt. Do I give Clexane? Do I give aspirin? Is it seronegative, seropositive? You know, there are umbrellas where you can fit and justify your heparin. But the beauty is to actually give to the right patient. So we have the luxury of having our team in our hospital. Thank you so much. I know we are running out of time. I will try to keep it as brief because I don't think you need to know too much about fertility treatments. So different terminologies exist. I don't know if you all agree on one terminology for these conditions. To me, everything's mean the same. Uh, and the spectrum of diseases, I don't need to state. Unfortunately, these diseases are faced in childbearing age, and they can affect fertility either directly through the disease or through the medications that they are on. And fertility treatments and preservation techniques are often indicated in these women. And they need careful monitoring when we're doing this, and they should postpone conception until remission is achieved, at least for 6 months. They should be stable enough to undergo the ART techniques. If pregnancy is not contraindicated, my take is infertility treatments are not contraindicated as well, because pregnancy is more thrombogenic than the ART itself. Investigate generally young patients. You can give them 6 months of natural trial. They may conceive. If not, then start evaluation. And the time to conception must be optimized, and we need to focus on ovarian protection, the timing of pregnancy, and the relevant medication adjustments. Before all these are done, we don't embark on any fertility treatment. Women needing stimulation must be clearly taken an opinion from their rheumatologist. They should get clearance before we start any medication. And we offer fertility preservation to those needing gonadotoxic treatments, which has been covered. So this is clearly an area of multidisciplinary care and not a standalone fertility specialist care. So I think this also has been covered. For lack of time, I will skip this. But as gynecologists, I need to be aware, are they on any of these medications before I actually advise fertility? Medication adjustments must be made beforehand. Keep the washout periods on time in your mind before you start the treatment. And we should also be aware of the contraindications when they should not conceive at all. So these are basic things that we gynecologists must be aware of before we discuss. What are the different treatments that we offer women? Simple thing is ovulation induction, IUI, intrauterine insemination, IVF, cryopreservation, and then surrogacy for women who can't carry their pregnancy. So we will not talk about cryopreservation and surrogacy for want of time. We just cover the three basic things. So in ovulation induction, what we do, we stimulate the ovaries with various kinds of medications to enforce a mature follicle development that can then be fertilized by a course of natural intercourse. This is used to treat women who do not ovulate naturally, or hypothalamo-pituitary dysfunction, or PCOS, which are anovulatory conditions. So we can also increase the number of eggs reaching maturity through this kind of treatment, and treatment should always be after thorough evaluation of their baseline hormones, their semen test, their uterine 3D volume, ovarian follicle workup. All of these should be done before we give any medication. Of course, they may not work for women with very low ovarian reserve. IUI is the same process of ovarian stimulation, except the extra part is that we place a prepared sample of semen inside the uterus, so in an environment where the gametes are closer for fertilization. So that's the only difference. And the indications are very clear: unexplained infertility, male factor, or failed ovulation inductions. And if there are comorbidities like endometriosis or pelvic inflammatory disease, or in case of HIV discordant couples, there are clear-cut indications. And we should also know when not to do IUIs. When there is a tubal pathology, there should be at least one patent tube to offer ovulation or IUI. And in the setting of infections, we should not be doing these invasive procedures. So prerequisites for IUI, women should be capable of spontaneous or induced ovulation. At least one tube should be patent. The sperm count should be minimum more than 10 million, pre-wash or a post-wash somewhere around 5 million, motile sperms with the percentage at least more than 40% with easy access into the cavity. We should not have a cervical stenosis diagnosed on table with the specimen ready. So you should work up your patient before you embark on this. And there are 10 steps for IUI. We will not go through all of these. So after ideal workup, we stimulate the ovaries with different regimes. We monitor the follicle growth through serial scans and also watch the endometrium. Then when the oocyte is ready, we give a trigger in the form of either HCG or GnRH analog. We need to know when to cancel the cycle, and then we time the insemination 24 to 36 hours after the trigger. Then how do we collect the semen and how do we prepare it? Then the insemination process itself under aseptic precautions. Post-procedure, how do we monitor these women? Then we give them luteal support, and finally the time comes to know whether they're pregnant or the period has come. So there are so many steps involved in an IUI process. Now, I know this is all too much of theory for you all, but there are 3 regimes that we generally use. Regime 1 involves oral agents, either clomiphene citrate or letrozole, which is an aromatase inhibitor, or tamoxifen, which is a SERM, which is a selective estrogen receptor modulator. These 3 are the simplest protocol regimes, oral, cheap, easy to use, and 5-day course. So this is what we follow, and we should all be aware of the side effects, but none of these are known to actually aggravate the rheumatic conditions. In fact, letrozole, as Baijayanti said, is a preferable drug because of its reduced estrogen levels and decreasing the thrombotic risk. So women should be informed when we give these medicines about the risk of multiple pregnancy, twins or triplets. And if no response to 5-day regime, we have extended protocols which can be given up to 10 days. If there's lack of response to clomiphene, letrozole and tamoxifen, then we move on to regime 2 with a combination of gonadotropins. They include FSH or combined FSH-LH, different varieties exist. So let's not go into all of these. This is, letrozole is now superseded clomiphene. It has good ovulation rates. It has a favorable effect on the endometrium as opposed to clomiphene. And multiple developing follicles appear on day 7, but usually monofollicular dominant follicle is achieved by mid-cycle, improved stromal blood flow with higher pregnancy rates. So this is how it works. None of these, as I said, have any detrimental impact on the rheumatological conditions. Regime 2 is a combination of oral plus gonadotropins. The advantage is the fecundity is double that of clomiphene. Economic advantage because less number of gonadotropin injections are needed, and use of HCG trigger is sometimes even not required with this protocol, and multiple pregnancy rates lower compared to gonadotropins alone. So we give the oral regime for the first 5 days, and we add on these injections from 3rd day onwards. You have step-up regime where you 3, 5, 7, and then if there's no response, you increase the dose, increase maximum to 225 before you actually abandon. Then you have, in this combination regime, you have low estradiol levels. That is the advantage. Regime 3 is only gonadotropins. Here there is a risk of ovarian hyperstimulation if you are not careful. So we should avoid the HCG trigger in this group. We have to give GnRH analogs to downplay the hyperstimulation syndrome. Monitoring follicular study starts from day 9. We do alternate day monitoring both for the follicle as well as the endometrium. They grow at the rate of 2 to 3 mm and reach, usually by day 14 to 18, they reach the dominant size, at which time the trigger is planned. Trigger is given once at least 1 or 2 leading follicles reach 18 to 20 mm and endometrium is at least 7 mm. Occurrence of ovulation happens about 24 to 36 hours after trigger, so that's when timed intercourse or insemination is planned. If there are more than 3 follicles of more than 16, then better to avoid HCG and give GnRH analog, that is decapeptyl, which reduces the risk of ovarian hyperstimulation. You need to know when to cancel a cycle. If there are more than 3 follicles of more than 18 on the day of HCG and there's a risk of multiple pregnancy, the choice has to be given to the woman. There are some women who are very rigid, come what may, I do not want a multiple. Then you have to abandon. And if the total number of follicles are more than 4 and if estradiol level is more than 1500, she's clearly at risk of OHSs, then better to cancel the cycle. So timing of insemination is usually 24-36 hours after the trigger injection. Then semen is prepared with double density gradient method that we use. Under aseptic, atraumatic conditions, ultrasound guided, very slow injection of the sample without disturbing anything inside the uterus. That will again trigger prostaglandins and lead to uterine cramps. And post-procedure, she's allowed to lie down for 10 to 15 minutes, and after that, she's discharged. We send her home on luteal support, and detection of pregnancy usually happens 5 days after stopping the progesterones. They can check. Complications exist for any procedure. These are minimal, but they need to know. And success is around 10 to 15% conception rates per cycle. But on cumulative, if you try 3 to 4 cycles, the success rate improves. After 3 months, you again have to review the entire case to know why it did not work. If no conception after 6, we definitely refer off for IVF. So IVF, I think without going into much detail, it's a 6 to 8 week procedure, but as Vaijayanti said, there are different regimes. You can cut short depending on the time constraint, but usually there is a stimulation period, 10 to 12 days with different medications, egg retrieval under sedation, then fertilize in the lab, grow the embryo, transfer either at 48-hour stage or blastocyst stage, and sometimes you can pull the embryos over 2-3 cycles and do a frozen embryo transfer in a later cycle to optimize her disease condition. In IVF, you have different approaches, the antagonist protocol, the agonist protocol, the minimal stimulation protocol. So many protocols are there, but the important thing is to start this process when the patient is clearly in remission. So agonists and antagonists are used to prevent natural ovulation. So stimulation, FSH and HMG are used, and for trigger short, HCG or GnRH agonist, and letrozole is one that we should keep in mind to reduce the estrogen levels. But remember, no fertility treatment till disease is in remission, till their medication is optimized, till the rheumatologist gives a nod, and it has to be a joint care. These are the points that we should not forget. And till that stage is reached, contraception. We should not forget contraception. I think this is a table that helps you. I think they covered it in the morning. Based on the APL status, if they are positive, you prefer IUDs or progesterone only pills. If with high titers, you avoid estrogen combined pills and go only for progesterone or IUDs. DMPA, if you are considering, remember osteoporosis is a risk factor, particularly if they are on corticosteroids as well. Anticoagulation, I think this has been covered extensively, so I'm not going to dwell on this too much. But this is a flow chart that will help us who needs, if they're negative for APL, proceed with ART without anticoagulation. If they're positive, no clinical APS, we can still do the ART but treat them with prophylactic low molecular weight during the procedure itself. And if they're OB APS positive, then proceed with ART but treat with prophylactic low molecular weight heparin during the procedures. And if they're thrombotic APS, then you have to treat with therapeutic doses. So this is all cleared, and cyclophosphamide also has been covered. It's gonadotoxic. Either you use low dose regimes or you send for cryopreservation before the CYC exposure, because it's known to cause premature ovarian insufficiency. So fertility preservation, she covered. And co-therapy, I think this is what was raised in the previous discussion. The first injection of GnRH should be timed 10 days before the CYC pulse. But if there is no time, as Vaijayanti said, after the first dose, you can still administer the GnRH analog and aim for the oocyte retrieval. If they have menopausal symptoms because of the GnRH agonist, you can give an estrogen patch at a very low dose to tide over the vasomotor symptoms. Depot for IUD contraception is another option unless otherwise contraindicated, but this is continued during the bolus of CYC administration. So to summarize, disease activity, fertility treatment is safest when the disease is inactive. It has to be a multidisciplinary care. Medication review must happen, and they should be on the safest medications. But remember, stopping the medications is never an option, because the disease itself can become a risk factor for poor outcomes. And women with SLE or APS are at risk of thrombosis. Therefore, careful anticoagulation management must always be borne in mind. Medical management of infertility with ovulation or IUI medications is a good option in young women with good ovarian reserve. They concomitantly should have immunosuppressant adjustments like steroids and HCQs, GnRH analogs to suppress the ovaries and reduce damage from chemotherapy, IVF with gonadotropin agonist triggers to reduce thrombosis, cryopreservation is an option, gestational surrogacy for women who are really high risk, who cannot carry the pregnancy, and donor oocytes or embryos is all the last option. So follow these safe practice principles when you're embarking on fertility treatment. And I conclude by saying women with connective tissue diseases must focus on achieving first disease stability at least 6 months prior to planning and tailor the treatment case by case, utilize ART such as IVF with specialized protocols to avoid thrombosis, and consider oocyte preservation in where appropriate. Thank you so much.
Thank you, Madam, for sticking to time. I would now request you to please have a seat, and we will proceed with the 3 cases, and at the end of the 3 cases, if there are any questions from the floor, we'll take them. So I think the bottom line here is to manage the disease and control the disease well before they embark on pregnancy. But however best we plan, always unexpected pregnancies do come up. So we have to be prepared for the worst as well.
Okay. Good afternoon. I would be presenting 3 cases from the PREVA registry, which is the pregnancy registry for Indian women with autoimmune diseases. So these are 3 real-life patients that had issues with conception and were managed. So we'd like to ask some questions regarding the same to our chairpersons. So the first case was a patient of a 30-year-old woman with SLE who was diagnosed in 2010. The initial manifestations were of arthritis, cutaneous vasculitis, pancreatitis, panicolitis, lupus nephritis, and pancytopenia. Quite a high disease activity. She received 2 rounds of cyclophosphamide in 2012 and 2015 for around a cumulative dose of 12 grams. And since then, she was initially on azathioprine, later switched to MMF. And in 2022, due to relapse of disease in the form of CNS vasculitis, she received 2 doses of rituximab. And in 2025, she was transitioned back to azathioprine as she planned for conception. However, she developed significant leukopenia with the same and hence had to be switched back to tacrolimus. Because her husband resided abroad, there was only a limited reproductive window available for her. So in consultation with the obstetrician, she was offered ovulation induction with letrozole, following which she had successful conception and is currently at 16 weeks of gestation. Other than this, she also has other issues such as she is anti-Rho positive. Her fetal PR interval is 101 milliseconds. APL workup is negative. Preeclampsia screen is negative. And she had a prior TIA history during her CNS vasculitis episode, and for which low-dose aspirin at 150 mg per day is currently being continued. So the questions that I would like to put forth, some of which have already been answered, are: the first one is, when is ovulation induction preferred to be offered to our patients? What drugs are used for ovulation induction? And with the various agents available, what is the risk of ovarian hyperstimulation in SLE with APS?
I think I have covered this, but however, I'll keep it short and brief. This lady is 30 years old. What is her age?
30, ma'am.
30. So the age and the ovarian reserve matters. If she's a young patient with regular cycles, that means ovulatory cycles, that's when we can offer simpler options of ovulation induction. The medications used are clomiphene or letrozole, tamoxifen if the endometrium is coming thin with these two. Tamoxifen has a better effect on endometrium. So you can use those, and the risk with ovarian hyperstimulation, the risk is highest if you use gonadotropins alone. Or in combination, the doses of gonadotropins can be reduced. So with gonadotropins, multiple follicular development, then you have to take a call and stop the cycle. The monitoring is very important because these women already have a background risk of thrombosis.
Yes.
And this OHSS also leads to vascular permeability issues, fluid shifts, and hemoconcentration and thrombosis. So maybe covering with anticoagulation is also an idea. So keep it simple, aim for monofollicular development with oral drugs in the first place. They should have their tubes open and their husband's semen test should be normal before we give this. And we don't dwell on 6 to 8 cycles like that. So try 2-3 cycles, doesn't work, move to the next step of IUI.
Okay. Moving ahead with the second case. This is a 32-year-old woman with systemic sclerosis who was diagnosed in 2023. She had predominant cutaneous manifestations with skin thickening, inflammatory arthritis, and ILD, but that was minimal. She had received a MMF till March 2024 and was transitioned to azathioprine as she was planned for conception. Previously, she had had an IUD at 7 months in 2021 and a first trimester miscarriage in 2022. Other than this, she also has hypomenorrhea and has already been tried on multiple ovulation induction cycles with timed intercourse, but they have been unsuccessful in these attempts. One IUI was attempted in 2024 October, but that was also unsuccessful. Her AMH level is normal and the HSG is also normal. So currently she is being planned for a second IUI cycle. The questions that I would like to raise are, when is IUI offered to our patients? What drugs are used during the IUI cycle, and what is the success rate of IUI in a patient who has already failed one round?
Yeah, the success rate of IUI per cycle is somewhere between 15 to 20%. So one cycle failed doesn't mean, the cumulative success increases if you try at least 3-4 attempts. So therefore this lady is ideal to try one more IUI, and she is definitely a candidate for IUI and not ovulation because she already had several OIs. Our protocol is 6 maximum OIs. We try, if no luck, we move to IUI. And what drugs? Same drugs. We aim for clomiphene, letrozole, or tamoxifen. Sometimes we may need to use a combination with gonadotropins very sparingly. We give 2 doses at a time, do the scans, titrate the dose. You can sometimes even reduce the dose, make sure they don't get overstimulated. And you could definitely try 2-3 attempts. If no luck, then think of the next step, that is IVF.
Right. And coming to the last case, this is a 32-year-old woman who is a known case of SLE from 2010. She initially had mucocutaneous and musculoskeletal manifestations. She had a right cephalic vein thrombosis that was provoked and initially received short-term anticoagulation. Later, it was found that she was APL positive in the form of LAC positivity as well as high titer ACL IgM positivity, and which when repeated later was negative. In 2022, she was diagnosed with lupus nephritis and received MMF initially, and since she had a recurrent flare, a renal biopsy was done that showed class 5 lupus nephritis, after which MMF and tacrolimus were given in combination. Since October 2025, she has been on tacrolimus 3 mg per day. Other than this, she had a history of adenocarcinoma of her appendix in 2022, for which she underwent a right hemicolectomy and 6 months of chemotherapy with capecitabine. She has now been unable to conceive naturally for almost a period of 1 year. She has low-grade proteinuria, mild thrombocytopenia, but more than 1 lakh. dsDNA is negative and complements are normal. So for this ongoing disease activity, tacrolimus has now been escalated to 4 mg per day. Fertility evaluation wise, she has a low AMH, a low antral follicle count, and her partner's semen analysis is normal, and she has currently been advised IVF. So to sir, I'd like to ask these questions. The first one is, when can we give clearance for ART procedures? That is, what is the minimum duration of clinical quiescence that we expect before giving clearance for ART? And in patients who are clinically quiescent but serologically active, that is, who are having low complements or positive anti-dsDNA, what is the risk of disease flare during ART in these patients?
So thank you for your questions. This patient definitely has more risk for thrombosis because of the presence of malignancy in the past as well as the positive antibodies. So ideally, we want the patient to be in clinical remission for at least 6 months before we plan any fertility treatments. So in this patients, the dsDNA being negative, the complements being normal, proteinuria less than maybe probably 500, she's probably in that low risk group. The only problem is the dose of tacrolimus is higher, so we need to focus on the blood pressure control. So maybe a set of these investigations done 6 months apart and she's stable for 6 months, we can think about fertility procedures. And we'll have to optimize the medications which are safe in pregnancy to the maximum in terms of maybe low dose steroids, here tacrolimus, aspirin, low molecular weight heparin, look at hydroxychloroquine, and all the other collateral things in terms of blood pressure management, anemia, and then probably make her the best for the procedure. Now, the risk of a flare during this treatment because of the current management strategies that they use is low. But once the patient becomes pregnant, the risk of flare is always there. And at that time, the problem we have is what medications to use, because our medications we have at disposable at the time of pregnancy is quite limited. So usually if they are quiet at the time of pregnancy planning and pregnancy conception, then hopefully they have a less stormy course. But occasionally it can be full of surprises, and a few of my patients who were quite well develop problems in the third trimester. So the first 2 trimesters might be okay, but in the third trimester they start having worsening proteinuria, high blood pressure, creatinine starts rising, and then we have to stop tacrolimus, and they may even require dialysis. So we need to be careful on that.
And so the second part, those who are serologically active but clinically quiescent, what is the risk of flare in these sets?
Correct. So if serologically they are active, that means they are prone for definitely some flare in pregnancy. So we have to maximize our medicines and then try to monitor these levels of dsDNA and complements maybe at a 3-monthly level if they can afford it. But just because they are not having any symptoms, they don't need any treatment, that should not be our thinking. So we should consider that yes, these patients are prone for problems and we need to give our medications in the optimal doses and look at proteinuria very closely. Because if the proteinuria is rising, there is blood pressure which is going above 130/80 systolic, that means there is something brewing in the background. So we need to be aggressive.
Right. And for the same disease set for ma'am, for phases of IVF and what are the drugs used in each phase, I think the second question has been already answered in the morning session, so we can probably skip it. And are there any differences in IVF pregnancies compared to natural pregnancies during the course, and in specific with relation to CTDs?
First of all, in this particular case, she's clearly a very high-risk patient compared to the previous 2, and she's already been trying for more than a year. And her AMH is low, her reserve is low, and she still hasn't reached that remission phase, which means she may need still another 6 months to 1 year to stabilize. Therefore, I think cryopreservation is an option in this lady, and even considering a surrogate is not a bad idea. So there's no risk to the mother's life, to the woman's life. So these are options that we have to offer her. But if every woman has a right to motherhood, we can't make the decision for her. If she still wishes to take the risk and wants to carry the child herself, then yes, IVF looks like the better option once her disease is under control, with regimes that are less likely to cause thrombosis. And the phases we have discussed. So they have to stimulate, we have to retrieve the eggs, we have to fertilize in vitro, and then embryo transfer, and then support the first 3 months. How do these pregnancies differ from natural? The first 3 months, they definitely are different. They need support, hormonal support, along with the CTD medications and so on, and anticoagulant therapy. But after 3 months, in general population, there is no difference between the pregnancy progression in a natural conceived pregnancy versus IVF. But in rheumatological disease patients, they are highly likely to develop preeclampsia, low birth FGRs and so on, and thrombosis. Therefore, they need more monitoring, they need more surveillance. They are high-risk pregnancies. They need to be seen by a specialist obstetrician in liaison with rheumatologists and other multidisciplinary specialists.
Right, ma'am. And one question, just for an overall understanding, one of the challenges that we would face is the cost barrier to these therapies. So how would we bridge that? Are there any options available?
Yes, it is an expensive option of IVF. Other alternatives we can offer is IUI with donor, the lesser options. But in her case, her ovarian reserve is low. So therefore, if you go for donor oocyte also, she has to embark on an IVF. Sure. It is an expensive option.
Okay, thank you.
Thank you. As a rheumatologist, I would just like to make two statements. One is that hydroxychloroquine is the health insurance for all of our patients with CTDs. So they should be on hydroxychloroquine, especially in women who are planning pregnancy, unless there are absolute contraindications like macular toxicity and other things. And second is, consider aspirin in patients who are going or planning pregnancy once they are conceived, even if you feel that there is no APL positivity, or because the pregnancy itself and the disease itself is a prothrombotic state. So 75 milligrams of aspirin, if there is no bleeding, spotting, may be a safe choice, and depending on how the pregnancy is progressing, we can think about increasing the anticoagulation or adding further agents. Before we conclude, if there is any questions from the floor, we can take 2 questions. We've got 1.5 minutes left. I think this session was fantastic. All doubts have been cleared. And with that, I would like to thank the speakers. Thank you.
The next section would be on immunogenetics and reproductive medicine. This session explores immunology and genetics at the interface of reproductive medicine and autoimmune diseases. To begin with, we have a session introducing the immunological basis of recurrent pregnancy loss and infertility, setting the stage for a deeper understanding of underlying mechanisms and clinical implications. May I invite Dr. Meghna Gawali, Associate Professor in the Department of Rheumatology at Nims, to please chair the session.
I invite Dr. Sunita, Senior Consultant Rheumatologist at Continental Hospital and Visiting Consultant at Fernandez Hospital, Hyderabad. Her areas of special interest are reproductive rheumatology, inborn errors of immunology, and inborn errors of immunity and lupus. Dr. Sunita, over to you for your talk.
Thank you, Dr. Meghna. At the outset, I would like to thank the organizing team for giving me this opportunity. So, from the morning, there has been lot of clinical discussions which were happening. Now it is the time to, move to the basics. I know it is a very dry topic, but I tried my best to simplify it. So coming to the topic, we know that the fetus is semi-allogenic. That means the fetus has half of the antigens from the mother, that is considered as self, and half of the antigens from the father, that is considered as non-self. So normally, if there is a normal immune system, what happens? Because the fetus has 50% of the maternal, 50% of the non-self antigens, it will reject. So if you look at if there is a normal or normal to high immune response, the positive effects would be the deletion of the pathogen, that is good, but the negative effect would be the fetal damage or the recurrent miscarriage. Then what will happen in the pregnancy? Do you think there won't be any immune response at all? If there is no immune response, there is no immune response at all, there would be a positive effect that the fetus would be survived, but the negative effect would be there won't be any, the deletion of the pathogen. So what happens, luckily, in the pregnancy is the immune facilitation, wherein the pregnancy is so modulated such that there will be an immune defense in order to clear the pathogen. At the same time, there would be specific immune tolerance in order to protect the fetus, so that the growth of the fetus and the protection of the pathogen, they are balanced. So, and where does this balance happen? This happens at the feto-maternal interface. So there are many immune cells which are involved in actually regulating or modulation of this particular immune regulation at the maternal fetal interface. So in the next 15 minutes, what I would be doing is to know what is the role of the each cell type and the way how do they communicate. And as I said that it happens at the maternal fetal interface, that is at the placenta. So it is important to understand what actually happens at the maternal interface, so that you know how the immune cells are actually doing there and they are creating this particular balance. So if you look at the early the implantation or the placentation process. After fertilization, what happens is then there is a formation of the blastocyst. So you will see a inner cell mass and an outer cell mass. Inner cell mass, it will form an embryo, and the outer cell mass becomes the trophoectoderm. So what happens is, in the initial phases, the blastocyst, it comes and attaches to the decidua, that is the endometrial part of the fetus where it receives. Then it comes in adhesion first, then it attaches, then a process of endometrial invasion happens. There will be creation of the inflammation. So if you look at this particular interface, if you look at in a zoom view, you will be seeing lot of immune cells. So for this process to happen, there are the immune cells will go there and orchestrate this particular immunological processes. There is another important process which is very important to understand, is the placentation. In the placentation, again, the spiral artery remodeling is one of the important thing which happens. So if you look here, this is the trophoblast area, and this is the endometrium and the myometrium. So when the trophoblast is here, during the phase of the placentation, what happens is the trophoblast stem cells, they form a layer of the cytotrophoblast. Then again they divide and they form something called syncytiotrophoblast, and then they form a villi that is called the extravillous trophoblast. So why this proliferation happens is, these trophoblasts basically they invade into the spiral arteries and they form something like this. So what actually happens is, arteries are usually, we know that they have something called intima, then elastic lamina, and the smooth muscle cells. So in the spiral artery remodeling, what happens is, the immune cells create such an environment that they will be losing the smooth muscle cells, and there will be a conductive channel which will happen, which will have a broader lumen, and it is less constrictive. So from the spiral arteries, which are muscular and vasoreactive, where the blood flow is pulsatile and restricted, the immune cells will make them into an artery which are dilated, flaccid, contractile, so that there is very good, the nutrients, and there is very good flow of the oxygen between the fetus and the placenta will happen. So coming from here, so here, at the maternal interface, the immune cells are there. So the recruitment of the immune cells from the bloodstream has to happen to the maternal interface. So who actually does this is the trophoblast cells. So when such an environment is created, the trophoblast cells are the main or major orchestrators, where they actually recruit these NK cells, or the T cells or the B cells, depending upon the requirement. And they basically secrete chemokines and interleukins, which actually drive to a particular phenotype, so that the environment becomes tolerogenic. So coming to one particular immune cells, that is the uterine dendritic cells. So what is the role of the uterine dendritic cells in the maternal interfaces? So as I have said initially, there is a blastocyst which has to roll, and which has to get attached to the maternal decidua. So what a dendritic cell does is, it will produce the chemokines, and so that the rolling over the endometrium happens, and the proper adhesion happens, so that it gets implanted into the endometrium. And it also has a role that it removes the mucin over the endometrial layer, so that it actually improves with the adhesion process. Along with this, what is the other property of the dendritic cell is, so as soon as the seminal antigen enters into the uterine cavity, so this particular antigen is taken by the dendritic cell, because we know that the dendritic cell is the antigen presenting cell. It takes it to the lymph node, and it stimulates the Treg cell production, and the Treg cells, we know that they are involved in the tolerance mechanisms. So this is another function of the dendritic cells that we know. So coming to the other immune cells, that is the decidual macrophages. We know the macrophages are involved in the phagocytic function, but in the uterine environment, the macrophages have a certain phenotype, that is an M2 phenotype. This particular M2 phenotype is again, again influenced by the trophoblast. So what a macrophage does in the uterine maternal interface is, it kind of, it helps in the trophoblast invasion, that is the spiral artery remodeling. And during the process of the remodeling, maybe we have certain trophoblast which can undergo apoptosis. It helps in the clearance of this, the trophoblast which has undergone. Along with that, it has some antimicrobial action, and it also helps in the production of the T regulatory cells. So what matters here is the polarization. So when somebody is having an M2 macrophage, what happens is it is something like an anti-inflammatory. It helps in the trophoblast invasion, vascular remodeling, and embryo development. If you have an M1 macrophage due to some other reason, so there will be increased chance of having recurrent spontaneous abortions, preeclampsia, and premature death. Coming to the NK cells, these are the prime cells in with respect to the maintaining a tolerogenic environment. So it is better to understand what actually an NK cell does. NK cells are normally a natural killer cells. What it does is whenever a non-self cell comes into contact with it, with the help of the MHC, that's a tag to recognize that the particular cell is self cell. So if they recognize a MHC on a cell, it kinds of, it assumes that it is a self and it inhibits so that there won't be any cytotoxicity. However, if they don't have MHC, it kind of, creates certain things called perforins and granzymes so that there will be cytotoxicity and the cell will be died. So in order to have a tolerogenic environment, the NK cells in the uterine environment are designed in such a way that they are quite different from the peripheral NK cells. The differentiation basically comes with the expression of the surface, transcription factors they have. So the peripheral NK cells will have CD56 dim and CD16 positivity. If you see the UNK cells, they have CD56 bright and CD16 negativity. CD65 dim, when you have it, you have more cytotoxicity. That's why peripheral NK cells are more cytotoxic. CD56 dim will have less cytotoxic. And you don't have CD16 on UNK cells, so that the antibody dependent cytotoxicity. CD60 is basically FC gamma 3 receptor. So when you don't have that, so these cells don't have the ability to actually undergo cytotoxicity. In addition, instead of the the inflammatory action, the NK cells are basically, they secrete lot of pro-angiogenic factors and growth factors, which actually helps in the vascular remodeling and the trophoblast growth and differentiation. So the uterine NK cells are designed in such a way that they don't want to reject the fetus, and also they are creating a tolerogenic environment. So the uterine NK cells, basically they have to go and they have to recognize the fetal trophoblast cells. So how are the fetal trophoblast? They are designed in order to avoid this rejection, that we will see now. So usually, as I said, NK cell want a tag, that is MHC, in order to recognize whether it is self or not. Normally, if you see the transplant, what we do is the HLA matching, wherein we see the HLA A, B, and the C. When the NK cell identifies when there is good kind of match which happens between the donor and the recipient, there won't be any rejection. In the fetus, instead, it is designed in such a way that it don't have HLA A and B. So it evades the typical immunorejection which actually a transplant will have. Instead, it will have something called HLA C, HLA E, and G. So what happens is, it is something like a molecular handshake, wherein the HLA-G, it will bind to some kind of ligands. So this is basically the UNK surface, and this is the trophoblast surface. So the HLA-G, it binds to a type of receptors. They are called KIR receptors. So this interaction makes it to a tolerant NK cell, so that there won't be any rejection. And there are some other receptors. What they do is, because we know that the UNK cells also have to do the spiral artery remodeling and the trophoblast growth. So when these particular maternal key receptors are attached to the HLA-C, they actually promote these kind of activities which involve the trophoblast growth. So it is the balance of this particular inhibitory and activatory receptor which has to be maintained in order to have a tolerogenic environment. So if there is lot of inhibition which is happening, there are there are certain genotypes which actually detect, which kind of the KIR receptors a woman have and which kind of the HLA that it takes from the paternal origin. So if you have a maternal KIR receptor which has lot of inhibitory genes, and simultaneously if you also have a fetal trophoblast which actually has an inhibitory ligand, there won't be any activation of the NK cells towards the growth of the fetus. So it leads to defective placentation, and the clinical outcomes will be fetal death or pregnancy loss or preeclampsia. So what a maternal gene which gives rise to the killer cell immunoglobulin receptor, or what a fetal trophoblast, what particular type of the HLA antigen it requires, it basically depends upon the maternal genetics and the fetal genetics respectively. So far I have said about the innate immunity. Now come to the the adaptive immunity. So these are the cells which actually are main orchestrators with respect to the adaptive response. If you look at the grossly, the T cells are basically divided again on the transcription factors they have, and also the actions basically depend upon what are the cytokines they secrete. T helper 1 cells are predominantly pro-inflammatory. So these pro-inflammatory cells, what they do is they basically activate the cytotoxic T cells, and they can reject the non-self cells, and also they cause activation of the macrophages and are involved in the inflammation. Whereas the T helper 2 cells are the friendly kind of cells. They have lot of anti-inflammatory cytokines they release, and they're also involved in the allergic response. T helper 17 cells are again pro-inflammatory. They kind of they have an extracellular action against the pathogens, and also create inflammatory cytokines. Whereas if you look at the T regulatory cells, they actually control all these cells and create a tolerogenic environment at the maternal interface. So but we have to like initially a decade ago there was a school of thought that when there is lot of pro-inflammatory cytokines, like when there is lot of T helper 1 response, it is not good for the fetus, because it the mother may reject the fetus. Now it has changed. So because the pregnancy is a dynamic process, so is the immunological changes in the pregnancy. If you look at the first trimester, as I said, the blastocyst comes and it attaches to the endometrium, and it has to invade the endometrium. So we require some kind of a pro-inflammatory reaction, because there should be some sort of tissue inflammation, and the damage has to happen. So here we need a T helper 1 type of the immune response. Then again after that, when the trophoblast is actually undergoing a spiral artery remodeling and the invasion, those kind of the things, we need a tolerogenic kind of the response, more of a T helper 2 kind of response. Again in the third trimester, when there is going to, then the labor is going to happen, again you need the tissue inflammation, wherein the T helper 1 response again predominates, along with the T helper 17 response, which is mediated by the prostaglandins. So if you look at these kind, usually these kind of the profiles will be asked for the recurrent the pregnancy loss, wherein what we see is in the normal pregnancy there is a markedly elevated Treg cells and a controlled T helper 17 and the T helper 1 response. If you look at the pregnancy loss, what happens is there will be decreased the Tregs and elevated T helper 17s and the elevated T helper 1 cells. So what I want to emphasize is we require all the 3 cells, but in a controlled way. So if you look at in an order, we want 3 regulatory cells followed by a T helper 2 cells followed by a T helper 17 cells, and again in a designated environment as per the demand. So successful pregnancy is usually characterized by increased peripheral as well as the decidual T regulated cells and a little T helper 2 skewed environment. So as I said, this is a very, very dynamic process. So who is controlling this? So there are two things which actually control this. One is the hormones, the other one is the cytokines. So immediately after the implantation, there is a HCG hormone which is produced. What it does is it actually induces the progesterone, and the progesterone is actually, it secretes something called a PIBF, which favors the T helper 2 response. The other switch is by the cytokines. From the blastocyst implantation till till the delivery, there are a lot of cytokines which are involved. So there are few cytokines which are very, very important are, if you have more IL-6 and more IL-1, there will be a shift to the T helper 17, which destabilizes the tolerance. And TGF-beta, if it is in excess, it is good for the baby. If it is low, it is not good. And if you have more PGE, it increases the T helper 17. So these are broadly the cytokines which favors the implantation and which does not favor the implantation. And again, the people will be looking at this cytokine gene polymorphisms, which will affect the number and function of the cytokines, so that they may affect the tolerogenic environment. Coming to the last, there another function under the cell which is important is the B cells. So normally what happens is when the seminal antigen comes, seminal antigen with the HLA comes, it gets exposed to the exosomes. So what is the basic message is, usually B cells produce polyreactive antibodies. However, in the fetus, what happens is there are certain antibodies which are produced which produce immunoglobulins which are not complementing fixing, they don't have an FC receptor, they don't have a cytotoxic properties, and they behave as a paternal blocking antibodies. Why this is important is, this is basis for the lymphocyte immunization therapy that they do. So what they basically do is, they look for the paternal blocking antibodies. If the antibodies are there, they won't be doing the procedure. If the antibodies are not there, they will be basically injecting the paternal lymphocyte into the mother to create the antibodies. To conclude, this is my final message. So what we need is the better communication at any kind of interface to have better outcomes. Thank you.
Thank you, Dr. Sunita, for very nicely and beautifully explaining a complex topic and establishing pregnancy as a stage of controlled immune tolerance with uterus as an immunological organ. I have one question for you. So, how far do you think these biological understanding of immunology in recurrent pregnancy loss, how far we have come in translating it at clinical significance level, be it at the lab or in improving pregnancy outcomes? Or is it still at the research level?
I am not the correct person to answer this because I don't practice it. However, whatever the understanding that I had, going through the topic and also seeing few cases which come to us for the referrals. As I said, the pregnancy is a dynamic process. As you have seen, either it is a cytokine or it is a T helper cell which produces, a T cell which produces the cytokine. It is very, very dynamic. And it is not only the pregnancy which causes this alteration. There are certain other things in the mother which can also cause this. And again, when are you asking the test? Which particular time you are asking, and what was the procedure? I don't think we have a standardized guidelines for asking the tests. So I think we need more data to basically to ask these tests and to interpret this test, and likewise to suggest some medicines accordingly.
I agree to that. We don't have guidelines and for the testing and even for the treatment. We'll take questions at the tea break in view of lack of time.
One comment.
Yeah.
See, I think wonderful, Sintha, really excellent lecture. Like you have taken us through very bad NK cells and M2 macrophages, Th1, Th17 skewed, a lot of things. I think what you said, because the known causes, the laboratory causes, what we see, like APL, and, which are responsible for the recurrent pregnancy loss. I think this understanding these real mechanisms, what exactly is the problem, at what level is the problem, like having a very bad set of natural killer cells or very high levels of Th17 or very low Treg cells. I think understanding this mechanism will again break this recurrent pregnancy loss into different endotypes. I think this could be the future. I think I have gone through some papers where some Chinese studies are there of giving low dose IL-2, so which improves the Treg. So it itself can prevent the recurrent pregnancy loss. There are very few papers, but not a very large RCTs. So anyway, Th17 we can't target, even though it is bad. It's required for us body. I think understanding this, these mechanisms and looking at future studies where we can do the transcriptomics, and if we know the exact signatures of which are the cytokines involved, I think maybe this is a future where we might exactly target these mechanisms and prevent the recurrent pregnancy loss or recurrent implantation
so
loss.
whatever literature I've gone through reading this, so there is a Asia Society, European Society for reproductive human reproductive embryology. So they don't recommend this test routinely because they don't translate into improved clinical outcomes. Only there is definite evidence for testing and treatment for APS, thyroid related autoimmunity, and whether there is a known case of lupus or there is a suspicion of a autoimmune rheumatic disease, then you go for ANA testing. Otherwise the uterine NK cells and the Tregs and everything, they are still in the research state. And exactly as Dr. Sunita said, because the tests are not validated, there is no standardization. There are different types of assays used by different institutes. So it is still into research, but it is very well a future where we will likely have those endotypes as you were saying. Thank you.
Thank you.
Thank you. Next, we move on to a session on phenocopies and genetic mimics, focusing on their recognition and relevance in clinical practice. May I please invite Dr. Lisa Rajashekhar ma'am, Senior Professor and Head, Department of Clinical Immunology and Rheumatology at Nims and Dean Academics, to kindly chair this session.
It's my privilege to invite Dr. Shagun onto stage. She will be speaking on phenocopies and genetic mimics, overlapping phenotypes at the intersection of reproductive disorders. And as the previous one of the speakers said, we are moving from clarity to confusion, and maybe Shagun will take us back to some clarity in probably early pregnancy losses. It's my privilege also to say that
what these terms mean, so anybody can identify her. Okay. So she's a Hollywood actress. So how is she different from all of us here? So what's the most striking difference? Maybe one of the fellows can tell. So what's the most striking difference?
she's blonde.
Yeah, so she's blonde, right? So you're seeing this striking difference between her and all of us here, that she has this light color hair. So this is something which is part of a normal variation, which is just a racial, a kind of a difference, which is a normal variation, which is, due to the, hailing from different backgrounds and all. And I'm sure everybody will identify her. So what we see here is, and we all know youngsters, so who are now bleaching their hair, and we can see that this is an Indian origin actress, and she also has blonde hair, right? So this is something which we call a phenocopy. So an environmental influence or something external which produces the same outcome or the same phenotype. Phenotype being the technical term here is, or what you can actually see. So that's what we call as a phenocopy. And this is another photograph of, again, an Indian individual, but this lady has a genetic condition, and this condition is called as oculocutaneous albinism. And this lady also now is having blonde hair. So this is now a pathogenic genetic variant, which is again producing the same phenotype, and sometimes we can also call it as a genocopy. Okay, so, and the crux of all these three, so how do all these three, why are they here looking similar? Because it is all determined by the amount of melanin there. So due to racial variation, there is a decreased melanin in the Caucasians. You can do the same thing by applying bleach to your hair, and then due to genetic mutation in the melanin gene, again you have the same outcome. So what we see as clinician is the phenotype. But then it's important to understand what's causing that phenotype, and my talk is going to focus on the aspect that at times in pregnancies you would have certain phenotypes which could look like phenocopies or could be look like external factors, but actually genetic. And why it's important to recognize these and differentiate these two aspects and how does it really help the patient. Okay, so again, this is for fellows. I hope some of the fellows are able to answer. So what we are seeing here are some very severe limb defects. This is the original paper describing this. Anybody can name what is this? Okay, this is thalidomide embryopathy, right? So this drug which was given in that 1950s, 60s and caused at least 20,000 babies to be born with these kind of limb defects. Okay, and this is now a family actually where the parent and the child have similar kind of limb defects, and this is actually due to a genetic mutation in the SALF4 gene. Okay, so what we are seeing on as a thalidomide embryopathy, that's the phenocopy. And what we are seeing on the other hand is, a genetic condition. Both are looking similar. Why do they look similar? Because the thalidomide also acts to inhibit SALF4. So that's the molecular pathway or the molecular pathogenesis which is acting here. The end result of the genetic mutation and the end result of thalidomide is that SALF4 gene is not able to function, and it further causes some downstream changes, and that's what results in the limb defects, what you are seeing as the phenotype. Okay. So just to kind of, understand this whole concept that usually most of these things would converge on the same cellular or molecular pathway, whereby even a genetic mutation or an environmental influence or sometimes a combination of these, what we call as polygenic multifactorial, would be resulting or impacting the same cellular pathways, the same molecular pathway, causing the same end result in terms of the phenotype. And then, again, it's, what we call as phenocopies or genetic mimics is, as a perspective. For me as a geneticist, I look for phenocopies. For ma'am as a rheumatologist, she would be looking as in her patients, are there any genetic mimics in her, it's a matter of where you are sitting and how you're looking at the patient, but the end point is that we should all be thinking in the similar direction and think of both the perspectives so that we are able to give comprehensive care to our patient. So then I'll just take you through some 4 cases to understand, how there can be these overlaps between the phenotypes what we are seeing. So we'll see in reproductive phenotypes, basically RPLs or FGRs or abnormal ultrasound findings or even late pregnancy losses, how all these scenarios, most of you are familiar with the immune aspect, but how genetic conditions could mimic and result in all these different phenotypes. So this is the first family. This was a non-consanguineous couple, and they have had 3 first trimester miscarriages. There is no other comorbidity in either of them, and the only interesting thing is that there is a history of infertility in the female partner's sister, and actually one of the losses was a terminated pregnancy due to a neural tube defect. So that's all the information we have, and the only the only one thing which could raise suspicion of genetic condition here is the infertility in the wife's sister. So if we look at etiologies of RPL, acquired etiologies are there. Those in fact predominant, and APS is one of the most common causes. But genetic etiologies are also important. But we also need to understand that around 50% of RPL still remains unexplained. And this is a guideline given way back in 2012 by ASRM, and this still holds true and is one of the best guidelines, I would say, which is there. Of course, there have been guidelines by ISHRE and RCOG recently, but most of these guidelines, of course, focus on the fact that the acquired etiologies are really common, of which APS predominance, and we really need to make sure all patients do go through all this. But then we also need to understand where does genetic testing come in. So in this particular couple, the acquired workup was completely normal. So then what we always do is a karyotype of the couple. So here's a karyotype whereby the husband's karyotype is normal, but the wife has something we called as a reciprocal translocation, whereby we are seeing that there is a exchange of some genetic material from here, the 5th chromosome to the 10th chromosome. And this is what is in the notation written here as translocation 510, and this is a reciprocal translocation. So such translocations are very common. 1 in 625 individuals will have such translocations, but if we look at their prevalence in couples with RPL, it's 2 to 5%. So either partner could have such a translocation. This individual who has this translocation is going to be phenotypically normal because they have not lost or gained any DNA material. Their DNA is just rearranged in a different way. So, but when such a person tries to reproduce, then there will be problem during meiosis as to how these two the chromosome pairs, how do they separate together, because in meiosis we know that the two copies of a particular chromosome go to two different daughter cells, or that's a meiosis reduction division, meiosis 1. So in this case actually that gets really disrupted, because these 4 chromosomes now, they kind of form something which we call as a quadrivalent, and that causes a lot of problems in how they go on to the daughter cells. So there's something called as alternate pairing, which results in normal gametes, whereby the gamete gets either the both normal chromosomes or the both translocated chromosomes, just like the pair in this one. But there is something called as adjacent pairing, where you have these gametes who are having some partial trisomies, monosomies, that is some extra materials are coming or some material is not coming due to the way these chromosomes go to those gametes. So actually such couples can give rise to 16 different possible gametes, of which 4 are usually non-viable, 2 are normal. Okay. And then there are 10 gametes which can have spectrum of phenotypic outcomes depending on how much genetic material is extra or lost. So this could range from kind of a failed implantation or occult miscarriage, which is manifesting as infertility, or as recurrent abortion as we saw in this couple, or even as late pregnancy losses, abnormal ultrasound findings, or sometimes what is most concerning is a live abnormal a child who will be having intellectual handicaps. So which is something which we want to prevent at all costs. Okay. So this particular couple, again there are figures available for miscarriages, usually 25 to 30% is the chance of miscarriage. Again the good thing is that the chance of a normal offspring is very high. It's around 50 to 60%, because nature favors the normal gametes. So what are the options for such a couple? Either they go for a spontaneous pregnancy, and then we do prenatal testing, because we want to prevent the birth of that live abnormal child. So that's very important, and that's the reason why we would always do a karyotype. Even if you find APS in a patient with RPL, you still have to do a karyotype. One patient can have 2 diseases coexisting, and you have treated APS, taken her through pregnancy, and you are landed with a child who is intellectually handicapped. That's something which is easily avoidable. So we need to do a karyotype for all such couples. Other options are IVF with PGT-SR. So here the couple actually opted for spontaneous pregnancy, and unfortunately in the next pregnancy the baby had multiple malformation, and when we did a POC karyotype, this baby did have one of the type of adjacent segregation leading to an abnormal chromosomal complement. So if we see overall what is the contribution of genetics to abortions versus recurrent abortions, okay? So if you take even one sporadic abortion and you do a karyotype, 50% will have some chromosomal abnormality, okay, which could be of different types. But if you have a RPL is usually caused because one of the parent has a balanced rearrangement. RPL is not caused by recurrent trisomies, recurrent monosomies and all. It is mostly due to a parent having a balanced rearrangement. That is why we advise testing of the parents and not the POC. So what testing needs to be done for early RPL? Karyotype for both partners. That's the main test which is needed. Inherited thrombophilia workup is not advised, except when you really have a history which is strongly suggestive of a thrombophilia. So again, to reiterate, this has to be done even if an acquired cause is found. Now we move on to the second scenario. This is a consanguineous couple referred in pregnancy, 23 weeks gestation. Again, Dr. Aarti has already shown her case. So this is basically binder phenotype. We see this fetus who has this really flat facial profile and which you can see in 2D also. And this is sometimes very alarming for the parents to see. And this fetus did have multiple epiphyseal stippling in peripheral joints as well as in the spine. But luckily its biometry was all good, corresponding to gestation. Dopplers were all normal. So the ultrasound phenotype was basically chondrodysplasia punctata with a binder facies. So now again this, you have already seen this etiological spectrum, that how so many different conditions can result in the same phenotype in the fetus, and you can see many of them are genetic. Most of them are actually single gene disorders which will not come in karyotype or microarray, and you need to do a whole exome. Some of them are common chromosomal abnormalities. And then we have this part where you have the maternal CTDs, maternal warfarin embryopathy, and even vitamin K deficiency due to various causes, again causing the same phenotype. So this is what is basically, what the term which I was telling, a phenocopy. Okay, so which environmental influence mimic a genetic condition. So here, but the genetic workup was negative, and in fact, this lady did have a subclinical SLE or preclinical SLE, whereby her anti-RNP antibody was positive. I'm sorry if I've used the wrong term. So this is something which we are seeing very commonly. So then we had referred them to rheumatology, and she was started on HCQ. And then on follow-up scans till 28 weeks, all was looking good. So we have, in fact, at present more than 40 cases with binder. Many of them children have been born. This is a little older data, whereby we did in 24 cases we had done RNP antibody in around 11, of which around 6 were positive. So in fact, what we found in this shorter study here is that the most common cause of the binder phenotype is maternal CTD and not a genetic condition, and the other common cause is just a normal familial variant. So in fact, we can reassure or treat most of these conditions, which does kind of clinically look to the patient sometimes a little alarming. So just to again reiterate the fact that why are these things looking similar? Why are these genetic condition and these environmental condition giving the same result? So again, this is this group of condition where the end point is that the vitamin K metabolism cycle gets disturbed. So this is the vitamin K, the pathway whereby the end result is this particular protein, which is important for calcium formation. And this is what, whenever this pathway gets disrupted, you get this epiphyseal stippling, and you get that cartilage of the nasomaxillary cartilage gets disrupted. So this end product gets abnormal whenever there are mutations in this VKORC gene, ARSC gene. So these are genetic diseases resulting in the same end result. Whereas again, dietary vitamin K deficiency, warfarin, which again inhibits this VKORC enzyme, or maternal CTD also disrupts this cycle. So all these things also converge on the same end result, that this particular MGP protein is not able to function, and it causes these same outcome in terms of the phenotype. So now to move on to this third scenario, this is a lady who is consanguineously married, and she has already lost 2 babies. The first baby actually had some mild ventriculomegaly in TIFA reported, and with some echogenic bowel loops, and they terminated. And the second pregnancy, actually there was fetal growth restriction with oligohydramnios, with poor Dopplers, and then resulted in an IUD at 30 weeks. And now in the third pregnancy, she already is actually having a missed abortion at 8 weeks. So there is another interesting history here, that in the second pregnancy, the mom had CSVT episode, and she had presented with hemiparesis, which had subsequently improved. So this is the whole pedigree of the family. You can see the consanguinity, these 2 lost pregnancies, and this also now is basically a missed abortion. So here again, given the history of CSVT, given the history of those abnormal Dopplers, the IUD, first thing which comes to mind is APS. So, but the workup here is normal, hormonal profile is normal, homocysteine is normal. So now, as geneticists, we always dig a lot. So we ask patients for all kinds of things. So here we ask them to come up with the photographs of the previous 2 babies who had never been worked up. So ideally, every pregnancy loss in beyond 12 weeks needs an autopsy, needs a genetic workup, which is unfortunately not being done in most of the cases. So this is the first baby which had ventriculomegaly on scan, and we see a lot of dysmorphism here. There is a sloping forehead, a beaked nose, a overhanging philtrum, and dysplastic ears. And the most striking thing is what you see in the feet of the baby, where this seems to be some amputations. Okay, so this is looking like a baby who has a dysmorphic syndrome. This is a second baby. Unfortunately, they had covered the legs only. This was the one photo. In the hands, there was nothing wrong with the digit. Feet we could not see, and they could not tell. Face, we felt that it looked somewhat similar, but we're not sure. Sometimes FGR babies also give the similar kind of appearance. So there was no workup. We did not know what had gone wrong. So couple karyotype was normal. So because acquired thrombophilia was ruled out, we did inherited thrombophilia, functional assays. These were normal. So then we went ahead to do an exome sequencing of the couple for carrier screening. Okay, so what we find here are 2 things which I've highlighted in red. So the first thing is that both of them are carrier for this genetic condition, which is Adam-Oliver syndrome, and this is basically a condition which explains explains the phenotype of the first baby, because this classically has this limb amputation. Okay, so with some FGR can be there, ventriculomegaly. So this is kind of is giving us a window into what happened to the first baby. And then we see this another mutation here, which is in the wife, and this is basically associated with protein C deficiency. So this is something now we are correlating with the probably the second pregnancy. So this is the Adams-Oliver syndrome. So this an autosomal recessive condition, and this is what was consistent with the first baby's phenotype. And the second mutation, basically, we are now kind of interpreted that possibly she has a functional protein C deficiency, which is not coming in the assay, and the second pregnancy course and the CSVT is probably related to this. So then that's what was the conclusion we had made for this case. And then now as this Adams-Oliver syndrome is a recessive condition, so for this she needs to undergo prenatal testing in every pregnancy, which can be done at 12 weeks. And for the inherited thrombophilia in the mother, that's a protein C deficiency, so we had advised her in consultation with our hematologist for a low molecular weight heparin and aspirin. So now in the ongoing pregnancy, she had come to us, so started on the anticoagulation. The first trimester scan was normal, CVS could not be done due to an inaccessible placenta, so we called her for an amnio. And at the time of amnio, the early TIFA actually, the digits all looked to be good, so we were hoping that the fetus is not affected, and luckily the fetus was only heterozygous carrier for the variant and not affected with Adams-Oliver syndrome. So subsequently she went on to have a healthy baby, and I mean she did continue the anticoagulation in pregnancy. So this
Dr.
is
Shagun, you'll have to.
Yes, ma'am. Yes, I mean just one more scenario. I'll finish in 5 minutes. So this is just to say that how the inherited thrombophilias again can mimic APS, but typically the risk with inherited thrombophilia is believed to be medium or low risk, whereas APS is a very high risk. And this is another case where first baby with FGR ended up with a stillbirth, second fetus referred as again FGR, but what we see here is that it's basically the long bones which are lagging and not the AC and other biometry. Dopplers are normal, and the baby did have other features like a narrow thorax, echogenic kidneys, and what was most interesting was this. I'm sure many of the ones as fellows here hopefully will spot this. This is a polydactyly. So this case now from going on from FGR becomes a skeletal dysplasia, and because there is a polydactyly, there is a renal abnormality. This is basically June's asphyxiating thoracic dystrophy. The autopsy was also consistent, molecular diagnosis also consistent. So there are various genetic mimics of FGR, which includes skeletal dysplasias, chromosomal disorders, and so many other monogenic syndrome. We need to look at the findings if Dopplers are normal or abnormal, amniotic fluid, maternal morbidities, and whether there are, so these, if these are abnormal, it's probably insufficiency associated. If there are malformations, soft markers, disproportion, recurrence, consanguinity, then it's probably genetic. So genetic evaluation again is really important for intervention for recurrence counseling. And this is an unsolved case. I just wanted to show you that despite doing everything, sometimes immune workup, genetic workup, at times we really can't help some cases. So this lady was gravida 10, lost so many babies, and in between there was a 30 weeks FGR baby which started within at 18 weeks, as early as 18 weeks, with oligo FGR, ended up with the IUD, and placenta also showed uteroplacental insufficiency, had APS, started ecosprin heparin, but the last pregnancy when she came to me, she actually had malformations. So we did amniocentesis, so very early onset FGR this is, and however microarray, exome, everything was normal, and family was very keen to continue pregnancy. We kept following her, this baby did not grow at all, and then this malformation was also there, so we're very strongly suspecting this is something genetic. And unfortunately by 23 weeks she ended up with AEDF and also started having CNS
Dr. Shagun, I think we'll have to stop you
Ma'am,
here
ma'am,
because
yeah. And this is my last slide. Yeah, so this is just to say that, you know, sometimes some patients can have features of both, and it's really difficult to differentiate. So we really need to take proper history, do detailed phenotyping, and understand that, you know, we need to distinguish these two parts because the management differs and subsequent counseling differs.
Thank you very much for a beautiful exposition of how, I mean, it is important to be aware of those red herrings hidden in the history and the difficult course of these patients. In the interest of time, we will not allow questions from the audience, but we would like to say that the next session with panel discussion would have a lot of discussion on binder fascies. If you have the time, please do stay back. Your comments will be really valuable. Thank you very much. I hand this session over to the organizers again, the stage.
Thank you, ma'am.
Thank you.
We now move on to one of the highlights of this session as well as today's program as a whole, a case-based discussion on complex pregnancies and autoimmune rheumatic diseases, including anti-Rho positive pregnancies, binder phenotype, systemic sclerosis, Takayasu arthritis, and spondyloarthritis. These cases will be presented by our rheumatology team at Nims, along with obstetric medicine fellows from Fernandez Hospital. The rheumatology team includes Dr. Srilekha, Assistant Professor, and Dr. Abhishek, Senior Resident, and Dr. Mahesh, Senior Resident. The obstetric medicine team includes Dr. Shruti B. and Dr. Priya S. These cases will then be discussed by our esteemed panel, bringing together multidisciplinary perspectives to address the clinical challenges involved in managing these high-risk pregnancies. I would first like to invite our panelists onto the stage. The moderators onto our stage. May I please invite Dr. Shravan Kumar Appani, Consultant Rheumatologist at Rishi Rheumatology Hospital, and Dr. Rama, Consultant Obstetrics at Fernandez Hospital, onto the dais. Next, I would like to invite the panelists onto the stage. Dr. Lisa Rajashekar ma'am, Senior Professor and Head, Department of Clinical Immunology and Rheumatology and Dean of Nims. Dr. Rajendra Varaprasad sir, Senior Consultant Rheumatologist at Yashoda Hospital. Dr. Tarakeshwari ma'am, Senior Consultant Obstetrics and Head of Obstetric Medicine at Fernandez Foundation. Dr. Sarita, Fetal Medicine Senior Consultant at Fernandez Hospital. And Dr. Ravali, Neonatologist at Fernandez Hospital.
Myself, Dr. Srilekha, and I'll be presenting the first case for this panel discussion. The patient is a Rho positive pregnancy, and the patient is a 29-year-old woman with SLE, symptomatic since 2016, with manifestations of malar rash, discoid rash, and there is a photosensitivity with urticarial vasculitis and alopecia and inflammatory polyarthritis. And obstetric history in 2018, first pregnancy, it's a spontaneous conception. At the 8th month of gestation, there happened a fetal hydrops and congenital complete heart block, and the labor induced but resulted in a stillbirth. And after 3 months of this termination of the pregnancy, she came to Nims and the workup was done. Investigations revealed anti-Rola positivity and also anti-Smith positivity. Anti-DSDNA was negative and her APS workup was negative and complements were normal. She was managed with low dose of steroids and hydroxychloroquine. And in 2024, she conceived spontaneously again, and repeat anti-Rola antibodies were positive. And given her prior congenital heart block, hydroxychloroquine dose was increased to 300 milligrams, and she was maintained on low dose of the steroids and antiplatelets. She was on regular follow-up, and she underwent regular fetal echocardiac monitoring also. At the 28 weeks of gestation, there happened a premature rupture of membranes and oligohydramnios, and emergency C-section was performed, and she delivered a female child with a low birth weight of 1 kg, and baby required an NICU stay for 2 months. Now the baby is of 14 months old and is doing well. Patient had an cutaneous flare postpartum, and she was currently on low dose of steroids and azathioprine and other supportive treatment. Thank you.
Good afternoon all, and these questions we framed by seeing these cases and which we face difficulty in daily practice, and we'll take expert opinion and how to manage these cases. So we'll go with questions. As you said, anti-Ro pregnancy, the main problem with the anti-Ro antibodies is they cross the placenta in the first trimester, and by two hypotheses. One is adipocyte apoptotic cardiomyocyte hypothesis and calcium channel hypothesis. There are two hypotheses which explain these conduction abnormalities. So with brief introduction, we'll go with the questions like what are the fetal risk you see in a patient with anti-Ro pregnancy, and what are the manifestations of neonatal lupus which are reversible and irreversible, and what are the cardiac manifestations. So we'll go with the panel.
So this, from the history, from the case presentation itself, we came to know that at 28 weeks there was high drops. So the cardiac manifestations which can happen as early as from 16 weeks is the effect on the conduction system of the heart as well as the endomyocardium. It presents as increased or prolonged PR interval or the heart block, which can happen at various degrees, or there can be endomyocardial fibroelastosis, or there can be high drops, there can be a dilated cardiomyopathy, or there can be effect on the valves as well. So when the valves are affected, there can be AV valve regurgitation or the thickening of the valves, which we can see on scan. So these are the cardiac manifestations. Because of the effect on the placenta and the uteroplacental insufficiency, we also can have fetal growth restriction. And as we have learned from the previous lectures, there can be effect, and then chondrodysplasia punctata features also can be seen in the intrauterine period.
So what are the manifestations of neonatal lupus?
Coming to the manifestations of neonatal lupus, the serious manifestation we are concerned about will be usually the cardiac manifestation. So of this, all the, like ma'am said, all the heart blocks are possible. So probably if it is first degree or second degree heart block, then still the prognosis would be good. So most of them, though we monitor them for progression because the antibodies of the mother do persist till 3 to 6 months, but most of them do good. But third degree or congenital complete heart block or Mobitz type 2, these are the serious manifestations which are irreversible and have to undergo. And other reversible things can be, they can be skin manifestations, and sometimes count cytopenias can be there, but most of them are usually transient, might subside with some mild IVIG or steroid or nothing at all.
So summarizing on this, the main things were cardiac manifestations, and if you see third degree heart block, it is mostly irreversible, and other non-neonatal, non-cardiac manifestation like rash, liver involvement and hematological are mostly self-limited and reversible. And the risk of this CHB, if you see in first time versus recurrence, in the first row, if you detect a asymptomatic patient with Rho and previously no obstetric morbidity, so the risk of CHB is around 1 to 2%. But if previous child is affected, the risk increases up to 15 to 20%. So here the main risk factor is if previous affected fetus is there, that implies a major risk to the subsequent pregnancy. So what antenatal monitoring is recommended for a Rho positive pregnancy?
Yeah. So the earliest heart block which can develop is from 16 weeks onwards. So we monitor the PR interval, which is an equivalent to the PR interval in the adult. So we have to up as per the gestational age when the prolonged PR interval is there. Usually more than 150 milliseconds for all gestational ages we consider as a prolonged PR interval. And then the second degree block, still we have HCQ and then dexamethasone which can affect and then stop the progression to complete block. When complete block develops and there is endocardial fibroelastosis, then there are therapies, the emerging immunoglobulins. To some extent, the myocardial changes can be changed. So every week we monitor for such cases where there is a previous affected pregnancy till 24 to 26 weeks of gestation, as most of the time 75 to 80% of the blocks will develop by this gestation. And then around 20% of the cases the late manifestations also may be there, but usually we are monitoring weekly for previous affected pregnancy till 26 weeks of gestation.
So this, as we know that this first degree or even fetal bradycardia can transform into a heart block or third degree heart block very rapidly. Even it can happen in 1 to 2 days or 72 hours. So they even recommend twice weekly if there is a severe indication. And what about this new concept of home monitoring, handheld Dopplers for the high risk previous CHB patient? These were given in the literature. So are we practicing it or is it recommended?
This is like a double-edged sword, and then there is it has not come into practice, and we may miss a case of IUFD as well with this type of monitoring, so we are not recommending. It's not advisable.
Okay.
So one small thing here would be that some of these patients, when they become adults, like around 14 to 15, at that point they may manifest the first signs of cardiomyopathy. So a little bit of monitoring will be required if you have detected even a first or a second degree heart block which has reversed during the early period. In contrast, if you've had a rash or you had a liver abnormality, those are patients you're not concerned with. They usually don't develop a lupus as they grow older.
Yeah, because that fetal maternal antibodies clears by 6 to 8 months, so we don't see that risk.
So can I ask a question? If somebody at 24-year-old comes for antenatal booking and she has a congenital heart block, do we do the ROLA antibodies in her?
Yes, of course. We'll have to find the etiology of the complete heart block and you might find an antibody. In fact, children when they are born with complete heart block, the mother is tested for the antibody. And these mothers may be carrying very high titers of antibody and they may be completely asymptomatic. And literature says, and we have personal experience, when they go on to develop either a Sjogren's or a full-blown lupus in the coming years.
Yeah, we had such scenarios where the baby was born with a heart block and then we went and did the ROLA antibodies in the mother, and the lady came for booking and she has a heart block, and then we have done the ROLA antibodies. So it's either ways. I think we need to understand that point, what you have addressed. Anything, Ravli?
Like 70 to 80% of the etiology for complete heart block would be mostly autoimmune related. Rest 20 to 30% can be genetic, other conditions also, but majority you have to rule out this.
We'll move on to. So we'll ask Dr. Vara sir. So is there any difference between this Rho 60, Rho 52 and La antibodies on the risk of this heart block, and does the titers of these antibodies matter?
Yeah, among all the three, Rho 52 has been proven to be having the highest risk of causing a congenital heart. And the next one is anti-Rho 60 and anti-La competent antibody, and on its own I don't think it is not reported to be pathogenic on its own, and usually the titers are also very less in most of the patients. And yes, the titers do matter, and the higher the titer, the higher the risk of clinical manifestations. And clinically, we have seen patients whose titers decreased on ELISA with hydroxychloroquine. So, from the therapeutic point of view, that can help. We will not go
Ma'am, is there any cutoff, any defined definition for cutoff, or it is not much defined?
I'm not.
One more question patients asked to us, if we give rituximab prior to the pregnancy, are we going to reduce the risk of the neonatal lupus?
There is no data, first of all, and because there is a proven drug, hydroxychloroquine, if you really know the patient is positive, that would be the best thing to do. And it is I don't think we can even try even in the most difficult case.
Yeah, true, sir. Because it is not recommended. Even if we target by giving rituximab, we are targeting the CD20 B cells, not long-lived plasma cells, which are the main source of antibodies. So we are not going to clear the antibodies even if you give rituximab prior. And again, safety considerations comes with fetal B cell depletion as a complication. So indications of permanent pacemaker in congenital heart block cases.
Complete heart block is a definitive type 2B and type 2B morbid is also an indication. Usually first degree and type 2A, sometimes they remain asymptomatic and they require monitoring like all through life, but these are definitive indications. And other than that, the heart rate, if it is absolutely less than 55, if neonate is having LV dysfunction or high drops, it is already evident, long pauses, wide QR, we do go for pacemaker. But it is not like pacemaker has to be placed immediately after the baby is born. So we see for the heart rate, and if at all baby is not having any LV dysfunction, we do follow up with them. So because always if we do it early, it has to be epicardial pacemaker, and that can have complications more. So they try to do at least till the baby is grown up to 15 kgs, so they go for endocardial pacemaker.
And role of HCQS, steroids, IVIG, plasmapheresis. Is there any role? Does this reduce the risk of the neonatal lupus?
So, as you said, there is a study which talks about, and that is the best evidence, and that is for hydroxychloroquine, as we've already said. About rituximab, absolutely no evidence. There are other complications the neonate may land in. Steroids, we already know. But I think you would be a better person to talk about your experience with IVIG here. In terms of giving it systemically, there are many studies which have given it and shown that it is not effective. But in terms of what we heard this morning about intraperitoneal injection of IVIG, I mean, it reduces the obvious dose. It goes from 2 gram per kg of the fetus to, 2 gram per kg for the mother to 1 gram per kg for the fetus. So that makes it feasible in terms of cost, but in terms of efficacy and biology, Dr. Shravan.
So, as we discussed, HCQ is the only proven thing which can reduce the risk. But we have to start by 10 weeks, before 10 weeks of gestation, or at least by 10 weeks of gestation. And it can reduce up to 50% of the chance. Even the studies have shown that recurrent heart block was 7.4% when compared to the traditional risk factor of 21%. And IVIG, again, the effect, it is controversial. Some studies say it is okay because it is all case reports and very few case series have shown some benefits. So this was a study in which the mother was given IVIG 2 gram per kg over 4 days at 12th week, 16th week, 20th week and 24th week, and all the patients were having prior 3rd degree heart block and no child was alive. So 9 patients were given this, and the outcome was all patients were born with normal heart rate and no complete heart block. So this study was published in 2023. So only it was 9 cases because this entity is very rare, and finding the cases and giving the timely drug again it is very rare. So This is the only largest study I could find till date. But again, based on this, we cannot conclude to any result. And another is fetal intraperitoneal immunoglobulin. So in this, we'll administer the IVIG into the intraperitoneal. So this can block the Fc gamma receptors and inhibits the complement activation and reduces the inflammation. So this is the theory. So here 5 cases were administered intraperitoneal IVIG, that is 1 gram per kg, and based on the assumption of that fetal weight which was there at the time of the administration, and most of these cases the IVIG was administered around 21 to 27 weeks, and the resolution of hydrops in all cases were noted, and regression of the endocardial fibroelastosis, and also the restoration of normal sinus rhythm in 2 cases with second degree AV block, and there were no procedural complications occurred. But it is considered as a rescue or adjunctive therapy only in high risk patients. It cannot be used as a first line prevention. So one of 2 cases were my cases from my clinic, and one patient had complete successful pregnancy and the baby was also fine. I have seen her, and at 8th month the baby died because of pneumonia and also diarrhea due to infection. Otherwise the baby was healthy till 8 months. So this is a new therapy. So the results, whether we can take it into consideration or not, I don't know. And this patient which I am speaking, she is now completely stable, and she is on azathioprine and HCQ and omnacartil 2.5 alternate day, and completely in remission from almost 1.5 years. Now patient wants to conceive again. So what is the best idea? How should I approach? Because the patient had previously 3rd degree heart block with hydrops and received intraperitoneal IVIG. The mother was asking whether should I go the procedure again.
I think we'll have to go a lot of back and forth to answer that question, so we'll drop it because the time is up. But it's definitely a very interesting clinical scenario. But I'm not sure whether we'll have the courage to do the same experiment again. But that will be your call as a clinician.
No, ma'am. Whether is it ideal to give maternal IVIG, not fetal? So is it that much beneficial or not?
For the 9 cases that you've shown as success, which is obviously peer reviewed and published, there are n number of cases where there is no success.
Yes.
Many failures. So it cannot be unless there is a meta-analysis which says that of all the published studies, there is significant benefit of IVIG. So maternal IVIG, no.
No. Only HCQ. And what are long-term outcomes in this patient with neonatal lupus? We already discussed this one. So we'll skip this one. And one last question, ma'am. Is there any future autoimmune risk in these patients with neonatal lupus?
We've discussed that most of them will not have.
Will not, yes. Their absolute risk is very low. So we'll go for case 2.
Good afternoon, everyone. Myself Mahesh. I will be presenting the second case. She's a 21 years female. She's a known case of spondyloarthritis with involvement of axial, peripheral and enthesial involvement. She's been symptomatic since 5 years, and she also had this non-specific colitis. And with the initial therapy of conventional DMARDs with methotrexate and sulfasalin, she was doing fine, and she had a pregnancy conceived on this medication. And as she was already on the methotrexate, she was advised for this medical termination of pregnancy, and which was done. Following that, her medication were changed to adalimumab. On adalimumab, she had a successful pregnancy with a healthy baby. Following that, the patient had self-increased the dosing interval, and with that she had a worsening of her GI symptoms suggestive of active colitis, with the evidence in CT enterography showing the segmental bowel wall thickening along with post-contrast enhancement, which suggests this active colitis, and the flare was attributed to this delayed TNF inhibitor dosing, and again the dosing was standardized with the standard intervals.
So this is a case of spondyloarthritis spectrum. So we'll proceed with the questions because of lack of time. And how does the spondyloarthritis affect the pregnancy outcome? Varaprasad.
in spondyloarthropathy, generally what we learned is it doesn't affect much. The pregnancy doesn't affect much in SPAs, but there has been one observation, one study from Pune, where they observed that there could be a flare in pregnancy, especially around second trimester, and immediately postpartum, around the postpartum. So the arthritis flare. So is that, that's what
And how is the fertility rate? It will be normal?
Unless the patient is having her general condition is poor functional class, which is affecting her general health, I don't think it affects the fertility.
Yes, sir. So, and most of these patients will be taking NSAIDs during prior to the pregnancy. So, does that affect anything about fertility, or if the patient is suffering from severe pain, can we advise any NSAID during that pregnancy in SPA patients?
Theoretically, it can affect ovulation. Pregnancy, I don't think there is no safe NSAIDs, but in the early trimester before the 12th week, maybe once in a while patient may take any NSAID, but not after that. Acetaminophen is the only go-to drug for the patient. Anyone can add fetal medicines.
First and the second trimesters, for brief time when she has a pain, we can still use Brufen and indomethacin. We don't obviously use diclofenac. Naproxen can be used. Third trimester we don't, because of the theoretical risk of premature closure of ductus arteriosus. That's what our call is.
Ma'am, how long can we give for 2 or 3 days? If there is severe pain, patient comes with severe back pain or something, because we don't give steroids in spondyloarthritis and patient is not affordable for biologics, so can we give intermittent or any short course?
Yeah, we have seen women using for about 7 to 10 days and then stopping. Most of them are on acetaminophen, as doctor said, but about 7 to 10 days is that. And indomethacin we use because that is one drug we used to use earlier for polyhydramnios. First and second trimesters, I think it is. Basically, we start after the 12th week only.
12th week.
So there are some concerns that use of NSAIDs leading up to pregnancy can produce, risk of infertility, because the implantation failures happen because you need prostaglandins for implantation. So you try to avoid it if you are planning a pregnancy, and that is the only concern. Otherwise, fertility by itself is not affected. The other things like severe pain and emotional response to the pain, the fatigue, they can affect, the ability for natural conception because of other reasons. But there is something which is called ovulation syndrome, which happens with NSAIDs. I'm not sure whether it's just a theoretical word which is used. Overstimulated luteal thing.
That's what I read in the papers while preparing for this. Kameshwari, any idea? It is luteal phase deficiency is one associated if you use around the time of ovulation induction.
There's no strong evidence. So, Shravan, to you, would you suggest using steroids in place of NSAIDs? Say if it's a severe pain. For mild pain, we'll tell them paracetamol, something else. But
if it is severe pain, if I don't have any option, I may give some 5 mg or 7.5, maximum 10 mg steroid only for 4 to 5 days as a symptomatic therapy, not as a long term like we use in other CTDs. Does this axial disease activity improve or worsen during pregnancy? I think Vara sir has already answered it, and most of the time it increases during second trimester or third trimester. It increases due to physical strain, and the postpartum period we see highest risk of flares, and mostly around in 40 to 70% of cases, and mostly within the first 3 to 6 months of postpartum period. So what strategies will help to prevent these postpartum disease flares in spondyloarthritis group? Lisa ma'am.
Again, it's the same thing. You have to control the disease well. You have to be prepared for these flares. And how would you, it's logically that you have the disease under control. If it is like if the patient chose not to use therapy, because sulfasalazine also, when we say it's completely safe, some patients will say, and I would rather not have anything when I'm planning the pregnancy, and that you'd say, okay, go ahead and try and see how it works. Sulfasalazine, if they fall into trouble, then you restart the sulfasalazine, and it takes its own time to settle down. Uh, Biologics are, I think, the way to go now in preventing postpartum flares or even controlling the disease in SPA.
So how early we can start that biologic? If a patient, she delivered a week back, can we start, or is there any timeline that we should wait for biologics or something like that? If there is severe pain postpartum.
I think we can start unless you underwent a C-section where the wound is infected or anything. If the wound is healthy and it is healing, I think there is no need to wait. We can start straight away. And just continuing what Madam was saying. And skipping medication or stopping medication is the most common cause for most of the flares. Patients are keep taking their medication. There is no.
Tara ma'am, what NSAID is generally you prefer in postpartum pains, or if you get encounter like these patients who had postpartum severe back pain or something, immediate postpartum?
Tramadol is one, and Brufen we do advise in the postpartum period. These are the two drugs.
Can we use it for little longer time, ma'am? Unlike in pregnancy, we say 7 to 10 days. Can we use it for 1 or 2 weeks, something, or is there any contraindication to use NSAID?
Not really. You can give it for 2 weeks also. Ibuprofen can be given for 2 weeks. Tramadol, some people have their own feeling that because of the side effects, but most of them use ibuprofen.
Ibuprofen. And even we prefer NSAID rather than Tramadol because we want to control the inflammation along with the pain. So, ma'am, does this axial disease activity affect the mode of delivery, or is it become that cesarean delivery more common in ankylosing spondylitis?
It depends upon the stiffness, how much they have. And we do involve our physiotherapists because we have different birth positions. Even with rheumatoid arthritis, with disabilities, there are some women we deliver on all fours with and different birth positions. So, but majority, whatever few cases we had in that literature from Pune, 60% had cesarean sections because of the disabilities what they had. But we do involve our physiotherapy team because we have optimal birthing positions to birth these women. It's not the traditional upright we have to birth them.
So we encourage vaginal delivery if there is no contraindication,
yes,
or if there are no limitations.
Absolutely.
Yes, ma'am. So unless there is severe hip and advanced spinal stiffness, we prefer C-section, not due to other obstetric indication. So are there anesthetic challenges in these patients? Do you face in these patients with spondyloarthritis?
One of the lucky things we have is antenatally we involve the anesthetist and the physiotherapist if a woman has a disability. So we discuss about the regional analgesia, what we would like to give, epidural if it is possible, definitely, or single short spinal if it is a section. So they assess, they look at the spine and previous images if they had any, and then they go for a little higher block if they have to give. So it is not an absolute contraindication for a regional anesthesia.
Ma'am, one last question. What biologic do you prefer in your routine practice, or what you recommend, and till what period of antepartum you recommend to take the biologic, and when you again restart it?
If my patient is willing, I'll continue it throughout the pregnancy. I don't see a reason to stop it. By the common, adalimumab is the commonest we use because of the cost and ease of administration, just twice in a month. Others are much more expensive, and if they fail a TNF, then we are in trouble because we'll have to look at whether we want to give them secukinumab or not. Data is accumulating that they are not contraindicated. There are no signals in those who have been exposed to secukinumab. But as we discussed recently, we don't know the duration of exposure to secukinumab in these patients. So TNF inhibitors, and if one fails, maybe try another. But these are expensive and we'll continue them throughout. the baby may have to be protected for vaccinations.
Vaccinations has to be postponed up to 6 months. All the live
Live vaccines.
So we'll go to the next case.
Good afternoon. She is 26-year-old female, case of diffuse cutaneous systemic sclerosis, symptomatic for a duration of 4 years, with manifestations of Raynaud's, skin thickening, and early ILD, with FVC of 65%, and significant obstetric morbidity, including one early spontaneous abortion and MTP at 5 months due to fetal cardiac anomaly. She was initially treated with methotrexate. In September 24, she had increasing skin thickening on methotrexate, so changed to mycophenolate. In June 2025, she had arthritis flare, so methotrexate was added, and in view of persistent arthritis, leflunomide was also added. This year, February, azathioprine was added as she was planning for pregnancy, and in March 2026, she had early intrauterine pregnancy without having an adequate washout period for leflunomide. Despite detailed counseling regarding potential risks, she expressed a clear preference to continue the pregnancy.
So before going to this actual question, so if any patient comes like this who takes leflunomide or methotrexate or mycophenolate and who became accidental pregnancy and they want to continue the pregnancy, so with this drug, how much risk you are going to explain the patient, or will you ask them to terminate as a first option, or you will counsel them about the risk? So how will be the routine practice in it? Any drugs, sir, leflunomide, methotrexate, or MMF?
But obviously, methotrexate, leflunomide, and mycophenolate, they have been known to be teratogenic and they are contraindicated. But there are now reports like leflunomide when continued even in pregnancy, the outcomes were for the baby were also good. But here it is always a shared decision. We cannot be sure that patient will not have any problems. It always depends on how much risk the patient is willing to take. We will explain. Will be obviously explaining the risk of to the fetus with the medication. As in the morning we have listened, even with the careful scanning it more frequently and up to the last IFA scan, there is again 10% chance there could be some mental anomalies and nothing. So here there would be and there also will be a shared decision from the rheumatologist, from myself, the treating obstetrician, and the patient. So I will not say go for a MTP immediately. We'll discuss about it and then.
I think we need to hear this again. So the 10%. So what are the risks which can be missed? So you agree with the patient and continue the pregnancy, looking for phenotypic abnormalities. But what else can go wrong with a normal fetus and fetal growth?
In the second trimester, the structural evaluation can pick up the major cardiac defects, major CNS anomalies, limb defects. So all these are very common for all these three drugs. But the hearing defects, late onset ventriculomegaly, which can happen in the third trimester. So those kind of abnormalities which we can miss during the antenatal period if there is not a thorough scan in the third trimester, as well as the functional defects and the cortical malformation defects, which is very difficult to pick up on a routine scan if you are doing, which is a very quick scan in the third trimester. So these kind of effects may be missed, so it is very, a detailed counseling has to be done, and then we need to document everything and then go ahead with continuation of the pregnancy. And what is the traditional teaching as well as what we practice is all or none phenomenon. If the embryo is affected during the embryonic period, the fertilization period, if it is affected, it will show the structural manifestations. So most of the times it is all or none phenomenon, but even then also the functional aspects need to be followed up after birth. This has to be documented in all these pregnancies which are exposed to these highly teratogenic drugs.
Ma'am, we'll go to the question. So, when is pregnancy considered in case of diffuse systemic sclerosis, and what are maternal and fetal risk in these cases?
Yeah, I think you've said that in your slide there. But so when would I counsel my patient of systemic sclerosis that, okay, you can go ahead and plan, is when I have seen the trajectory of her disease for a few years. So if she has a patient who has recently developed, the diagnosis of systemic sclerosis, and then, then limited and diffuse does not matter, because in the next few months she may progress. And this progression can happen in the skin, so that what is limited today can become diffuse tomorrow. And it can happen in the lungs. So what was initially a mild basal, few crackles or a ILD can become a progressive ILD. So until I am sure, and third thing is the pulmonary arterial hypertension. So unless I am sure that these three things are stable, I would not ask the patient to conceive, because it's not just about the patient, it's about the child also. Because mortality is significant when there is a progressive pulmonary hypertension or progressive ILD, which is mirrored by the thickness of the skin, progression thickness of the skin.
So, if a pregnant woman who comes with 2 years of skin thickening, not much ILD and no PAH, and will you ask them to hold the pregnancy until 5 years or something like that, or we'll allow them? Because early we can't define.
You said she's pregnant. Then
no, not pregnant. If they ask for other preconceptional counseling, they came, can I become pregnant now? So, or should I
then
wait
I would
for
say
5
probably
years?
say this is the safest time. If it's already 2 years of disease and nothing is there, then I would say yes, please, this is the best time for you to conceive. I'm not sure if you would tell me whether the antibodies matter, the type of antibodies have a...
No, not antibodies. Some say that until 5 years, the 3 to 5 years, the risk of progression is there in the disease. So, should we go for very safest period, something after 5 years, or because in practice we allow them to go for pregnancy if she is stable?
Shall I ask something?
Yes,
it's like Raj Kiran saying 2 beta to glycoprotein low positive, 2 miscarriages, third pregnancy, do I still have to wait for one more abortion to do the antibodies? If we stick to your case scenario, she already had a congenital malformation in the heart and she terminated the pregnancy. Unfortunately, this is the same lady, despite the she washout period, she couldn't wait and she's pregnant again. So there is somewhere the counseling part, apart from what all you do and we do, there is something, the family structure, which is causing the problem. So what best we can deal with the scenario when the woman comes to us, we will deal with the scenario, because termination is definitely, we cannot, unless until she also wants to do it. So there is an entity embryotoxicity, there is a fetotoxicity. If she passes that embryotoxicity, she comes into the fetotoxicity where we have to monitor. So waiting for those antibodies and all, we may talk, but when you, the couple sits in front of you, we need to understand this particular woman is at a high risk for recurrence of the anomaly, also the disease activity, and also like first case who had a preterm birth at 28 weeks, the congenital heart block, she wants to plan another pregnancy, that means she will again have a preterm birth, the risk is there. So inherent obstetric risk apart from the rheumatic disease will always be there when we have to analyze a mother. That's where risk categorization, and every visit you see, you have to look at her with everything together and see how the woman is doing. That's what I...
So, does this anti-SCL70 positivity influence the pregnancy outcome, unlike Roe, which we discussed previously? So, anti-SCL70.
No strong signals for...
Yeah, it's a risk marker, but not a direct cause. So, and it also do not cross the placental barrier also. And what is the risk of ILD progression during a pregnancy in scleroderma case?
Again, the same thing what we were talking about. When on the isolated ILD, the whole disease goes as a process, and the first 2 years and then the first 4 to 5 years are the time period to look out in general. But if we know we have been seeing the patient for at least a couple of years, that patient had ILD and she's been maintaining normal pulmonary function tests, then I would call it is a stable ILD. And if the PFT for her it was showing mild restriction, so she can go ahead with the pregnancy. The effects of pregnancy, like it can decrease the ventilator function in the third trimester because of pushed up diaphragm. I think disease progression as such, it is not known that pregnancy will progress ILD in sclerodermas. As far as I know, you can add.
Yes, sir. It is unpredictable. That is what the literature says. Even it says only 20% there is risk of progression, but most of them, if it is stable ILD, they will be having a successful outcome in the pregnancy.
So the unpredictability is even in the non-pregnant scleroderma population.
No, yes, that's true. Sir, ma'am, what are the absolute contraindication in a scleroderma pregnancy? So pH, do you categorize anything like that, mild or severe, and anything value you want to give to the pH, or?
I mean, I'll just say what I do in my practice. In the morning, there was discussion about that there should be a right heart catheterization. The patient is on has pulmonary arterial hypertension, is on sildenafil, and now the echo shows that there is no pulmonary arterial hypertension. Is the pregnancy safe in this patient? So what happens is, very rightly, somebody in the audience said that you need a right heart catheterization because echo is very subjective, and especially when you're diagnosing moderate pulmonary arterial hypertension, then it may actually be a mild pulmonary arterial hypertension. At this point of time in that woman's course, you should withdraw the sildenafil if you find RHC is normal, and because though it is generally believed that pulmonary arterial hypertension is non-reversible, but we have enough examples in our experience where PAH in lupus has completely resolved once the severe disease activity has declined elsewhere, and there's a lot. I mean, the survival of patients with PAH has improved on drugs. But if the survival is simply because the patient is on very good anti-PAH therapy, then it is contraindicated. But if it has led to improvement, then a right heart cath, a withdrawal, again checking whether there will be a recurrence or not. Usually in scleroderma, there will always be a recurrence. I mean, it will be higher. But in disease like lupus, you may find that your PAH has resolved completely.
Can someone with NIHA class 1 or 2 on anti-PH medications can be cleared for pregnancy?
Okay, NIHA class 1 is a good, I think mild PAH, a stable mild PAH, and the patient is not requiring any
on medication, sir.
On medication, I'm not sure. I will ask a cardiologist advice on this. But in my practice, if patient is having is recovered completely and not on any anti-PH medications only, I would generally advise give a word from my side. Otherwise, I will take a cardiology opinion on this.
Ma'am, Tara ma'am, do you advise anything about this? Patient is on PH medications. If patient comes and asks, can we conceive?
Same. I will take the cardiologist advice. Maybe the mild. Yes, but we have referred to a higher center where there is a continuous monitoring with the obstetrician cardiologist, and it's difficult to take care because suddenly they can become high risk because the things what you have written over there. Unless you have a cardiologist in the team where you are working, I'm very scared of pulmonary arterial hypertension.
So class 1 or 2, it is a high risk. We'll allow them, but we have to be carefully monitoring them and we have to explain the risk.
Because it may worsen as the pregnancy progresses.
Yes.
That is a problem.
As well as the associated comorbidities like obesity, superimposed preeclampsia, all these things can add to worsening of the heart failure. So it's a very dicey situation.
Yes, yes. But cardiology group, when I see the literature, they say PH is absolute contraindication for pregnancy. They are not describing mild or severe, they are saying absolute.
We cannot give any medications if we want to give also. I think only sildenafil is one drug we can give.
And Tara ma'am, how does the pregnancy physiology affects the already involved cardiopulmonary system in the scleroderma?
Apart from the what you have put it here on the table, I'm always concerned for the woman as a whole with the comorbid conditions. disease activity, that particular scleroderma is one, and the fetal growth is one, and associated if she develops preeclampsia or she develops a severe, again, lung problem, they end up in a very premature deliveries. So as such, if you look at the systemic sclerosis, this is one condition, most of them whom we have helped with the interstitial lung disease ended up in severe fetal growth restriction and premature births.
So one last question regarding this case: what vasodilators are advised during pregnancy for Raynaud's or PAH?
I think nifedipine is the one we can give, and sildenafil, nothing else.
So nifedipine and endothelin receptor antagonists are contraindicated. So we can give nifedipine and sildenafil. So we'll close this session from rheumatology and we'll go for the next case. Thank you.
Good evening all. Myself Dr. Priya Sharma. Starting with the case, Mrs. B, 23 years old, homemaker, married for 4 years, non-consanguineous marriage, G3P1L0A1, spontaneous conception. In February 2020, at 17 years of age, she had shortness of breath insidious in onset for 6 months, and with bilateral lower limb claudication, she was evaluated at Nims Hospital. Her right upper limb blood pressure was 140 by 80 millimeters of mercury, and left upper limb blood pressure was 130 by 70 millimeters of mercury, and both lower limb blood pressures were normal. All the peripheral pulses were palpable. There was no bruit, no carotidynia. CVS and respiratory system examination was normal. After ultrasound KUB, right kidney was, it was given right kidney as small, and in renal angiogram there was severe stenosis of the right renal artery and left renal artery, as well as there was mild abdominal aortic stenosis. HB was 8.8 and iron studies were suggestive of iron deficiency anemia. So provisional diagnosis of Takayasu arthritis was made, and she was started on low dose steroid, and for hypertension clinidipine. And later on even methotrexate was added, and she was suggested MR aortogram after 3 months. But she defaulted for 4 months and then returned with escalating symptoms of occasional pain in legs and syncope. Her CRP was raised. On MR aortogram, there was involvement of the lower thoracic, upper abdominal aorta, and severe right renal artery stenosis, as well as involvement of the left renal artery, and the long segment of the supra and infrarenal abdominal aorta was also involved. This is suggestive of Takayasu arthritis type 5. And cardiologist opinion was taken. 2D echo was normal. In January 2022, angiography was done, which shows involvement of the aorta of the L1 to L4 long segment. 50 to 60% of the part of the aorta was stenosed. Also, there was involvement of the superficial femoral artery and both the renal arteries. So from cardiology, she was told about medical management, as this was not amenable for stenting. After the DTPA scan, which was done for her kidney function, left kidney function was normal. Right kidney function showed reduced cortical function and slow drainage. She had regular follow-up in cardiology and rheumatology department, and she continued steroids, methotrexate, clinidipine, and Minipres XL. Then in January 2023, there was an increase in ESR and CRP, for which MR aortogram was repeated, and which showed, an FDG PET showed active disease in aortic arch, for which MMF was added in view of active vasculitis. Then after, when her disease was in remission, she was switched to azathioprine, and her treatment was azathioprine, Vizolon, Minipres, and Prazosin. They were continued, and she was cleared for pregnancy. Coming to obstetric history, in 2023 she had one missed miscarriage of 8 weeks, for which SCRPC was done. Then in 2025, in May, She had accelerated hypertension and early onset FGR at 28 weeks, for which compassionate induction was done, and she birthed the baby boy 700 gram. Placental histopathology indicated maternal vascular malperfusion with decidual arteriopathy and fibrinoid necrosis. This was secondary to autoimmune etiology, and postnatally she received 3 antihypertensive. Coming to the present pregnancy, so interconception period is 4 months, and she booked at Fernandez Hospital at 7 weeks, 3 days. She was counseled about 50 to 60% recurrence risk of her preeclampsia, and also 40% risk of the preterm birth risk. She was started on aspirin 150 mg and continued rheumatology medications, and for secondary hypertension she was switched to tablet labetalol 100 mg twice daily and tablet Nicardia retard 10 mg twice daily. Fetal monitoring, her nuchal scan was normal. EFTS showed screen positivity for preeclampsia. Anomaly scan showed no obvious anomalies. Fetal well-being scan at 24 weeks showed stage 1 FGR with MCA redistribution and increase in uterine artery resistance, for which a scan was repeated after 2 weeks, and it showed 4th centile baby with absent end diastolic flow. And Doppler changes. This is a basic ANC investigation, which is normal. ECG 2D echo normal. Then she was admitted with accelerated hypertension, and she received HTU care. Multidisciplinary team was involved. She received antihypertensives. Her P profile was normal except urine PCR was 0.3. She received injection Mexilf. And then induction, she was offered compassionate induction in view of accelerated hypertension, early onset FGR and Doppler changes. Birth vaginally 780 gram baby boy. Apgar was 3, 5 and 7. Baby was shifted to NICU. She received intrapartum stress dose of steroid, and couple declined placental histopathology. Her postnatal period was uneventful. And baby course in NICU in first week of stay, baby had respiratory distress, for which received 2 doses of surfactant. In second week developed pulmonary hypertension and was started on inhalational nitric oxide. Presently baby is on bubble CPAP, and baby weight is 920 grams.
So this was a case where actually a lot of things happened. She conceived in very short period. So we just wanted, and we had almost given up on the baby, but the baby is actually a fighter and is currently stable. So we wanted few inputs here. That's why we are discussing this case. So I would like to know what are the maternal and fetal risks associated with pregnancy in such cases in Takayasu arthritis. Tara ma'am, what are we looking at? And
I think it's more than the theory of the Takayasu arthritis. I think, Lisa, you have to take this question, because the dilemma what we had is she was hardly 21 years, 22 years, I think. 17 years she got detected, and it is stage 4. Both the kidneys are not functioning well. She has accelerated hypertension. So first time we actually told her it's better that, we bring everything under control. We will induce you. You can have a vaginal birth and then come back later. So second time the dilemma is she comes within 4 months. And the change of antihypertensive drugs, I'm not aware, will it help her, or whether we change clinidipine for some particular reason. And here we did not give antenatal corticosteroid. There is so much of ethical, you go through so much, like this young girl with so much of hypertension requiring 4 drugs. And the same scenario like first time, where we have actually sacrificed the baby. This time we said no fetal monitoring, no CTGs, no antepartum corticosteroids, because we know how much she can also afford to. Didn't want to do a cesarean section. She birthed normally, and our neonatologists were totally zapped when the baby came out, and they wanted everything to be done for the baby this time. So there are two issues here. You are morally responsible. You have not monitored this baby and given a baby where she didn't receive antepartum corticosteroid. She did not receive magnesium sulfate we give for the neuroprotection. Right now the baby is in NICU. She can tell the course. So what are we? Where are we today? We counsel, we do it, but they come back. I don't know whether I would have given the steroids, I would have done magnesium sulfate, done the section and given the baby to NICU in much better way than they received. And the antihypertensive management, this lady, how is she going to be in future with this Takayasu arthritis?
So I'll just take the easier question, which is also difficult, that how will she be in the next few years? Right? There is a window where probably we think we can intervene. That is, she has an active progressive disease, and we think that by giving her the steroids and by giving her the either methotrexate or MMF, we might be able to achieve better control of the disease and hence better control of the hypertension, because though she has a pretty advanced renal artery stenosis bilaterally, some of the hypertension can come from the other parts of the aorta which are also active. So maybe, little bit of hypertension control can be achieved. And going forward, at some point of time, we will have to do, sampling of one or both renal arteries to see which kidney you should be sacrificing to control the hypertension. It's going to be a very difficult journey. There are no easy answers. Regarding the second part which you said, I think those are dilemmas which the safest thing is to write down on a paper and then stick to it. But when you deviate from the plan, then I think it's okay that you handled a difficult problem and then you tell us, what could have been better, you thought.
Because my resident suddenly calls me in the night, Tara ma'am, we have not given the steroid antepartum, even though you have written off the baby. It's not easy not to give steroid, not to give magnesium sulfate. I'm doing everything. What if I'm not going to section her? I'm for sure that I'm not going to section this lady. But the first time it was an easy decision. I thought, induce her, vaginal birth, she'll get the disease under control. But within 4 months she came back. Now this is like we have written to the foundation. No way we can sit on this baby. We'll do our best, and this baby has to, whatever best method we can give it in the neonatal. And now the baby is 1 month old?
Yes. Baby is 4 weeks old. Initially, baby required intubation. Probably like giving steroids would have made RDS better. The course would have been better, but pulmonary hemorrhage, probably due to that immaturity baby had, and then secondary pulmonary hypertension which baby developed in second week. These probably could have been better.
If I give a steroid, it comes the NST. If I do an NST, it comes the decelerations. If I get a deceleration, I have to do a section. If I have to do a section, my residents every day monitoring this mother, they had so many difficult questions in their minds. Why is Dr. Tara not allowing us anything to give steroid, anything to give magnesium sulfate? Why are you waiting for? But if I have to start with the steroid, we have to intensely monitor the fetus. We cannot just cut course and I say, I just give 2 doses of steroid. We have to give steroid, we have to do an NST, we have to give magnesium sulfate for the neuroprotection. It doesn't stop. Once you start, I'm thinking I'm going for aggressive management. These are the dilemmas which we face every day in and out in our practice.
Yes, ma'am. But sometimes, like if the baby probably was a fighter, so it didn't end up in stillbirth or IFT, but if at all they want aggressive management, at any point we have to continue.
Yeah, sorry, but
probably
this was the situation where we have to hand over.
Not for the mode of delivery, but at least if at all we would have given steroid for that sake.
So how is the baby today?
Baby is good, ma'am. Baby had fungal sepsis because it is an ELBW baby, but otherwise is hemodynamically stable, gaining weight on CPAP.
So neurosonography is fine, echo
there
is
is no
fine.
significant IV, no.
Thank you.
So this is one thing which was wanting to be discussed. Should low-dose aspirin be routinely used to prevent placental insufficiency? Not only pertaining to this case, but in general in autoimmune rheumatic diseases. So the thing is, in arterial diseases, it would be preferred to be given ecosprin. Otherwise, I would like Dr. Sarita to answer what do we follow as per the fetal medicine protocol.
Most of the times when they come to us for the booking visit itself, they'll be on ecosprin, the low dose 75 milligrams. If they are not on ecosprin, what we do is at first trimester NT scan, we follow the Fetal Medicine Foundation algorithm, which is as per the ASPE trial recommended by the FIGO, we follow the combined risk model approach where we take into consideration the maternal history and demography, uh, maternal biophysical profile, where we include the weight, height, BMI, as well as the uterine artery Doppler, mean arterial pressure, and then we also will include the maternal serum biochemistry. So combining all these factors, we put it into the model and then we get the risk calculation. So the final risk, if it is more than 1 in 100, we put this mother on 150 milligrams cecosporin. Before, this has to be started before 16 weeks of gestation to have the reduction in the risk of preterm preeclampsia, especially in this connective tissue disorder mothers, which reduces the risk to 70 to 80%.
Yes, as rightly said, this is the fetal medicine algorithm which is followed wherever available. If it's not available, then we go by the NICE and ACOG guidelines of history-based screening. So this was already discussed, the factors predicting adverse outcomes in Takayasu arthritis, active diseases, conception and other associated autoimmune diseases, renal artery involvement. So preferred mode of birth for mothers with large vessel vasculitis, Tarana?
Most of them with accelerated hypertension and uncontrolled hypertension associated growth restriction, they end up in cesarean section. Our own data showed 60% had C-sections. I wanted to take a call on this antihypertensives, Lisa. So is there wisdom in changing clinidipine to labetalol in this particular scenario?
I mean, labetalol is considered to be the drug of choice, and so, but clinidipine is also not contraindicated. So if you have good blood pressure control, it's fine. What is important is that the blood pressure should remain controlled.
This lady was changed from clinidipine to labetalol here when she came for a check, and it may be coincidental or a pregnancy, weeks of gestation. She had very accelerated hypertension after the change of medication, and she required 4 antihypertensive drugs. So my worry as well as a concern is, do I change the antihypertensive clinidipine when it is well under control?
No, I would not change. If it is compatible with pregnancy, safety and all, I don't think there is a reason to change. Because that's what we say when we switch a patient from MMF to azathioprine. We also say that you need to wait for 3 to 6 months to see if the azathioprine is able to control your disease as well as MMF did. So that waiting period for switch and seeing whether the second drug is effective is also part of the planning. So if you don't rock a steady boat.
For this woman, ma'am, because she is not amenable for stenting, is there any other option for in future? Because I don't know, she may come back with a pregnancy again.
I don't think we should ask for an intrauterine contraceptive device. She's hardly 22-year-old. No, what is her plan? Like, how would you like to monitor her now? Stage 4 Takayasu, both kidneys are not functioning.
Dr. Funny, would you like to step in here? Because I think management of bilateral renal artery stenosis advanced, where the percutaneous procedures have already been said that we cannot do it. It has to be a aortorenal bypass in a very quiescent stage of disease. So that would be an open surgery. I mean, not a procedure, not a percutaneous intervention.
No medications are available?
To reverse damage, no.
To further stop progress?
So we will continue the immunomodulator therapy till the acute phase reactants stabilize. But they will not change the course of the renal artery stenosis. 80% stenosis and near total occlusion on the other side. Funny, any other?
I think when there's a bilateral renal artery stenosis to this degree and recurrent preeclampsias in the last pregnancy and this pregnancy, I think these cases, I think if there is almost a damage, if it is more than 80%, so they can't stunt it. And even if people do a DTPS scan to see any functional kidney remaining, so if it is remaining, maybe that's it. If it is less than 70%, they will try to stunt it. Otherwise, I think nothing can be offered to these cases. And regarding the progression of disease in Takayasu with pregnancy, so there are some reports to say over time they may flare up, but again the reports are still less to say. There is nothing to reverse damage, but only to reverse inflammation, which I think we will assess postpartum, because we can't do anything at that point other than controlling hypertension.
Thank you, sir.
Is there a mortality with accelerated hypertension over the next 3 to 6 months because still she's requiring 3 antihypertensives?
Absolutely. Every day we have a patient in the ICU with accelerated hypertension, pulmonary edema, and back and forth, and intubated, extubated, then reintubated. So these are very high risk patients.
So due to lack of time, we would end the panel with this case. Thank you to all the panelists for giving us their time and input.
Thank you, all of you also, for bringing such beautiful cases and for grilling us so hard.
Thank you.
Thank you. After that exhaustive session, finally, to give us a glimpse into the future of collaborative research in this field, we have a session on what is cooking in mod research. May I invite Dr. Vijay Kumar Kotala, Professor, Clinical Pharmacology and Therapeutics of Nims, to kindly chair this session.
May I also add that he is the nodal officer for our multidisciplinary research unit. So the best person to chair the session.
Thank you, ma'am. So, good afternoon, everyone. So, after hectic deliberations since morning, we came to a final presentation by none other than Organ Secretary, Dr. Stella Madhuri. So, I am pleased to invite her to present a topic on what is cooking in mod research. Stella Madhuri is a faculty at Nims, seated as a DM also from Nims. So interest is rheumatoid rheumatology, psoriatic arthritis, and ultrasound in rheumatology. So I request Madhavi go to presentation.
Thank you, sir. It is such a privilege to be introduced by you. So I'll really stick to time. I'll be quick, and let's see what is actually cooking in mod research. As we come towards the end of the program, I think I'm more at ease now and I'm less stressed. So yeah. So these are the disclosures and my acknowledgements. So this is the brief outline of my talk. So can we really do research in pregnancy? Yes, we may not be able to do RCTs, but the impact trial is proving us wrong. But we can do research at our level also. There is an urgent need for collaborative pregnancy registries. So we collect the data, we do a joint analysis, and we come up with evidence-based guidelines. This is what the ULAR has been doing over the last few years. So the world has seen a decade of rapid expansion. Right in 2004, US and Canada, they have started their pregnancy registries, but there has been a lull period for almost 10 years, and then the Europe picked up, and there were multiple pregnancy registries across Europe. But could they come up with a collaborative research? And so what they looked at is the data that was being collected was disparate, and there were different enrollment periods across the pregnancy registries, and the temporal limit of enrollment varied, and the temporal limit of follow-up of the child was different. In fact, few of the registries did not have any follow-up for the child. But there was a common outcome across all these registries that the live birth rate was as high as 87 to 98%. So it is actually reassuring that our patients can have a safe pregnancy if we come to a common stage, have a good dialogue, and then follow up their pregnancies. But what happened was it was difficult collaborating the registries because there were varying healthcare systems, different enrollment windows, and different disease activity measures which were used across the systems. Then came the ULAR network of these pregnancy registries, and they saw the methodological differences, and they identified the structural data discrepancies. Then they formed a ULAR task force, and then they came up with simple data sets that can be collected by physicians, rheumatologists, obstetricians, which includes maternal information, basic information, the data regarding the pregnancy, neonatal outcomes, that is only up to 28 days, and then the treatment, This is 12 months, just 12 months prior to conception, and what was the immunomodulator therapy that the patient received during pregnancy and postpartum, and use of other treatments during treatment. So these were the core data sets that were mandatory according to the EULA task force for pregnancy registries. Now, let's go to what's cooking at Nims. So, in the other talk, Dr. Sudarshan pointed out there was a PREVA registry. So this is pregnancy registry for Indian women with autoimmune diseases. This is actually just a single center prospective observational registry at Nims, which is a brainchild of Dr. Lisa Rajshekar and Dr. Amrita Gopalan. And I am trying to continue this PREVA registry. So we are trying to stick to the EULA core data set, which is mandatory, but we have been over zealous, and we have tried to keep a follow-up up to 5 years, and including the developmental milestones and autism screening also. So these were the introductory results from the PREVA registry, which was presented at a national rheumatology conference. And this was displayed in October 2024, and till then almost 66 pregnancies were recorded, of which 33 were completed. And they have observed that live birth rate was as high as 85%. There was 1 maternal death and 4 had lupus flares. So the enrollment in PREVA registry till 18th April 2026 is 169, of which lupus tops the chart, followed by APS and then TAC, Takaisu arteritis. And of which the preconceptional enrollment has actually increased over the last 2 years. We are better able to identify those patients who want to conceive in the next 1 year, and then we are able to counsel them and then keep a follow-up. And then we had 9 patients who are actually planning for ART or conceived by ART. But the problems that we face is there is a lack of electronic medical record, and obviously the clinical workflow constraints. There is no dedicated research person who can collect all the data and have a longitudinal follow-up. And there are referral gaps and loss to follow-ups. And then as a part of the same PREVA registry, we went ahead and tried to look at the maternal serum placental factors, that is serum FLT1 and platelet growth factor, the ratio, whether this would predict adverse pregnancy outcomes in women with SLE and APS. There's a lot of data in non-lupus or non-AIRD patients for prediction of preeclampsia, but what about in our lupus patients? This is in fact funded by the multidisciplinary unit at Nims. And there was a multicentric 2-point analysis of the same serum FLT1 and platelet growth factor. The idea was conceived, but it couldn't be funded by the ICMR. So we have to see whether we can take it forward. So a total of 45 patients have been enrolled to date, and the full-fledged results are awaited. So yes, we do collect data, but what do we do? Sit and analyze? No, if it is properly collected and if we are able to apply some machine learning algorithms, we are able to come up with some set of baseline variables which can actually predict adverse pregnancy outcomes in a lupus patient or APS patients. A set of variables like a combination of LAC, platelet count, and ACLs, these are able to predict whether it's a low-risk pregnancy or a high-risk pregnancy. And researchers across the world have tried incorporating various machine learning algorithms. And they've, in few studies, the area under curve has gone up to almost 0.917. So that is at Nims. Then what's cooking at the national level? At the national level, there are multiple single center studies which are done by obstetricians and the rheumatologists as well. This is one such study which was done at JIPMER. And again, they have reiterated the fact that lupus nephritis and hypertensive disorders of pregnancy are independent drivers of perinatal loss, and emphasize the point of the protective role of hydroxychloroquine. And this is from the SLE Special Interest Group of IRA, done under the guidance of Professor Amita Agarwal, fertility and pregnancy outcomes in Indian women with SLE. And as a part of the cross-sectional arm, close to 1,050 SLE patients have been recruited, and the full results are awaited. So coming to the reproductive rheumatology SIG, this was formed in 2022, led by Dr. Vinod Ravindran, and it was started with 40 members and now expanded to 100 members. And as we know, Dr. Madhuri HR and Dr. Sunita are active members of this rheumatology reproductive SIG group. And multiple studies have been done by them, of which I like this study, which is really interesting. the knowledge, attitude and practices of Indian rheumatologists regarding reproductive rheumatology. And they have seen that we are familiar with the ACR, EULAR, BSR guidelines, but the FDA labeling of the drugs, maybe we are not really confident, and still 18% of the patients, 18% of the respondents labeled the pregnancy safe medications as pregnancy and lactation safe medications as incompatible. And they have observed that 80% of rheumatologists face conflicts with other specialties regarding the drug safety, and 77 patients of the patients were told that they can never conceive. So, and they have also seen that we are highly confident in managing the routine pregnancies, but we have a low confidence in looking at the oocyte preservation and assisted reproductive techniques. Maybe after this CME, we should do a post CME cap. And then another study which is on RA, maternal and fetal outcomes in women with RA, a multicentric observational study, and close to 66 patients have been enrolled to date. So these are the editorials written by the SIG. And last but not the least, we are actually going to kickstart the placental histopathology study under the guidance of Dr. Shefali Sharma. The main institute is PGI Chandigarh, and it is supposed to be a 3 to 5 year duration study, multicentric study, and a prospective observational study. So as Dr. Fani sir and Dr. Sunita pointed out, that placental pathomechanisms are far beyond what we know, simple inflammation or thrombosis, and it is really essential to understand this black box, what is happening at the histopathological, cellular and molecular level. So we are just beginning with the histopathological studies. So multiple centers across India have been included, and these are the aims and objectives, and we are actually awaiting the ethics approval at Nims and Fernandez Hospital to start the study, probably by May 2026. Ultimately, what's cooking at the global level? There has been a discussion about this fetal heart rate monitoring at home. There are controversial answers, I understand, but there were two studies, and I would like to quote this study which was published in arthritis rheumatology in 2024 called the stop block study. What they did was, do the titers of the Rho antibodies matter? Yes, they do matter. The second thing is, there is fetal heart rate monitoring importance, but this heart rate monitoring is conveyed to the pediatric cardiologist within 12 hours, and then they ask the patient to come back for a diagnostic echo. And then they show that those who come back within 12 hours, they're able to reverse the second degree heart block. So it is not just fetal heart rate monitoring. If the mother perceives that the rhythm is abnormal, the rate is abnormal, she reports back to the treating physician or the obstetrician. And then, as quoted in the previous talk, this is a much awaited study, the Hypatia protocol, the use of hydroxychloroquine to improve pregnancy outcomes in women with APS. And these are the potential areas of research where we can actually do meaningful research only by collaboration. Thank you so much.
Thank you, Madhi, for your brief but very informative presentation, especially on the registry. Very much interested. I think in future, definitely, if you have a multicentric collaboration with the funding from SMR, it can expand cancer registry like that. So wishing for that. And also regarding the placental biology, I think a lot of future is there. Many people are focusing on especially inflammation and immunology aspects of placental biology.
Yes.
That also in one context very better future. Now the house is open for any questions or suggestions, please. I think Fernandez is one of the main contributor. I think can have a collaboration with them. History also may be useful.
Yes, sir. We are actually at the final step. We should formulate an MOU and then we are good to go. Hopefully, yes, by 1 month, by May 26th end, we should be able to do it.
So I think if there are no questions, I close the session.
Thank you.
Thank you for giving the opportunity. Really, it's a very live opening for me to learn many things today's presentations, because first time I'm presenting this type of area very new to me, and I learned a lot. Thank you very much.
Thank you, sir, for actually you come right in the morning and stayed till the end. Thank you so much. I would now like to call upon Dr. Lisa Rashekar ma'am to formally close the session and give her closing remarks.
Thanks for staying till the end. To a lot of people, Sunita, Madhuri, Madhuri again. I think we all will join our hands together for a round of applause for the dynamic organizing secretary of this conference, Dr. Madhuri. She's been like a woman possessed. Once she thought of this conference, there was nothing else occupying her mind. And thank you, Dr. Tara, for saying yes at such short notice. So we've actually started this whole thing maybe 10 to 12 weeks ago, and I've forever felt that that's too short a time to hold a conference. But as I said, Madhuri would not let go. And every time she would see me, there would be a new question in her mind, a new way of doing things. And so we did experiment a lot with the program. We learned a lot of things in the morning, especially how we can do a lot of things better, how we need to do a lot of things. As Dr. Gutala said, find that they're sitting there, let's start it. So Dr. Madhuri and they also have started the journey. So much is happening. And I've been to a lot of, many times to conferences at the American College of Rheumatology, where we have small focus group meetings on myositis. And even there, you see that there are 5 or 6 groups doing excellent work in different areas of myositis. And then they realize that the resources are limited, because that same patient can't go into a registry, then into an interventional trial, then into a trial of how the pregnancy is succeeding. So they are talking about how you can have combined major collaborative planning right at the beginning, and then it becomes smoother because a lot of information, good evidence-based information comes out, and it's so much easier for everybody to share resources. So we're going to take this journey forward, starting with this 3rd step today, and we will definitely reach out to you with the 4th edition. But before with the 4th edition, we'll reach out to you with a feedback form. Please do be extremely critical in what you say to us, because that will help us to define our programs better. And we are also planning to make a template. Dr. Fani said that he would do it today. So template of what is the minimum information which should be shared between rheumatologists and obstetricians on an individual patient. So when I refer a patient to an obstetrician, it may be a simple problem, or it may be as complex as this Takayasu arthritis. So, but how much minimum data I have to write, and it's the language in which I should write it, so that if I say the SLEDAI is 4, what does an obstetrician understand? Maybe Fernandez obstetricians will understand, but what will an obstetrician in the tier 2 city understand? But that is where most of the care is happening. So I think it is important that we develop simple templates so that we don't have the cognitive load during a busy OPD. What should I write? Should I write now? Should I just say it to the patient? We know half the things will get lost in translation, but that's not my problem. I said everything. I documented everything. But I think there are many, many things which we can take forward. Thank you all very much for being here. Dr. Rajkiran, Dr. Gupta, thank you for coming, staying, encouraging. And that's why we made the dish at the end, what's cooking in research, because we look forward to enormous support from the Indian Rheumatology Association. Thank you very much. Thank you for the residents, for the sponsors. I don't know, residents are transforming into faculty, and the residents today are looking wiser than us. Thank you all very much for going beyond your brief to be here. Thank you to Hetero for supporting this at short notice, and they are giving us ideas for the next one, how we could do better. We will definitely take it better. Thank you very much. And please do join us for the cup of tea and samosa before you hit the road again.